Check one. Hello. 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 Check. Check one, two, three. Hello, Mike. Check. Check one, two. Hello. 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 हाँ 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 अभी बंद किया. अभी आऊंगा. सप्लाई का इधर का नहीं है. इधर नहीं है. मेरा पेन ड्राइव. हाँ. अरे यार मेरा पेन ड्राइव दिया ना. अरे यार मैं पेन. अरे मैं अभी पेन ड्राइव नहीं. मेरा दिमाग. हाँ. नहीं मेरे पास है नहीं ना. अरे नंदू माइक चेक करो. हेलो. बोलो ना.
Hello, 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 hello. Check. Hello, hello, hello. Check one. Hey, hello, 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 hello.
Check one, two. Check. Tick.
check, check. Hello, hello, hello. Check one. Hello, 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 hello. Check. Hello, hello, hello. Check one. Check. Hello, hello, hello. Check. Hello, hello, hello. Check, check. Hello. Hello. Check. Check. Hello. Hello. Hello.
Audible? Good morning, ladies and gentlemen. On behalf of the organizing team of 56th IOC Pune, I would like to extend a hearty welcome to each and every one of you. We would like to extend a hearty welcome to the President, Indian Orthodontic Society, Dr. Shri Krishna Chalasani, Secretary, Indian Orthodontic Society, Dr. Shri Devi Padmanabhan, President, World Federation of Orthodontics, Dr. Nikhilesh Ved, all our dignitaries, foreign speakers, President-elect Dr. Balwinder Singh, all my teachers, seniors, and dear friends. We start the proceedings of the day with the digital lighting of the lamp. I would request each and every one of you to please stand for 10 minutes, 10 seconds. Thank you. Now I would request President Indian Orthodontic Society to please come and declare the meeting open.
Namaste to all. Very good morning, dear friends, delegates, speakers from all around the globe, and postgraduates, everybody. After a long gap of 3 years, we are going to meet physically. The warmness of Indian traditions, hugging each other, giving, recognizing each other, very much noticeable since yesterday. And I won't take much time. And the speaker, today's speaker, Dr. Jonathan, sir, is there ready. And welcome to one and all for the 56th IOC. Best wishes to the organizers. Thank you.
On behalf of the 56th IOC Scientific Committee, I would like to start this session by inviting our chairpersons for the day, Dr. Arvind Kumar S., Dean, Professor and Head, Savita Dental College, Dr. Shailesh Sanava, sir, HOD, Professor and HOD, Terna Dental College, Mumbai. Sir, I request you to please invite our first speaker for the session, Dr. P. Janardhanam, sir.
Very good morning. Dr. P. Janardhan has graduated in the year 1983 and done his MDS in the year 1987 from Government Dental College, Chennai. He's got a clinical experience of 35 years as an orthodontist. He was a faculty member in the Department of Orthodontics, Meenakshi Ammal Dental College, Chennai, for a period of 16 years. He has been instrumental in conducting conferences and was the founder member as well as the treasurer of the Madras Orthodontic Study Group. He has participated in various clinical courses conducted in India and abroad, and is also the associate editor of the prestigious JIOS. He has been an ardent clinician throughout the tenure and has shown immense interest in newer concepts and changing trends in clinical orthodontics. His major area of concentration is currently on MBT mechanics and newer clinical innovations in surgical orthodontics, which has made day-to-day practice easier with greater predictability and consistent results. He has presented papers and guest lectures in local, state, national, international, and specialty conferences, and has been conducting advanced PA courses and surgical modules. He was also the past president of the Madras branch of the Indian Dental Association. He has conducted a number of webinars during the COVID lockdown period, which was well appreciated. With this, I hand over to Dr. Janardhan, sir.
Hello. Am I audible? Okay. Thank you for the kind words, Dr. Shailesh Shenava. Respected chairpersons of this scientific session, senior colleagues in this profession, fellow orthodontists and students, a very good morning to all of you. And in the beginning, when they gave me the first slot, I thought I'll be talking to empty chairs, but I'm glad that some people are there in the auditorium. And today, whenever we're there, the only talk is about aligners, TADs, and the most advanced way of treating patients. But we have to understand, we live in India. The bulk of the patients are treated with conventional fixed appliances. And pressure was passed out, it gets between 10,000 to 15,000. You have rupees. So if you convert it into any other currency, you will understand what he's being paid. And this topic is purely on conventional mechanics. And I'm going to show you where I went wrong or where I did right, what did I do, and those kind of things. Okay, the most common extractions we do in orthodontics will be the first premolars. Now, this girl came to this thing and she wanted something to be done. She was not happy with her face. She felt her teeth were protuberant and she was very psychologically affected by this. Her parents didn't want to do anything, but when you see her dentition, there is something wrong, but there's nothing too much wrong about it, okay? So we just see here, she's a very prolific brusher. Can you see the amount of dehiscence you have near all the teeth around? So she's a pure class 1 case, minimal overbite. But what was the problem was there is a lot of arch length deficiency in both the upper and lower. The CEF, the OPG. Today, if you have to treat, one other option would have been to extract all the eighths, then en masse retract the whole dentition, both the upper and lower dentition. It could have been done. But how many of us can afford to do that? Now, I'm just going to skip part of this. Is what is the most important thing here. There is a huge proclination and forward placement of but her profile was not too bad. Okay, you couldn't afford the upper lip to fall back too much. So we extracted all the fours. The one thing, if there are any students here, I just want you all to understand, the movement to force ratio is what determines the kind of tooth movement that you get. We'll leave the burstone way of doing it, but we'll stick to the profit way of doing it. It's easier. So it is movement of a couple by movement of a force. What is movement of a force? If I do an active tie back, or if I use a looped archwire and pull it, the movement that is created because you are applying the force away from the CR is what gives you the movement of a force. What is movement of a couple? The inbuilt torque in the system and the torque that you put into your wire. And when you put it into the slot, that's when you get the movement of a couple. Always the movement of a couple is much larger, movement of a force is much larger than that of a movement of a couple. But as the time goes on, the movement of force keeps coming down, and then it comes to equal. That's when you get translation. And if you wait for a little while longer, then you get a little bit of root movement also. So you need to keep it. So how do I control my moment of force ratio? Basically by one thing is reducing the moment of a force. Second is giving longer spans for the retraction. This is how the torque is expressed. So we went ahead, we strapped her up, and after some time we picked up the 7s also, and then we started retraction on posted archways. So as we went on, we came towards the end of the retraction. We have, if you notice here, we have lost a little bit of anchorage here. This should have been somewhere here. This side also I've lost very minimal anchorage. So after this, we always take the check X-rays. When you take the check X-rays, fairly decent bonding because you have got fairly good parallelism of the roots. And then we went for settling. This is not the way I usually do my settling. I'll show you in another case what I do. And then we finished her like this. Now, if you see here, midlines are coincidence. You have a good socking in, and this 7 reason will settle when you put the wraparound retainer. And good parallelism of the roots. Now, if you notice here, my upper one TNA is still fairly proclined, but I need to keep that because I need to support the upper lip. And the retainers, okay, this is how she looked at the end of the treatment. And if you go and compare to her, now she was happy with the face. You can see the difference in the eyes itself. They get one particular look in their eyes when they start looking good. Sorry. Now she is very happy with the smile. Notice we have not extruded the upper anteriors too much. At the same time, we have not allowed the upper lip to fall back too much. And the occlusion is good. And we finished her like this. Sorry. Can you just have some water, please? Just open it. So this is the other kind of extreme case that we have. You see these lips? They are very thick. Always remember, as a student or as a young practitioner, the upper lip, when it's thick, doesn't fall back. You will find that it doesn't fall back that easily. Now, this is what another thing that I want you all to notice, because when you see here, this premolar cusp should be in this embrasure. Already it's a 2 millimeter class 2 and maybe about 2.5 millimeter, even though the molar shows like class 1. To me, it's a 2.5 class 2 on the other side. When you have a thin lip, it's different. When you have a thick lip, it's very, very different. So we started with extraction of all the premolars, and we used micro. In fact, this was the first case in Meenakshi where we did a micro implant, and it was, we had a learning curve to go. I did some mistakes with you, and I'll show you also. When you have minimal overbite like this, you have to be very, very careful. Well, the mistake that I did is the implant is much higher on this thing. So it should have been the other way. Either it should have been parallel or this should have been higher. The vector of force should have been like this. So, but we still went ahead with the retraction. Can you see that we have created a mild open bite, then used a little bit of vertical elastics and we were able to get back the vertical control, and then did a little bit of settling, and this is how we finished. Nice occlusion, both in the midline and the canines and the molars. A nice thing, he had a deficient chin to start with, and the deficient chin is there. We've got slight increase in the vertical here. The only thing you can think of is doing an genioplasty at the end of his growth phase. This is a case I show very often in all my talks, because I don't know why I did this treatment. Today I would not do it. Maybe I was much younger that time. If you notice here, these are two premolars. You cannot say they are premolars. I don't know what tooth they are, but they were there. So there's no way you can get a good occlusion with this tooth. So today, if I'm going to treat this, I would have treated non-extraction, use part of the spade, put 2 implants, and replace the 2 premolars. But those days was different. This was somewhere in 90s or early 2000s. Now, the basic thing that you get between a 5 extraction and a 4 extraction is, in a 4 extraction, the 4 and 6 don't look so great together. But when the 4 and 6 come together, it looks nice. But in the lower jaw, always remember, you get a very good, very, very poor contact point and leading to food impaction. I'll show you as we go along with the finish. So the main thing that you should all remember when you're doing a second premolar extraction is the tooth adjacent to the extraction site is not the canine like in a first premolar extraction, because there is an inbuilt mesial tip in the canine which gives you the counter movement to prevent tipping, and you get translation of the unit. But when you extract a 5, the 4 has got a 0-degree tip. So there is no inbuilt tip in the first premolar, no counter movement to prevent the tipping, and there is increased time required for root paralleling. So what we do is, this is slightly exaggerated here in a typhodon just for educational purpose. So you incorporate a little bit of mesial tip into your premolar, and when you do that, you end up getting a little bit of root movement ahead of the crown movement, thereby you get more parallelism. And generally in a 5 extraction case, you want some molar protraction also. So it puts these teeth in the form of a stationary anchorage, and then it goes. So we extracted all the premolars. I don't know how it finished like this, but it did. We didn't dish in a profile also, and we got a good occlusion at the end of the treatment. Okay, this is how it is. Just another case on 5 extractions. Any PG, when they're coming for presentation, if they see a premolar like this, they want the 5s extracted. Otherwise, they have to spend a countless amount of appointments trying to rotate this premolar. So, but then the profile was also ideal for the 5 extraction. But when you do a 5 extraction, always be very careful of the vertical. So We went ahead, strapped up. We started with the 7s also. And then we started retracting. And then we did a space closure. And fairly good parallelism of roots except a couple of teeth. And then we did a settling. So usually when I do a settling, this is only for freshers. There'll be a mild active tie back and a Kobayashi hook to settle in this I'm settling the lower upper premolar, so there's no wire in this side. So we finished like this. Some amount of mild deep bite has occurred, but not too bad. This is what I wanted to show you. You get a very poor contact point between the 4 and the 6. Upper, it doesn't make a difference, but lower, it does make a difference. Okay, I'll just rush through these slides. This is how we changed. Good smile. Maybe slight deepening of the bite, but not too much. Good occlusion. Now, when you get a class 2 finish, until 95, I was extracting the upper 4s and the lower 5s. Then I had a contact with Dr. Creekmore, and actually it was a hotel room, and with Dr. Prakash, he'll always call us for a drink, and I was explaining to him. Then he took the hotel station and explained to me these points. Just see her here. She has got a class 2 malocclusion. Yes, you can do so many things. You can distalize the maxillary dentition. You can bring the lowers forward with, but the lower was fairly okay in this case. So you can bring the lower forward with a fixed functional, whatever you want. But this is one other way of I go about treating the patients. So if you extract a lower 5, what happens when you extract the lower 5, you have upper 4s and lower 5s. You have to finish the molars in class 1. So that means my lower molar has to move ahead by at least 5.5 to 6 mm. So when that happens, it's almost difficult to do that, mainly because you kind of the situation that you have in the system. So the amount of space left behind is very little for any correction of your proclination or whatever is there. But the main thing is you have to accept when you do a camouflage, you need to accept that we are going to retain the dentoalveolar compensations of a class 2 malocclusion. Main thing is why this does not move is, one is this moves from here to here in a thick cortical bone. There is a narrowing of the arch in that area. And when you see the root surface between the 6 and the 5, there is a huge difference. So generally, it does not move. It look with class 2 elastics, the patient will posture the mandible forward, but after some time, when you see the patient, he'll be in an end-on occlusion in most of the cases. So we went ahead, extracted only the upper premolars, and we started retraction, and then closed the spaces, settling, and then this is how we finished. I have a fairly, maybe slight, not so coinciding midline, but the canines are sitting nicely in class 1, molar is in class 2. And this is how she changed. Her mandible was good, so we could get away with just the 4 extractions. Now, just for your usually we use the lower second molar tube of the second molar tube of the opposite side for this. Why we do that is, generally in a class 1, you have a distal in rotation in the upper molar. So what happens is the upper molar gets rotated distal in. When it gets rotated distal in, the mesiobuccal cusp comes out and occludes against the mesiobuccal groove, which is probably the broadest area in the transverse dimension. But when you do a class 2 finish, you're going to occlude against the distal surface of the lower second premolar, so which is going to be a much narrower area. So you need a tube that does not have rotation. So when you have the rotation, the molar rotates distal in. And when you don't have rotation, it rotates. I think this was created by Anil Chirla. I think he's there in the audience. Thank you, Anil. I'm still using it. The second thing that you do is, in these cases, is you just keep the tube. If you're using pre-welds, push the band up a little bit. Or if you're welding a tube, just push it up a little bit. So when you do, or if you're bonding also, you can do that. So this gives you a much better settling with the distal surface of your lower second premolar. So just for theory's sake, the only tube that has got no rotations is basically your MBT system. And since the lower second premolar, second molar has got 10 and it's closer to 14, that's the reason why you choose. And you choose the opposite side to get the right torque in. The main problem with the class 2 finish is all of us start with this, but then what happens is after some time, you close the space, okay, because your class 2 means the upper molar is ahead of the lower molar by 5.5 mm. But when you start retracting it back, after about some time, you still have about 1.5 to 2 mm space, but you don't have the overjet to do it. So what do we do that time? Okay, there's one more point. One is you can increase the torque on the upper anteriors. The second way is, the molars are rotated mesial in. So when their molars are rotated mesial in, they are rhomboidal shape, they occupy a little more space. There is slenderization of the lower anterior, which is possible, where sometimes you'll also find a completely blocked out incisor, so you can also sacrifice that. And if any of you have this thing, these are the series of articles by Dr. Jansen, in which he has showed that it's more predictable with the 2 premolar than a 4 premolar extraction. Now, the same thing happens. I have once again a class 2 patient, but I have a subdivision. I have a class 2 on one side, I have a class 1 on the other side. So what do I do with this? And if you see a lateral like this, always suspect a Bolton's discrepancy. So what did we do? We extracted the upper premolars and the premolar and the lower only on the class 1 side. So we went ahead with a retraction and we closed the space. We had a little bit of hurry of time, so we used a little bit of loop mechanics there and then did a little bit of settling. And this is how we finished. Now, this is what you need to understand. The midlines are coincidence. Left side, you have extracted both upper and lower premolar. So you have a class 1. On the right side, haven't extracted the lower premolar. So I have a class 2 molar, but a class 1 canine. So actually, the final occlusion should always be a class 1 canine, or the tooth that is substituting the canine to be in class 1, and the other one should be in a cusp to groove relationship. This is how she finished. She was still growing, so the lower jaw did come forward a little bit. Once again, Jansen et al., they tell you what happens is it gives you a similar this thing, but it always, you find that the 3 premolar extraction is also the same as the 4 premolar extraction. The better occlusal, so that is, you get a good cusp to groove relationship with this. Very, very rarely, okay, these are rare cases, so that is why I just put it. If your upper midline is away from, usually you take the philtrum for that. So if your upper midline is slightly away and you have a subdivision, but I have a lot of spacing, I don't want to extract too much in this case, I don't want to do 3 premolar extraction, you can always think of extracting a single premolar and then correcting it. This is a very old case. So we were using the overnight slot those days, so we're using some loop mechanics, and we finished like this. And this is how he finished. Now, once again, if you go and see his occlusion, you have a class 1 canine, but you have a class 2 molar on the right side. Okay, now we go to a slightly different kind of extraction patterns. This was a patient that presented at college, and she had something like this. This tooth, you can see the amount of root surface that's gone. Then you can imagine where the bone level is. On the labial side, there's no bone at all. And when you go and see occlusally, what you see is I have another incisor, which is lingually placed, but the root is even further lingual to the crown. So if I have to give a labial root torque on this patient or a lingual crown top, I have to move the root from there to here. Almost we are talking about 10 millimeters of root movement in a cortical bone. And also we are going to talk about the lower incisors which have thin roots. Chance of getting root resorption is very, very, very high. So what did we do here? We extracted the upper fours and then we extracted both the incisors only on the right side. And if you notice here, sorry, if you notice here, we have not bonded the four anteriors. The canine was mesially tipped. When you have a minimal overbite, always be careful. It's very easy to go into open bite. So what we did was we wanted to upright the canines before even starting the putting the brackets onto the four incisors. So then we used open coil springs to dislice the canine. When I put an open coil spring and dislice the canine, what is the advantages? I'm in reciprocal anchorage. So I could have used a TAD here and done it, but always remember, wherever we don't become prisoners of our own, having to put this, having to put that, and if you use a little bit of your common sense, you can get most of these things done without this use of TADs or whatever is there. So we went ahead, did the retraction. But you understand we have created a Bolton's discrepancy because you have extracted 2 premolars against 2 incisors. And then we did a little bit of space closure after a little bit of slenderization in the lower anteriors. And then we finished like this. Fairly good parallelism of the roots. And a little very minimal settling was needed in this case. And she came off with the braces. Now, the advantage when you do this is you have still a midline that can coincide. If you do a 3 premolar, 3 incisor extraction, you'll never get a midline coincident. But your canines sit nicely in class 1. And this is how she had the occlusion. And the retainers, as usual, I have a very standard pattern of retainers. Suddenly, the PG started doing this. They started, doing a little bit of makeover for these patients. Whether the occlusion is good or not, the face looks much better. Okay, so they started bringing a head straightener and all full makeup kit before doing the post-op photographs. So this is where we started from there to here, and there to here, and from here to here. And this is what happened. Okay, see the change in her face. You see that spark in the eyes which comes when they know they look good. All girls or ladies know the day their hair is good, the day they look good, one extra look comes into their face. So she was okay. Now we'll talk something on non-extraction also, just for completing everything. Nice girl, slightly deficient lower jaw. I like this 3-4 millimeters class 2 for any fixed functionals. If it's huge class 2, I'm a little bit worried because generally there is some amount of relapse. And when you see a frenum like this, you go for frenectomy, but that frenectomy is done post-treatment, not pre-treatment, unless the space is not closing. So when they do a VT2, especially if there's a large class 2, I tell them to take in various levels, and then you realize at which stage the face looks the best. Okay. But remember, your upper teeth are also going to get a little bit disliced, so you have to. I think this will become the ideal situation. So we went ahead, strapped up the patient, then used a fixed functional forces. She broke some things, and then once again we had to replace back the whole thing. It took a lot of time. And then this is how she looked. We closed the remaining minor spaces which were there after a little bit of slenderization. And we did a little bit of settling. And this is how she looked. If you see her face, well balanced. And this is how she looked. The occlusion is very good, midlines coincident, nice settling, and this settling will occur further as you put your wraparound retainers. Okay, this is very, very little bit controversial also, you can say. I had my training during my PG time only in Beck technique. I didn't even know what was straight wire. We have never seen a bracket also when we were learning. So little bit of that concept still stays in your mind. And this was a lady, she was in her 40s, but she wanted something done about her teeth. Now, if you see the OPG, there's a lot of bone loss everywhere, okay? The first thing is a perio opinion. They did a lot of curettage and things like that. And in spite of doing that, it was still, you can see the condition of the gingiva everywhere. It was very bad. So we're wondering, should we take up the case or not take up the case? And if you take up the case, the main problem is when you have bone loss, your CR goes more apical. When it goes more apical, what happens is your amount of movement that you generate becomes more. So my old this thing, so we didn't bond the two premolars, okay? So after that, we used AJ Wilcock and only intermaxillary hooks, and I started retracting with this, with just yellow elastics, okay? And we did only the lower because there was no overjet for me. Then after some time, we got the overjet, then we started retracting both the arches, and we went on like this. Then we picked up the premolars, and then we started doing the settling. And this is how she looked at that time. Traction. And settling. And this is how she finished. Not too much change in the face, but she was so happy that space was there. And somehow, you know, the teeth became more healthier once you got that open bite corrected and once you got the lip closure. And very good paralleling of the roots. And if you see here, the bone support, I don't know, it's not come down much here, but some of these lowers look more healthier than what they were. And this is the occlusion that we had. Coincident mood lines, good canine class 1 and molar relationship. As usual, the retainers. And this is how we finished her. Always remember, use light forces on these periodontally compromised case. You can still do wonders. Okay, I come to the last case. It's a little bit different case. She had a very cute smile, but she was very, very conscious of her smile. Okay? She was highly conscious of her smile. So we did the preliminary investigation study models. I spend a lot of time with my study models because to me it's a 3D way of looking at a malocclusion. Today we think of some are higher levels. We look at the CEF. CEF is great for me for a, confirmatory diagnosis, but it's never my primary diagnosis. Clinical examination, study models, then only this. Now we had some problem here. One canine was okay to brought out. This canine was almost across the root. And this girl was to get, they were looking out for her marriage and things like that. So we went ahead, extracted the right upper canine, which was impacted, and the left lower incisor. I told him to extract, but the student was always hopeful that I'll somehow bring it into occlusion. So we went ahead, started, but you remember, we see here, we have retained the C. Okay, so we've retained the C, and we started bringing this incisor out first. I told him get this knocked out, but he was always hopeful somehow we'll bring it into occlusion. Then we started closing the space, but if you notice here, I've used a little bit of an open coil spring here. This is basically to maintain the space, a little bit of extra space, because when I give a permanent canine here, then I will need a little more extra space. And we started closing the spaces. And this is how it looked occlusally. Now what did we do? We found that the deciduous canine had a fairly long root, okay? And if you have a long root, it can last you for 20 years, 25 years, okay? So what we did was, we did a little bit of crown lengthening procedure. But whenever you do a crown lengthening, what you need to remember, there's something called the biological width. Biological width is nothing but a bone needs to be covered by with attached gingiva and then followed a little bit of free gingiva also. So if you don't reduce the bone here, the gingiva will grow over this. So always remember, if you're going to do a crown lengthening beyond a certain level, you always need to reduce the alveolar bone height a little bit. So we did this. Once it healed, we put a crown on her, not the best of crowns, but that's all we could do it in the college. We didn't put any bracket on the crown because it was a zirconia crown and we didn't want to spoil it. Those days, today for a zirconia crown, I use something called the Assure Plus, which is there with Reliance products. It's available here also. Assure Plus. You get fairly good bond strength with them. And for all my molar boundings, I use that. I'm not propagating that product, but just for information's sake. Now, if you see here, can you see the amount of root that is still there in the deciduous canine? So what happens is this root will last up a fairly good time. Sorry. And mid-treatment photographs. And then we went with a little bit of settling. Here I had a little bit of debite, so curvus P was still there. So if that is there, then what I do is I remove the wire in the lower arch and supra-erect my premolar. Sorry. Second is I also could not put an attachment on this. I didn't want to spoil the crown. And this is how you won't get a midlines coincident. Why we won't get a midline? Because we have 3 incisors in the lower arch. It will coincide with the center of the centralmost incisor. So we finish like this. Retainers. And this is how she finished. Now you see the smile. It's a different smile altogether. The occlusion, once again, we had a very deep bite. We got that corrected. And the occlusion was really good. And slowly the zirconia crown started merging with the rest. And from here, she turned to here. See the difference in the smile, difference in the way she looks. She looks like a model face. Thank you one and all for a very patient hearing. We have a lot of time for questioning. If any of you want to question, I'm open to questions.
Sir.
Yeah. Pardon? Good morning. Yeah, thank you. Any questions? Can somebody pass the mic on to him, please, so that all of them can listen to the question? There are some mics placed on the port in the passage also. If any of you want to ask questions, I'm willing. Yeah, please go ahead.
Sir, in class 2 subdivision,
Yeah.
you extracted on class 1 side.
Yeah.
Why not on class 2 side and get it into class 1?
That's what I explained to you. See, if I have extract on a full cusp class 2, I have to bring the lower molar forward by about 5 to 6 millimeters. Understand what you use class 2 LS, even the begs, we used to do that on a regular basis. But after some time, when we see what happens is the mandible goes back a little bit and we always end up in an end-on occlusion. We never get a full cusp class 1 relationship. It's very difficult to bring a lower molar forward by 5 to 6 mm conventionally. Even with the use of TADS, it takes a very long time because the molar has to move in cortical bone into a narrower area of the premolar region. So to me, I always look at the percentage of success. When I do a finish like this, I'm almost close to 100% success. Okay?
Thank you.
But when you do the other way around, you do not get your profile will be the same, but you do not get the good cusp to groove relationship. And it makes your journey so much easier. Why do you want to extract a lower premolar? Just to get a class 1, that means you are still stuck with the angle error.
No, sir. What I meant was, anyway, you are extracting on the other side.
Yeah, if I
So-
extract this side,
Yeah.
I will not get a good occlusion at the end of the treatment.
Sir, you extracted only one premolar.
One
so-
premolar only on the class 1 side. See,
Correct, sir.
if you're going to finish in class 1, remember you have to do a non-extraction or a bijaw extraction. If you're going to do a class 2 finish, you're going to be one premolar short in the lower. If I do a class 3 finish, I'll be one premolar short in the upper, but I'll never do a class 3 finish. Why? Because the upper 7 will be completely unsupported. You understand? If you set it in the typodont, you'll understand. But if you do a class 2 finish, the distal cusp of the 6 will always see that the lower 7 will not supra-erupt, or the lower 8 also will support the upper 7. So this can happen in a class 2 finish, but it will never happen in a class 3 finish. The upper second molar will be completely unsupported. So it's very difficult to keep it in place.
Thank you, sir.
Thank you.
More questions? Thank you, Jana sir, for the wonderful presentation, and it was a very clear presentation. And it is wonderful to learn from an experienced clinician like you all the tips and techniques of what to be followed from your experience. These things we don't get it from the textbook, and it's a volume of knowledge that we have gained from your presentation. Thank you so much for that.
Thank you. Thank you.
Thank you, sir. May I invite Dr. Shailesh Shanava, sir, and Dr. Arvind Kumar, sir, to please felicitate Dr. P. Janardhanam. Dr. Manerikar, sir, may I please call upon Dr. R. Manerikar, sir, to please felicitate our chairpersons for the session. We start with the second scientific session for the day. May I invite our chairpersons for this session, Dr. Anjulumba ma'am. She's a former HOD, Saraswati Dental College, Lucknow, currently into private practice. And Dr. Anup Kanase, he's the Director, State Program Officer, NDHP, Delhi, and also a member of DCI. Welcome, sir. Welcome, ma'am. I welcome our speaker, Major General Dr. B. Jayan, sir.
Good morning. I see a lot of stalwarts of our Indian Orthodontic Society over here, our international guests, and our very own president of WFO, Dr. Nikhilesh Vaid also. Morning, everybody. It's indeed a pleasure and honor to talk about our speaker, Major General Balkrishna Jain. He's a graduate of Government Dental College, 1989 batch, and was commissioned in the Army Dental Corps in 1991. He did his MDS from AFMC Pune, and he's the first dental professional in India to be awarded a fellowship in sleep medicine by the Indian Sleep Disorder Society. He completed his fellowship program in clinical research, and he has done the senior defense management course from the prestigious College of Defense Management, Secunderabad. He's a recipient of the IOS Research Award in 2009 and is also a recognized PG teacher for MUHS and Delhi University. He has made a number of presentations, 92 in various national and international conferences, and published almost 84 papers in various renowned journals, and has also contributed 9 chapters in International Orthodontic with special reference on sleep medicine. He has also the distinction of delivering the prestigious Major General Kartar Singh Memorial Lecture under the PFA and the Punamma Memorial Lecture at Coorg Institute of Dental Sciences. He has been also instrumental in training the Air Force dental officers in aerospace dentistry. They have a special 2 weeks program, and he has formulated the dental standards for fitness and dental screening protocol for the Indian Human Space Program, that is the Gaganyaan program. And we all know he's a very accomplished clinician, researcher, leader, administrator, and a speaker. Welcome, dear Jan.
Thank you. Thank you, chairpersons. A very good morning to all of you. I have been speaking from the Indian Orthodontic Society podium and various other podiums on airways since the last 2.5 decades. And it has taken my society and also my professional colleagues to realize that this particular topic deserves its attention, so it has upgraded itself to a keynote talk. I have spoken in the auditorium with 5 people, 10 people, sometimes only my students. Today I'm delighted to see that there are seats which are filled, and more than that, I'm delighted to see there are people sitting in the last row also. I learned from my father at a very young age that you learn more from universe and less from university. So my knowledge has been acquired more from what I read from lateral sources and less from the mainstream books, nor I got this education and what I'm talking from the university. This is the new motto of ours: the earnest aspirant gains supreme wisdom, and this is from our own Rig Veda. Now, if you look at these wonderful faces, they're world-class athletes, some of them Indian, some of them international. You have the latest Lakshya Sen, the legendary P.T. Usha, Neeraj Chopra, Subhadar Neeraj Chopra, and P.V. Sindhu and the others. What is common that you notice is they've got fantastic jaws. The maxilla and mandible are so well developed and prominent. I am yet to see a kid or a case or a boy or a girl who has a craniofacial issue and clocked 100 meters in less than 10 minutes, 10 seconds. Their athletic performances are normally compromised if you have a poor facial architecture or if the maxillary and mandibular bones are not well oriented in space. These are the famous Raramuri tribe who live across the canyon. They can run around 400 miles. The beauty is that they train themselves by putting water in the mouth, run about 1 kilometer and spit the water. Then again, water in the mouth, you must take it to 5 kilometers so that you enhance the quality of nasal breathing. So this is what we learn from tribal medicine and anthropology. cultural anthropology. The objective of my lecture would be to revisit the evolution, the decision making in orthodontics, which I have differ in many ways, and discuss various strategies to improve the vital human airway, which is essentially good for good health, longevity, quality of life, and well being. And my talk is based on various editorials and review articles that I've been writing since 2009. I not only worked in these three great armed forces dental institutions, and I've also headed these three institutions at various points of time. The talk would be covered with introduction, my focus is on decision that we take, the silent epidemic called the mouth breathing, and a little bit of case series with not too much of pre and post photographs, but emphasis on how much the airway improves, and I shall conclude thereafter. Philosophy of airway orthodontics triumphs everything else in contemporary orthodontics. The central aspect of function and performance is the airway and breathing, which is, in fact, hierarchically the most important function, and we would have realized that during the recent pandemic. Orthodontic profession is crucial and integral part of interdisciplinary team and well poised to become a part of mainstream. Let's see how it can. When the definition of health was just limited to absence of disease or infirmity, specialties like orthodontics could not find a place in the mainstream health sciences. And only after WHO included the concept of health as a state of complete physical, mental, and social well-being, that in the 1940s, that we found a place in the healthcare system. The expanded view of health, which includes quality of life, and that is precisely the reason we are healthcare professionals today. It is important that we integrate ourselves with sleep medicine. We have better understanding of evolutionary biology, medicine, the importance of jaw, particularly in view of the anthropology, orientation of the same, which are the key determinants in optimizing the upper airway. And you will realize subsequently why some of them are so good in their breathing and athletic performance. Specialty of orthodontics is also poised to normalize form and function, not only in children but also in adults, so that function is optimized for the rest of his life and he enjoys a good quality of life. It actually does not matter if he has got imbrication or diastema. It only matters if his quality of life is good. And if you do a survey of orthodontists here, 90% of them will have crowding and spacing. And we keep talking about that. But there are larger issues we need to address for the sake of this 140 crore population. Now, this is one thing which I always cite, this beautiful editorial in Seminar in Orthodontics. The medical necessary orthodontic care. Basically, we are all child care specialists and adolescent care specialists. So we have to contribute towards their health. Actually, the specialty of orthodontics emerged from otorhinolaryngology. It is so important that we need to have the basic knowledge of otorhinolaryngology. So therefore, medical necessity that may involve the care of orthodontists alone or with the medical team also brings up the issue of separation of dentistry with medicine. One of the greatest tragedies of the last century is the artificial divide between dentistry and medical science, whether we accept it or not. The medical people have less idea of dentistry, and dentists after some time refuse to integrate themselves with a large medical science. If you do not narrow, our population and our people or our clientele is going to suffer. Now, if you scan the literature over the last 40 years, it is only of late that you find a lot of airway-related articles, particularly in allied literature, and not very much in even in international, but although it is it is improving. The research over the 50 years has been based on airway and facial morphology, head posture and the airway, adenoids and tonsils, how it impacts the airway, emphasis on volume, investigative methods to find out. And of late, it was on OSA and COVID in the recent past. If you just put these two words in the Google, you will find that many a COVID patient, the mortality was more in OSA patients because the respiration was already compromised and the jaw architecture could have seriously contributed to the OSA. Our textbooks, both in oral surgery and orthodontics, are bringing these issues so that our people get oriented towards this philosophy and put them into practice. The other important point is our need to study anthropology. Although it is a mandate of the Dental Council of India, seldom it is taught in the dental schools, nor we have anthropology teachers. So knowing the evolution is more important. And it is based on these that these subjects have emerged, especially dental sleep medicine. Another landmark article, The Great Leap Forward, a medical hypothesis in sleep medicine by Terence Davidson, summarizes how craniofacial architecture is so crucial for your basic respiration. Our body is like a bottle. The neck of the bottle is where this neck is. You choke the neck, the body can't survive. And if you see how we transform ourselves from being a quadruped to a biped and then have a bipedal stance, what got compromised in the whole bargain? The maxilla and mandible started receding in order to place it on the spinal column so that the CG is maintained, what is called clinorhynchi or rhinorhynchi. There is cervical vertebrae, maxilla and mandible went back. What got compromised is the vital human airway. And actually, who are the ones who are managing jaws? It is orthodontists. So whenever you're playing with the jaws, your diagnosis will start from vertebrae to airway and then move towards the lips. It is not the other way. Another important thing which happened in the history is what is called ontogeny recapitulates phylogeny. So all that you see in the evolutionary process, you will see in the development of a kid right from fertilization to its birth and thereafter. In primates, the epiglottis and the soft palate is locked. So they can breathe and they can eat simultaneously. As far as human beings is concerned, they are the only ones having an oropharyngeal space. We have an oropharyngeal tongue. Primates do not have an oropharyngeal tongue. Because we have an oropharyngeal tongue, significant part of the tongue is parked in the pharynx. And if you do your treatment, which will further facilitate it going back, you are going to compromise on the airway. The descending of the epiglottis or the laryngeal apparatus down by first year is the primary reason that humans have vocalization and they can speak. It is only because of communication that human beings survive. If it is physical force, we are not even capable of fighting a monkey. Not even capable of fighting a dog. So therefore, this aspect and the descending of the larynx and propelling the jaws forward is an important point to be noticed. Over the period of last 2 centuries or 300 years, the maxilla has grossly narrowed in the current population across the world. Why? Because of modern eating habits and less children being breastfed. Breastfed is the first and the most important stimulus for maxillary growth. And maxillary growth is the most important stimulus for mandibular growth. The foramen magnum has also migrated forward in the course of evolution for you to become a biped. Maxilla has become narrow. Now coming to the decision making. Decision making has largely depended on obtaining optimal proximal and residual contact of teeth and improve smile and appearance. The protocol of analyzing the airway and the impact of orthodontic treatment on the upper airway dynamics is seldom factored in. We are more interested in proximal contacts. How does it contact? It is important. But there are more important things. If you have a good lip seal, and if you have a highway like an airway is like a highway, everything will fall in place. But if you are having good proximal contact, but you have a narrow airway and lips are not competent, it's as good as you know you're doing no treatment would have been better. So we don't factor that in our decision-making process. So improvement in smile and facial appearance with resultant improvement in individual social well-being, obtaining optimal proximal contacts has been our key. In spite of mounting evidence that rapid maxillary expansion, mandibular advancement, maxillary advancement improve the airway, we actually do not factor in the outcome as the goal. The goal is never that. The goal is something else. So decision making has largely involved family dentists sending the patient to you and you using your clinical findings and your diagnostic records. And you need an integrated approach of maxillofacial surgeon, prostho, perio, other medical specialists in our field, particularly ENT specialists and pulmonologists. Decision is a course of action consciously chosen from available alternatives. Now comes what do we know about this? For the purpose of achieving a desired result, and in decision making, rationality of individuals is limited. There's something called bounded rationality. We make decisions based on our perception, what we have learned, and what we know. But there are many things which are to be incorporated into our decision making, which is a dynamic process. Suppose the mind doesn't know that we need to know this, you're not going to make the right decision. Now, if we talk about integrated human health, overall health of the planet, animal health affects us. The more breeding of animals, the more viruses, the more problems. Animal health, climate change, everything is going to affect the face. The other day, I asked one of my students, why don't you do PhD on the effect of facial morphology and its relationship to climate change? There was a big laughter. They thought that he is a madman. I am not mad. How much of pollutants you create, and you're constantly creating people who only breathe through mouth, your facial architecture over a period of the next 100 years is going to change. So therefore, orthodontics as such is a combination of anthropology, biology, and technology. If your decision making revolves around technology, ignoring anthropology and biology, you're bound to make mistakes. So that is the reason why I told bounded rationality is an important aspect. We have created in media and in the newspapers and in otherwise also, a distant profile is okay, chalta hai. दांत पूरा अंदर है, दिखता नहीं है. दांत दिखता नहीं है, बहुत अच्छा है. How can you make a statement like that? And then you don't realize, after you dished in the face, this person puts on some adipose tissue, they become mothers, they have weight, they have in the lingual region, and then what happens? You choke the vital human airway, and you make them cripples. As I said, the development of complex language was a great leap, and that was important for us. And now people living in closed rooms and with allergies are one of the reasons. So orofacial health is influenced by what we eat, how we eat, and slack jaw and prevailing oral posture is also because of our indoor living and the allergens that we have addressed. Chronic nasal allergy and you do 4-4 extraction and do orthodontics. Do you think the teeth will be in place? Because you have not addressed the allergy at all. You will continue to make him oral breathers, and then you will say relapse हो गया. The relapse होने के चक्कर में आप पूरा दांत को बांध के रख दिया अंदर. And you tell that is a way to retain. It is an artificial way. An orthopedic surgeon doesn't bind 2 fingers and keep for long. He releases it after some time. So that itself shows you that something in you is not natural. If you analyze the profile on your extreme left, which is the laser, on my picture frames on the extreme left is most susceptible to sleep disordered breathing, and the most healthiest profile is the first profile, like what you saw in these athletes. So the moment you see a profile, you know this is compromised, no question of retractive mechanics. It has to be protrusive and nothing else than that. And I have to put the lower jaw in place, and symphysis or chin, which is unique to humans, has to be restored. Craniofacial dystrophy is a syndrome now, and you see it every day. and in your practice. Insufficient mid-face support because of poor nasal breathing, nasal cartilage collapse, maxilla is down and back, and then mandible follows it, so it goes further back. Airway is like a soft tube supported by the jaw bones and the cervical vertebrae behind. It can collapse anywhere, and you need to know where exactly it collapses. And this literature is emerging as to which profile is more susceptible to sleep disordered breathing, particularly the convex facial profile. And these references I have cited, these are reported in sleep medicine and thorax journals, not in orthodontic journals alone. So therefore, our medical fraternity is also keeping a close eye on the thyromental angle. And if you're going to worsen your thyromental angle in any of your mechanics or treatment, you're not doing good for the health. These are the classical signs of not only sleep disordered breathing, but they are classical signs in mouth breathing cases. So mouth breathing is an impending sign of sleep apnea. So if you leave a mouth breather as mouth breather, kuch bhi nahi kiya. We have to integrate airway and tonsillar grading as a regular check in all cases, whether it is child or whether it is adult. And how many of us know to do it exactly? We have to go and introspect ourselves. This analysis by McNamara was put way back in 1984, but still it becomes only an academic discussion. What is the airway? One theory question or short notes is asked, but do you actually put that into practice? We have devised a 11-point wherein we analyze the posterior airway space, middle airway space, position of the hyoid bone, in addition to assessing the relationship of maxilla to cranial base, mandible to cranial base, dentition. Arithmetics make no sense. View the cephalogram like a radiologist, not like a mathematician. Then you will be competing with mathematics, 82 to 84, 86 to 87, nakko nakko. How is mandible related to the cranial base? Maxilla to cranial base? How is each and every component like hyoid related? Then comes soft tissue, then comes the airway. If you play mathematics, all the best. More mathematics will come in the days to come. Now, this is an important input you need to have from CT in whether your airway is compromised. Retrolingual airway cross-sectional area was found to correlate with severity of sleep apnea. The more it is compromised, the severity will increase. We don't need big investigations. Now, this is a case which reported tele-dentistry yesterday, a doctor from Trivandrum. He said his AHI is 66, he's not able to breathe. His wife sent me the audio and video of his snoring. And I just told, take this cephalogram. And if anybody can make out, is there an airway there for him? His BMI is 22. That means a thin-looking guy. And when you protrude the mandible, you see it becomes a highway. Now you can create one highway for him just by pushing the maxilla and mandible forward, and you will contribute towards the larger health. But if you fix yourself to class 1 and occlusal contacts, you will be stuck. Pharyngometry is another important tool, non-invasive. Chairside, you can implement it. The Armed Forces Medical College did this quite some years back, I think 10 years. And I'm sorry to say the rest of the country is still not catching up. You can see what is the outcome with your functional appliances and your surgical cases just by doing an acoustic pharyngometry. And another one, IOTN, what are the other scores? PAR index, all these indexes, all related to mathematics. What about the medical reasons which makes our treatment complex? What about systemic illnesses? What about medical necessities? What about airway compromise? So we need to make new indices which will define as to what is the difficulty of the case. Difficulty of the case is not based on the overjet and the overbite. Difficulty of the case is based on what is the problem with the human being. Am I right? I see some nod, so I think I'm right. None of these mention about the effect of systemic diseases, behavioral condition, etc. on the difficulty and the outcome. So let us do some research and make a new index. If there is diabetes, itna score extra hoga. Behavioral problems, itna hoga. At age, attention, deficit, hyperactivity, there will be a different score. The way ahead is to integrate the difficulties, and one of my officers, Colonel Dinesh Chaudhary, is already working on it. Now, we have already written to a journal outside internationally. They are still reviewing it. I don't know whether they'll reject and buy the idea for themselves. This model already exists, Stanford morphometric model. It is a chair-side tool where you can do this calculation and you can know or you can predict whether it will be a sleep apneic. And we can include that in our orthodontic checklist. Stanford morphometric model, which includes body mass index, neck circumference, overjet, intermolar distance, and you can do research and refine it. Currently, if the score is more than 70, means he's susceptible to airway compromise. So if the Stanford morphometrics index is high, you are having a deficient mandible, and then you do 4 extraction, maja hi maja hai uske baad. When the tongue rests in the roof of the mouth, the teeth are wrapped around the tongue, forming a normal shape. The tongue is basically the scaffold. If you do not control the tongue posture in the first 10 years of this child's life, be rest assured, whatever orthodontic treatment you do, it is bound to relapse at some stage. So the scaffold need to be managed. Now, finding a room for all the teeth is not a common problem if you start early enough and mimic what we are supposed to be more of pediatric care specialists. You need to see them young and you need to find space for them. Open mouth posture is the most common and significant soft tissue dysfunction in children today. Just give some time for settling down. The only scary thing, the numbers, is this number. Other numbers not scary. The missing link is, it is not just growth and development, it is growth, development, and adaptation. Airway, for example, airway compromise, forward head posture, craniocervical extension. To make you breathe, that's an adaptation. The same adaptation, would you want that adaptation to continue? Or whether you want to reorient that person, both in his posture and otherwise, it is left to you. Or if you are okay with that posture, then that is different. So as I said, craniocervical extension and forward head posture is a clear indication that the airway is compromised. And you need to do whatever intervention at that appropriate period in order to improve the airway. And naturally, these two phenomena is going to improve. Factoring in craniofacial risk factors for upper airway collapsibility and SDB in decision making in orthodontics is critical in contemporary orthodontics. Orthognathic surgery, we take a lot of pride in saying, मैंने surgical case को मैंने non-surgical कर दिया. अरे भाई, तुमने ऐसे कैसे कर दिया? तुमने कुछ तो कर दिया होगा गलत. ठीक तो नहीं हो सकता है. So this taking pride in something which you say is the problem and something else you did as a solution is a mystery. So therefore, and if you see the Wikipedia, orthognathic surgery is a surgery to correct conditions of the jaw and the face related to structure, growth, sleep apnea, TMJ disorders, so and so, so and so. This Wikipedia is telling you. And you still are telling that it is not required. And if you see the current trends, it is decreasing because we have propagated orthognathic surgery as an aesthetic surgery. Orthognathic surgery is not aesthetic surgery. It is also life-saving surgeries in many cases, particularly with severe deficient jaws. When you do advance the maxilla and mandible, it is life-saving. So we should not tell that it is cosmetic surgery. And if you see our trends in JIS also, there are 4 or 5 articles every year of importance on surgical orthodontic treatment. That is a reflection of the mood of the nation. If you see the articles internationally, there's a PubMed scan, slowly increasing, but not to the level. When you treat a person, you need not think that I should treat alone. Your whole team together can treat. Anesthetist is a part of your team. Pediatrician is a part of your team. Pulmonologist is a part of your team. Endocrinologist is a part of your team. And if you see the definition of dental sleep medicine, its scope, it is craniofacial evaluation for risk factors, OAT or oral appliance therapy, maxillomandibular advancement, cephalometry, and prevention of SDB through RME and other means. That means there is nothing called a separate specialty of dental sleep medicine. All orthodontists are dental sleep medicine specialists by virtue of they being orthodontists. And there can't be better people to handle this than orthodontists because they have good knowledge of craniofacial growth. Mandibular advancement itself does a lot of activities, like it elevates the base of the tongue, tenses the palatoglossus and the soft palate, decompresses tissues around the pharynx, plays the tonsillar arches. So a whole lot of muscular tonicity and activity happens just by advancing the mandible. Again, I go back to the anthropology, where if you don't position the jaws in space, these muscles will also get affected. Twin block, a very well-known thing as to it improves the airway. But again, we focus ourselves on whether there is a problem or gain in the TMJ modulation, or there is growth or there is no growth. But the bottom line is there is improvement in health. The recent meta-analysis, both for DO in children as well as functional appliances, are clearly indicative that they are one of the first line of treatment for sleep disordered breathing in children. All these appliances which are today coming up in quite a big way, both internationally and nationally, the mandibular advancement appliances for sleep disordered breathing, is all based on the simple philosophy that you need to position the mandible in a particular position so that you pull the tongue forward and enable the person to breathe better. Obese with craniofacial abnormalities, obese with normal craniofacial anatomy, long face syndrome, mandibular deficiency, high arch palate, and environmental factors including scarring, these are considered as risk factors for sleep disordered breathing. And we come across this every day. So eliminating the risk factors is the key. And if you see the current literature on the craniofacial management of OSA patient, early expansion, nasomaxillary protraction, stimulating mandibular growth, bone-anchored orthopedics, and surgically assisted orthodontics are the different modalities of improving the same. Now, most of the craniofacial cases like upwards or cruise-on, you will never find a nasopharyngeal airway space. And our target should be to open up that. In tonsillar enlargement, adenotonsillar enlargement, again, the adaptation of the child is to put the mandible forward so that they can breathe. And that results in subsequently class 3 malocclusion. Identification of adenoids and tonsils on the lateral ceph is crucial for children. All these cases like long face syndrome have an impact on the airway. Cleft cases severely impact the nasopharyngeal airway space. So if you do not protract the maxilla out and try to manage the case based on your dental and occlusion, you're not going to do good for the case in the long run. Mouth breathing is an unrecognized epidemic. Long back, there was a book in 1840s, Shut Your Mouth and Live Longer, or Shut Your Mouth and Have a Long Life. Nasal breathing is important for nitrous oxide, and nitrous oxide is a very important molecule. It is liberated by the nasal mucosa and the sinuses. It helps in getting in more oxygen into the lungs. And if you make somebody breathe through the mouth, you are depriving that oxygenation in the deeper part of the lungs. I'll just skip a few of this. And needless to say, it's an epidemic. And more important, mouth breathers have chronic hidden hyperventilation. They breathe continuously from the mouth. That results in increased release of stress hormones. Stress hormones means adrenaline in small. That has an impact on all organs per se. So chronic hidden hyperventilation is one of the issues. Recent reports from the neurology literature is indicative of impaired cognitive function in mouth breathers in particular. So they have some cognitive impairment due to mouth breathing in addition to athletic performance. And as I said earlier, air pollutants. So climate change will have an impact on our face. Buteyko's breathing and other breathing exercise need to be incorporated. If craniofacial development is complete by 12 years, you are in a best position to modulate the same. Breastfeeding not only to be propagated in terms of immunological and nutritional benefits, but also in terms of benefits of growth and development of the craniofacial skeleton. So all these habits and everything that we target regularly is towards that. Adenotonsillectomy along with rapid maxillary expansion is the first line of treatment for sleep disordered breathing in children. Whether they have a narrow maxilla or not, this is the first line. 4-4 extraction is highly debatable, but however, we know it is against the nature, so we need to look at 4-4 extraction and its impact on the airway much more seriously. And these are briefly running through the cases. Hypoplastic mandible, just look at the airway. The end result is opening up of the airway. Again, the end result again is the opening up of the airway. I'm not focusing on the occlusion. A young child, 14 AHI, narrow airway, distraction about 14 millimeters, and the airway gets opened up. Again, a TMJ ankylosis case, orthosurgical treatment, how beautifully the airway opens up. In class 3 cases, there is a need for you to consider elective glossotomy, especially to control the tongue. Rapid maxillary expansion, severe OSA to almost normal breathing. Cleft cases improves the nasopharyngeal airway space. Now, these are some of the in setbacks. You need to see at the end of the day whether the airway has been maintained or not maintained. In class 2, always BSSRO, it always improves. And my talk is based on over the years of my publications. And this is one particular which I always tell in orthot French. And I would like the postgraduates to just read this. Functional consideration should outweigh purely aesthetic one. It is important when making an orthodontic, surgical, or combined diagnosis for a patient to bear in mind the impact that treatment may have on upper airways. Good aesthetics should never be achieved at the cost of diminishing airways. So we must be more airway conscious. And I had the pleasure of meeting His Excellency, the President of India, in his own office for the work that we did during COVID. This is my team. This is the philosophy that we follow. You need to be an eternal student. So we need to march together. The speciality of science is built brick by humans. And we need to always rethink our strategies, integrate ourselves with larger science and the ecosystem, and improve our thinking and decision making so that we contribute significantly towards the health of the individual and the health of the nation. Thank you and Jai Hind.
Hi. Thank you, Doctor, for the excellent presentation. And I also agree that we must now look forward to more presentations like this. We'll be attending more of these. And you are absolutely right. We must see the etiology and then start treating the patients. As we are running short of time, so we are skipping that question answer session. So I'm sorry for that.
And now I thank Major General Dr. Jayan for the wonderful session. Now I would request our chairperson to felicitate our speaker. Now I would request Dr. Sheetal Padni to felicitate our chairperson.
इसको निकाल दो ना नीचे। ऑडियो चेक करना है। एक मिनट। या
May I invite the chairpersons for the next session? Dr. Krishna Nayak, sir, Principal and Dean, A.B. Shetty Memorial Institute of Dental Sciences. Dr. Gurkirat Singh, Professor and Head, Sudha Rastagi College of Dental Science and Research, Haryana. Please welcome our dynamic speaker, Dr. Nikhilesh Ved.
ऑडियो चल जाएगा, चिंता मत करो।
A very good morning to all my colleagues and friends. I and my co-chairperson, Professor Dr. Gurkirat, are indeed privileged to be chairing this session by Professor Dr. Nikhilesh Vaid, who has been the president of the World Federation of Orthodontics, apart from so many other things. He is adjunct professor of Savita Dental College in Chennai and has a private practice in Dubai at the Invisalign Center and only orthodontics at Mumbai. He has widely published in edited journals, including the seminars in orthodontics, and was a editor-in-chief of APOS Trends in Orthodontics from 2010 to 2020. He is currently EIC Emeritus of the same. He is an active member of the Angle Society North Atlantic Component. He is also past president of the Asian Pacific and Indian Orthodontic Society. He has published more than 180 peer-reviewed papers and textbook chapters and has lectured in more than 50 countries around the world. The important forums at which he has lectured include the AAO annual sessions, the International Orthodontic Congress, AOS, APOS, and many more. Professor White's current areas of interest are evidence-based decisions, making technology, aligners, orthodontic treatment effects, AI applications on what is going to talk of today, and management protocols. His mission is to encourage global collaboration in the profession through leadership, advocacy, voluntary service towards professional societies. This is a very, very brief account of Professor Dr. Nikhilesh Vaid. I invite Nikhilesh to kindly go ahead with his lecture.
Well, thank you so much, sir. It's an absolute privilege to be back home after a really long hiatus. And this place has a lot more deja vu than any other Indian Orthodontic Congress would for me. Before we get started, we will be talking about artificial intelligence and its applications in orthodontics. The last time I remember I was sitting in this auditorium, and I just remembered this because I spoke about it to Dr. Usha Malkani. She and I were sitting together listening to a speaker, and she made a comment to me. I'm not going to name the speaker. She said, but all this is fine, but what does he really want us to do? I hope, ma'am, you don't have the same experience after this lecture that I'm going to talk about, because we are essentially going to be more conceptual than what you can do. And when we talk about technology, it's very important for you to realize whether you're talking to a professional colleague or a salesperson. Ladies and gentlemen, I have no commercial interest in any product procedure that I'm going to be talking about. The maximum honorarium I must have received from somebody would be a bottle of sparkling water, nothing more than that. When I spoke about my deja vu, this is me just outside. This building is the same building where you're here. This is 1997. This is when I became a dentist. So this is me in this class. Don't ask me who I dated in that class. That's a story for another day. And from here, I met a man. I went to a place where I met a man who's influenced my life more than anybody else. If today I can stand on any pedestal, it's the concept of serving the profession that I have learned from my professor, Dr. E.T. Roy. If I have tears in my eyes as I say this, please excuse me, but best professors are those the success of a professor is determined by where their students reach. So I don't think anybody has scaled that more than Professor E.T. Roy. Sir, I can never be indebted to you enough. And then I was also privileged to serve the Indian Orthodontic Society. This is way back in 2015. This is 2016 when I served as the president of the Asian Pacific Orthodontic Society. And here I am now, hot and sexier, 2022, losing a bit more hair. But there has been one constant in this entire journey. Whenever I have embarked on any of these journeys, whether it's going to Mysore to do my master's, whether it's going to Ahmedabad to contest as the president-elect of the Indian Orthodontic Society, or going to Malaysia to contest to become the president of APOS, and Professor Deshmukh will bear testimony to this, or whether it's going to Japan to contest to be the president of WFO, every single time I've made a visit to Pune. You know to where? This is the place. This is the boss of the universe. This is Sarasbag Ganpati. We're going to talk about data number crunching. We're going to talk about what is statistically significant. In my life, this has had 100% success rate. Whenever I've asked for something, I have always gotten it. And that's the power that this city brings to my life. Without much ado, so in my current capacity, I alternate between these two cities. I'm serving the World Federation of Orthodontists. This is an invitation to every single member. By being a virtue of the member of the Indian Orthodontic Society, you can apply to become a fellow of the World Federation of Orthodontists if you're a life member of the Indian Orthodontic Society. And if you're a student member, you get a combined student membership of the WFO and the American Association of Orthodontists, which gives you a personalized access to the entire AAO library as well. Some of the projects that we do undertake, and there will be some scholarships that we will be rolling out early next year. We've already passed them. Is a scholarship for the World Orthodontic Health Day, a travel fellowship for young speakers. We've got an educational portal that brings out a lecture every single month that's available to WFO fellows free of cost. It's a portal that has more than 150 lectures that are available for you to download and get C certifications at your leisure. And of course, the JWFO, you must know and also be very proud that the journal with the most increasing metrics is also edited by an Indian, and that's my colleague on the EC, Dr. Vinod Krishnan. So there is a lot happening at the WFO. And our next Congress will be at Rio de Janeiro in Brazil 2025. Now, when we were to look at orthodontic evolution, and this is something that comes very specifically because most people in other parts of the world don't get this context, because all of us are expert at writing 50-mark answers, right? I mean, sorry, 100-mark long answers, 3 hours, you're writing one answer, paper 4 in MDS. So if suppose in 2050, somebody was asked a question on top moments in orthodontic history, or if I were to talk to my 13-year-old niece who understand apps and versions on different versions of orthodontics, Ortho 1.0 would be tooth movement with simple appliances. All right, this is at the turn of the 19th century. Ortho 2.0 would be the early 1900s, 1930s or so, the edgewise appliance, the advent of cephalometrics, the Jara back technique, the famous friction between the teacher and the student on the extraction, non-extraction philosophy. And then Ortho 3.0 were your direct bonding systems, the advent of most technologies that we use today. Now, you can probably assess yourself on the curve as we go ahead. What kind of orthodontics are we doing today? Ortho 4.0 is the advent of three-dimensional technology, three-dimensional diagnosis, using scans, understanding the concept of acceleration, understanding that we need to get more regimented in terms of applying evidence to our treatment. And Ortho 5.0 will be governed by the Internet of Things, big data, artificial intelligence, tissue engineering, genetics, and the works. Now, as we chronicle this, where does AI step into the scheme of things? So the agenda for today is going to be a simple 4-point agenda. Conceptually, what is artificial intelligence? Beyond GoFi, how do we understand artificial intelligence? For those who are wondering what GoFi is, wait for 5 minutes and I'll tell you what it is. And if you're expecting that this is going to be some very, very intense technological term, you'll be surprised. What are the AI applications that have been in published literature? I will give you a brief preview of some conceptual applications that are patented but yet under applications with whatever I can and have the ability to share at this point. And finally, we will discuss about it from a rational perspective on the risks and audits that need to go into any kind of technology that we adapt. I know I have 26 minutes to go, and when my time is up, I will stop wherever I am in the middle of my lecture. So, how do we understand AI conceptually? Probably like this. Is the audio working? Can we test audio again, please? Is it? Nope. If not, I can go ahead with without the audio. But let's not waste time on. That's not going to work. All right, forget about it. Forget about it. All right, so we're going to play. So I'm going to play some of my slides without audio. Now, when I speak about it from a conceptual understanding perspective, this day is again landmark in the history of humankind. All right, 11th May 1997, the invincible Garry Kasparov, who had never lost a grandmaster bout, gets defeated. This is not some great chess player. Who this is nothing but a representative who is representing a supercomputer called Deep Blue. That was the first time that an AI application beat a human champion at sport. And since then, technology and humans have never lived happily ever after. This kind of a friction that we've seen is something that has then percolated to almost every sphere of life. So how do we describe it from a commonplace understanding? Now, an artificial narrow intelligence is an app that you and I use every single day. For example, your Google Maps, all right? The IQ of a Google map is 0, is absolutely 0. If it was to analyze on its own, which is why sometimes it gives us crazy routings, because by itself, the IQ of an application like that, which is a narrow intelligence application, is absolutely 0. Then you've got an artificial general intelligence. Now, this is what mimics what is close to human intelligence. It can reason like how humans can, but cannot give you complex solutions. And then you've got artificial super intelligence. Now, most organizations want to get somewhere short of general intelligence, because if you were to get artificial super intelligence, it would have the total cognitive capacity of the entire humankind, and it can replace almost everything that we do, and it can be a form of intelligence that would be very, very difficult to control. Now, how does this translate into an orthodontic application? All right, somebody like this walks into your clinic. This is -6, -7 millimeters overjet. Now, this patient goes to consultant number 1, who says that the best way to treat you would probably be an orthognathic surgery. This is how we go about our surgery. We will do some compensation. Okay, no, we will not do compensation, Junji-san. We will do surgery first, all right? The modality does not matter, but the solution will finally be orthognathic surgery. Then he says, yeah, this is good, but I really don't want surgery. So, let me seek another opinion. Now, he goes to another orthodontist who says, why do you need to do that? And that other orthodontist is the man who's sitting next to Junji, right? Who says, no, I will treat everything with Invisalign. This can very easily be treated. We'll run some elastics. I'll be able to correct everything with Invisalign. Magic. All right. Now he says, is it possible that I can have 2 such diametrically opposite treatment plans? So what does the patient do? Goes to the third orthodontist. Now, the third orthodontist says, yeah, Invisalign is good. I can probably treat you with it, but we will need some bone anchorage as well. So, we're reaching somewhere middle, and you probably might not need surgery. The patient says, all right, but some relative of mine said that there is another doctor who's good enough. Let me go and ask for another opinion. So he says, all right. Now he goes to a fourth doctor who says, well, why do you need aligners? I can treat you. Yes, TADS is good, but I can treat you with a fixed appliance. And then he says, oh man, this is now getting confusing. So now he makes another choice. He says, okay, I'll go to the fifth one. Now he goes to the fifth one who says, why do you need TADS? Why do you need aligners? Why do you need surgeries? I will just knock 2 premolars off in the lowers and I'll be able to correct you. Now, imagine yourself, not as a professional, as that patient or that patient's parent. Which specialty in healthcare will give you 5 different modalities of skinning the same cat? What does this do in the patient's eyes? Actually reduces trust in a professional opinion, and very often what happens is when multiple alternatives are presented to patients, treatment is often deferred or probably never carried out. All right. Now, when the patient is at this kind of a decision-making crossroads, the clinician himself needs a validated system to make a decision. That's where AI can choose to be and prove to be potentially in future a great tool. Now, you've got different input variables that go in, whether it's your options, pragmatism, what is the cost versus risk assessment, clinician's choice, what is the best available assessment data outcome. Now, today, we heard an excellent lecture on whether you extract 2 premolars or 1 premolar and what is the stability outcome on each of them. We've got that in peer-reviewed published literature. So decision-making has to come rather than from emotion based on the evidence that it does exist. And finally, you live in an era of patient autonomy. Gone are the days when, I could tell somebody that, okay, this is my treatment plan. If you don't want it, walk out of the door. Those days don't exist anymore because ultimately the seeker is the decision maker. So it's only at this point that AI can serve to be a great decision-making tool. Now, before we ask, what is it that makes computers intelligent? Because AI, simply defined, is computer technology that mimics human technology. Let's first answer a question as to what is it that makes humans intelligent? Why is it that we are at the top of the species chain? Because you and I can move around. We've got motor control, that's robotics. That's how robotics will mimic it. We can look at each other and understand who this person is and who that person is, and this person is different from that. That is your computer vision. And finally, we can speak in a language that each person comprehends. That is natural language processing. This is exactly what your AI tries to replicate. But unfortunately, in human healthcare, all roads don't lead to Rome. So AI is, in the conventional sense, is not new to orthodontics. Way back in 1980s, you did have video cephalometric softwares that were introduced. Those were the earliest precursors of AI. Today, the applications involve another area of technology which is known as machine learning. And this is what we speak about when we go beyond GoFi. Now, for the suspense to get over, ladies and gentlemen, GoFi is nothing but good old-fashioned artificial intelligence. That was what GoFi means. But the orthodontics of today and the AI applications are way beyond them. It's just like when we solder in orthodontics, the term that ideally should be used is brazing and not soldering. For all orthodontic applications, the term that should be used is machine learning and not AI in its conventional sense. Since videos are not playing, we're going to skip this. So, what is the difference? The difference is that machines have a series of probabilistic models. Well, that's exactly how all education should be. A machine is learning based on the probabilistic tool by itself. We just teach the machine, feed in the big data, and teach it how to learn, and then the algorithm keeps developing itself and improvising. Now, the different categories, to explain it from a very, very simplistic aspect, is you've got a reinforcement learning, unsupervised learning, and a supervised learning. Now, in the reinforcement learning, the teacher has exactly specified what he expects the student to learn. He's supposed to follow that kind of a pattern and then put the blocks where they need to be put. In unsupervised learning, the teacher leaves the student, watches what he does, and then assesses only the outcome at the end of the task. And in supervised learning, which is most of your orthodontic softwares, the automated softwares, they follow this kind of a model, is where you have exactly specified the kind of steps that you want the student to follow. And it's exactly the steps that are laid down, and then the student is going to perform those kind of steps. This is exactly how our softwares function. And the newer model is the deep learning mode, where you can get video images collected and integrate different data. This is where you create neural networks, exactly how a human brain functions. Now, once we've understood this from a theoretical standpoint, the most used application of this is a photo monitoring as far as orthodontics is concerned. And I'll explain this to you. This is one area where we've done a lot of research. So, it's as simple as how the facial feature on the iPhone works. Right now, somebody developed that kind of an app. How did he do it? You collect a large number of data, more than millions of pictures, right? Now, in case of orthodontic applications, the bigger the sample. If today you're sending in AI manuscripts with samples of hundreds, 300, 400, 500, invariably they get rejected. The reason is that's too small a sample that can at best only be a small little pilot model, nothing more than that. You identify elements on those images with the help of experts, then build a neural network with an algorithm. Now, hands up at this stage, this is not your and my job. We work with data scientists to do that. It's important to understand what our core competence is, and then we detect the amount of specificity and sensitivity that you need, detect the spot attributes and how we'd like to score them. So, Let's assume this is a child with his parents, and they've collected all the pictures of the child. All right? Now we go to the next step, and which will be the identification. So you've got videos, pictures, all of them. You basically created an active appearance model of the child where you've got specific landmarks that you've marked. Now, there's a relationship between these landmarks. At any point in time with a small standard error, they're going to be at a certain distance from each other. Once you've done that, you create a formulation of an active appearance model. At this point, you're going to put in your input layers. There will be hidden layers that will do the algorithmic counting. This is what, I think Major General Jain, Field Marshal Jain, all right, made a very, very pertinent point that it's important for us to understand things from a perspective wherein we are not being mathematical about the inputs that we are going. So you put in, the algorithm creates relationships, and then you've got an output layer that comes out. Now, look at how this is applied, all right? So when we come from an application point, now you're going to detect whether the software that you've created can identify the same child. And you look at the percentage accuracy. Simplistically speaking, when the child has a cap on, you'd get only a 70% accuracy. Every headphones is 95% accurate. Otherwise, you'd get a higher accuracy where only the face without any other appendages involved. Sense of deja vu when you use your phones to unlock, this is exactly how this thing works. Now, how do you apply this orthodontically? Aligner patients, fixed appliance patients, between appointments to detect gingival recession and unseat. Now, this has been a huge boon in the pandemic in a lot of countries. Dental monitoring is a huge app that has orthodontic applications where patients are remotely monitored. Whether the patient has broken a bracket, there's an elastic wear, there's an impingement of a palatal expander, or there's a tad that's been covered by tissue. All of these things, based on the algorithmic model, when patients are uploading their pictures at every 15-day intervals, the clinic gets an alert and they are scheduled for emergency appointments. Now you might say, okay, man, yeah, this is all fancy stuff. What does it relate to me in terms of treatment outcomes? Sabar karo, khatam nahi hua hai. We'll come to that. We'll come to that. So you can create this as a consultation device where at the consultation appointment, a patient wants to have a visualization of an in-photo monitoring on how will different kind of braces look on the face. It can be created right on the chair side. This is the paper. This is a purely clinical paper with more than 50 odd clinical applications where patient appointments have actually been reduced or saved because of using a photo monitoring app like this. Seminars in Orthodontics 2021 issue. For people who have institutional access, anybody else who wants a copy of this paper, just email it to me and I'll be happy to send it to you. Now, when we make sense of this kind of a jargon, there are different attributes that go into it. Mathematics is one of them, but only a very small portion. And that exactly is what defines the age of machine learning as we know it. I remember having a very interesting discussion in 2018 with an orthodontic educator. And if we were to put it from a crystal gaze perspective, next year we'll have the new guidelines of the World Federation of Orthodontists on postgraduate orthodontic education. And courses in machine learning will actually be a recommendation on the preclinical syllabus, because almost every orthodontist in the year 2025 onwards will be using some sort of a machine learning app. Now, let's look at some published orthodontic literature on it. So, I know this is again very, very fashionable because all of a sudden, a huge part of the world has already been living it. We are slowly waking up to the fact that everybody needs to have a PhD, all right? So a lot of our orthodontists are now pursuing PhDs. This is relatively new to our country. And suddenly people come up with a requirement that with your PhD, you need to do one systematic review. Ladies and gentlemen, This is probably the biggest bane. Is everybody okay? I will, can I continue? Yep. All right. So the concept of doing a systematic review for everything under the sun is one of the biggest wastage of human resource when it comes to research resources that it exists. If something has prospective literature of 2 or 3 papers, a systematic review is not going to reinvent the wheel. So when I look at it from, and there was one missing link in terms of what can replace a systematic review is a scoping review. And how should you carry out a scoping review? There is a QR code for this paper that was published in the APOS Trends in Orthodontics. Please have a look at it. I'm not going to go into those details. It essentially tends to narrow the bridge between what we know, what we ought to know, and the missing links between the two. So we carried out the first scoping review on artificial intelligence in orthodontics. This was published in Progress in Orthodontics last year. Essentially, the 4 areas where AI has been immensely used in orthodontics is diagnosis, treatment planning, landmark detection, and growth assessment. This is the incipient stages. Now, we are going to go a little beyond that. This is that issue of seminars in ortho, and my editorial in it basically gives us the classification of different kinds of usages of AI as far as orthodontics is concerned. Now, you can look at treatment outcomes of pretty much anything that you've treated. And that's a great, but of course, the first step is creating great data. Once you've got a database, everything can be worked backwards and studied through an algorithm. Diagnostic outcomes. I know a lot of senior professors would find it kind of funny that people are encouraging others to use softwares to detect whether you should extract or non-extract in a given case. I can see the smile on your face, but technology does crazy things sometimes, because my retort to that would at sometimes be that you should have got an orthodontic education then. Automate landmarks, growth assessment, and tooth segmentation. When it comes to creating digital appliances, yes, AI has a huge role to play there. Now, this is the map of AI research that's happening all around the world. We've got a few incipient projects that are coming up in India, and and I find that this can really be more, because wherever you are, there is definitely an institute of technology close to you. Just like you've got to carry out a research project, the engineers also need to carry out a research projects. It's just a question of meeting each other and having the right drink together. That's about it. And a lot of creative ideas will probably flow. Now, what are the different kind of algorithms that are used? Most of them are essentially 4 kinds. Temporary. And ultimately, your workflow will be, you will create an algorithm and then compare it with an expert-based system. So I will quickly run through 5 orthodontic publications which give you a clinical application and some newer concepts that are probably on the horizon. Now, will an AI-dependent diagnostic procedure provide any other information that can otherwise be overlooked? I have 5 minutes. That can otherwise be overlooked in any kind of literature? Well, now let's have a look at this paper by this group from Korea. You do your impressions, integrate it with the 3D scan, you integrate it with the CBCT, and then you realize that there is a transverse deficiency. The same scan is used to make measurements, fabricate the appliance, and evaluate treatment outcomes. Now, similarly, when you need to look at long-term outcomes, now this was a paper that I was pleased to be a part of, which looked at what were the predictors of failures when orthodontic surgery was carried out in the public health network in the United States. I mean, a factor that otherwise would have been overlooked when they looked at a 20-year factors was the fact the year in which the surgery was carried out, was also the joy in which the surgery was carried out. Factors that can otherwise be overlooked is something that technology can catch on to. The next one is even more interesting. All right. Now, this is an app that was built by us for public health referrals in the UAE. So we understood first step was creating a questionnaire for general dentists and pediatric dentists who used to refer patients, is to understand what is their understanding of mixed dentition orthodontics. Once we quantified that, we created an AI-based referral system, and of course, we needed to have a relative correlation of absolute 1. What happened? All right. Then we actually used that prototype in different primary health centers, and finally wanted to evaluate, did the referral pattern at all change? Now, what you see very interestingly is, before using this kind of an application, on an average, you had 1 referral from a general dentist to the specialty clinic, and you had almost 6 references from a pediatric dentist before they were using this kind of an app to direct whether this is the correct time for referral or not. After using the app, the referrals from the general dentist increased 10 times, and the referrals from the pediatric dentist almost became twice, and they were all appropriately timed. You can read more about this in this paper that was published in the same issue of Seminars. And this is another paper by Lorenzo Franchi and his group. Now, prognostic indicators of class 3 growth. What's so new about it? I mean, we all know what are the prognostic indicators. Now, there were 2 different kinds of networks that they tried to study. If you don't understand these words, it's not important. This is computer lingo. People tend to get you confused when they talk about AI with the technical details. It's the outcome that we need that is more important. Now, as orthodontists, the 2 predictors that they found, lower 1 to mandibular plane, or, so if you look at a growing child, lower 1 to mandibular plane, we know about it. What was surprising was the palatal plane to SN plane being such a great predictor of a prognostic class 3. So this is your 6-year-old male, right? Just look at the palatal plane to SN angle, it is 11 degrees. And this is how the child has grown at 21 years of age. Another child, 8 years old male, 13 degrees, and this is how the child has grown. So if the palatal plane to SN is less than 15, out of all the analysis that were carried out for so many years, it took an AI app to be able to pinpoint that as a prognostic factor. In the UNESCO education goals for 2030 are to use intelligent tutoring systems, whether it's in research or preclinical. Now, hats off. This is a picture that Professor Arvind and Sriranga Lakshmi have taken when I visited the Savita Dental College in Chennai. This is a haptic-based learning system. For somebody with minimal dexterity like myself, doing a cavity prep even before I'm wasting a plastic tooth on a typhodont is the intelligent way to train residents in the future. Now, if you're asking me, what is the orthodontic implication of it?
Not running the burr.
Pardon? Oh, that was, yeah. So finally, the audio started to work. Perfect. Very good. But it's time for me to stop. 5 more minutes. The reason is I was allocated 40 minutes. All right. Now, what could be the orthodontic implications of this? An automated wire bender. Now, this is an automated wire bender. You put in a straight wire, a robotic wire bender. What do you mean by the clinical application of it? 4 minutes. Your bent bonded retainers are actually churned out in exactly 4 minutes. And this is today not a very expensive purchase. It's a $20,000 machine only. And the price of this kind of technology will come down as time goes along. Now, this is something that is really, this is Professor Faronetta and his group. The analogy of how you can use a haptic in orthodontic training here is you've got a photo monitoring app. You've decided what is going to be your prescription at the end of treatment. You're trying to position a bracket with the app at a specific distance. And the app will give you a red or a green to tell the resident whether he's placing the bracket at the right place on the typhodont or not. Now, this is only the beginning. This could have clinical implications in the future, and this should be out there in the market probably in early next year. So, from the orthodontic application perspective, the party, ladies and gentlemen, has only just begun. Now, with any great technology, you've also got to have, like they say, like Spider-Man says, with great power comes great responsibility. Now, when Edison invited the light bulb, people thought, people could die because of that. So as we unravel artificial intelligence today, I am directed to this excellent paper that was published in the Journal of the American Medical Association. Now, these could be the outcomes when you use a software to make a diagnostic decision. All right? I want you to focus on the oranges. If you follow it, you have an injury, but there is no liability, you're probably okay. You follow it or you don't follow it, but there is an injury and a liability, who takes responsibility? Can you say the app told me to do so? I mean, that's the big question that we need to address. And this has been very interestingly described in this book that was published called Weapons of Math Destruction. And the example that was given is of this high school teacher who was laid off in 2008 because somebody in the education department decided to use an algorithm to track the performance of teachers. They didn't take into account the other softer elements, like she was teaching a class of weak students. Those students would have otherwise never performed if she was not their teacher. She was laid off her job, finally got jobs in one of the most private schools, and this has been a case study on retraction of a lot of algorithms that were used to track teacher performances. So this, of course, received great amount of press publicity in Washington because statisticians do count out exceptions. An algorithm cannot do that by itself. And with this comes the Hippocratic oath for data scientists who are using AI in medicine, that I will remember that I didn't make the world and it doesn't satisfy all my equations. I will not use it to estimate all values boldly. I will never sacrifice reality for elegance without explaining why I've done so. And I will not give people false comforts about any model whose accuracy I myself don't understand, and understand that this can have enormous benefits on society. There are guidelines for how authors should be writing their AI-based manuscripts. First, is it digital orthodontist? Second, are all model sets validated at every level? Have you described material and methods, and are the limitations of your model described? Now, when I say that a workflow needs to be described, this is what I mean. This was a paper that we published in the seminars issue. Every single procedure in the world of AI needs to have a workflow that is clearly defined with clinical application. And then there is regulatory framework for it. Every country has to develop their own. Now, I said I will come back to you with when we use dental monitoring on two different cohorts. One group of patients actually finished their aligner treatment much faster, the one that was using the monitoring app compared to the ones who didn't, because they got to their refinements much, much faster. So there was a significant clinical difference. But finally, as I end, there was something that I wrote in the editorial, and that was that when you sprinkle the term AI, it's great for an investor pitch. People give you loads of money because the healthcare industry with AI is actually going to grow 5-fold in the next 4 years. The big problem here is accountability. You probably need to look at an algorithm board of orthodontics as well, because nobody makes public the data that went into creation of an algorithm. And that's supposed to be a trade secret, which in healthcare is the biggest problem. So, should we be using AI? Of course. Why? Because without it, we'd be like this. This was an editorial that we wrote for seminars which speaks about this bridge. This is an excellent bridge with Japanese technology that was built for Honduras. All right? Because this place used to have a lot of cyclones. But finally, once they got a cyclone, and the entire course of the river changed. So now you had a great bridge standing over barren land. Absolutely superb bridge, over nothing, with nowhere to go. Conventional skills, what we think are conventional, can probably lead us here if we do not adapt to technology. So a quick recap. We tried to demystify the AI jargon. We understood what is machine learning and how that is contemporary. We did finally understand the concept of diagnostics, referral, monitoring, education, and outcome assessment. And finally, question whether can evidence be applied to algorithms. The big question is, will AI take over human jobs? If the video plays, I will leave you with this. This will answer
For
this question.
starters, what should I call you?
I'm Chloe. And you, what's your name?
Oh, John. My name is John.
Delighted to meet you, John.
Could you tell us a little about yourself and what you can do, Chloe?
Of course. I'm the first personal assistant built by CyberLife. I take care of most everyday tasks like cooking, housework, or managing your appointments, for example.
And I understand you're the first android to have passed the Turing test. Could you tell us a little more about that?
I really didn't do much, you know. I just spoke with a few humans to see if they could tell the difference between me and a real person. It was a really interesting experience.
But this is the first time in history that man has created a machine more intelligent than himself. I gather your brain can perform several billion operations per second. Is that right?
Absolutely. But I only exist thanks to the intelligence of the humans who designed me. And, you know, they have something I could never have.
Really? What's that?
A soul.
A soul, ladies and gentlemen, in orthodontic care will never just be an algorithm. So let nobody fool you ever by saying that technology alone will ever be able to treat patients that seek treatment with us. Thank you so much. It's been an absolute pleasure and an honor and a homecoming for me to come to Bharati Vidyapeeth. So the title of this lecture was AI-driven orthodontic care. You know, is it a quest for utopia? So this is me over the years, all right? Me over the years. I know, Junji-san, you have 19 lectures at the AAO. I have only 10. I have 9 more years to go, all right? But utopia for me is none of this. Is this a six-pack ab? And I hope when I come back, I will come with this. Thank you so much, ladies and gentlemen. It's been an absolute honor.
Thank you, Dr. Niklesh Vaid, for the wonderful presentation and insightful knowledge on AI. Thank you very much. We will not be taking any further questions.
May I please ask the chairpersons, Dr. Krishna Naik sir, Dr. Gurkirat Singh, to please felicitate our speaker, Dr. Niklesh Vaid. May I now invite Dr. Srirang Joshi sir to please felicitate our chairpersons. As usual. No, you're too good. Sorry. We now have IBO promotion by our IBO chairman, Dr. Varivel Kumar sir.
A very hello. Yes. Hello. Fine. A very good morning to all of you. On behalf of the Indian Board of Orthodontics and the Board of Directors, I would like to welcome all of you for this 56th IOC in this great city, Pune. And I'm here to talk to you for 10 minutes about the board and how the board is giving the certification process to as a promotional program. So the road to board certification and our motto we want to tell you is never give up. So as we understand, every successful person has his own failure story, has his one maybe a failure in school or dropout student, or maybe a different than others. But the fact is, the most successful persons never gave up on their dreams. So great success is built on failure, frustration, and even catastrophe. So what is a board certification? Board certification is an extra step taken to demonstrate that we know the latest advancement and we strive hard to achieve excellence in orthodontics. The board certified orthodontists demonstrate their desire to practice at the top of the profession and deliver high quality care for their patients. So they never give up until they achieve the goals. So the goal of Indian Board of Orthodontics is to establish and maintain the highest standards of clinical excellence in orthodontics. One of the ways to accomplish this is through the board certification process. At the 25th annual general body meeting of the Indian Orthodontic Society at Mumbai in 1990, a formal proposal was set up to asking for an autonomous independent board was made by the executive committee. The members of the AGM unanimously accepted. The constitution of the board was presented at the AGM of the IOS in 1998 at Manipal. With this, an autonomous board was formed. The history is a thought process which started in the year 1990, proposed in 1998, constituted as autonomous independent board under the aegis of IOS in 1999. And this is the first specialty board to be so constituted. So they are the first set of directors, Dr. Samraj sir, Dr. Joe Vahis, Dr. Karad, Dr. Jayde sir, Dr. Jodhindra Kumar, and Dr. Girish Karantikar. And at this point, I would like to recognize the efforts and contributions of then President Dr. Asha Verma in 1990, along with Dr. Samraj, played a very important role in the formation of our board. So the objective of the board intends to stimulate the spirit of self-improvement among teachers, practitioners, and students of orthodontics. The board encourages continued professional review, elevation of standards of education and treatment in orthodontics throughout one's professional career. The board certification is intended as a benchmark of the level of professional attainment. The board is established on the premise that it shall examine the applicants. If they are found proficient, shall issue a certificate of excellence to those who meet the standards established by the board. So it's a three-step certification process. First is board applicant, then you become board eligible, third is board certified. Phase one is application. The applicant's advanced orthodontic education credentials are reviewed and they will be called as board applicant. Phase two is written examination, which assesses the candidate's knowledge of basic science and clinical orthodontics. MCQ type of examination, a candidate who has successfully completed the written examination of the board shall be designed board eligible. Phase three is a clinical examination consisting of oral examination and evaluation of candidates' 5 case reports. 5 categories of cases as per the directives should be treated by the candidates himself or herself. On successful completion of a case presentation and oral examination, the candidate shall become diplomate of Indian Board of Orthodontics and shall be designated as board certified. So the phase 2 examination, eligibility criteria, postgraduate students, they have to be a student life member of Indian Orthodontic Society who have registered to orthodontic postgraduate program and have completed 12 months of training, and orthodontists who have passed their MDS examination after 31st December 1998 are eligible. The examination pattern of the phase 2 consists of multiple choice questions. Total number of questions are 400. Paper 1, 200 questions, and paper 2 is also 200 questions. The duration of each paper is 2.5 hours. Phase 3 examination, those orthodontists, but must be a life member of Indian Orthodontic Society, who have passed MDS examination before 31st December 1988, can take the phase 3 examination directly. They need not go through the phase 2 examination. Without requiring phase 2 examination, they can appear for phase 3. And also, a candidate who is board eligible may not be able to take the phase. That's a postgraduate students who finish the phase 2 during their post-graduation cannot appear for the phase 3 for 5 years. They can appear after 5 years of her receiving the post-graduation degree. So the requirement for phase 3 is 5 categories of cases have to be submitted for clinical examination. Category 1, selected clinical case depicting crowding more than 5 mm, managed by extraction of one tooth from each arch. Category 2, selected case with angle A and B more than 5 degrees. Case should exhibit efforts taken to correct the sagittal discrepancy non-surgically. Basically, this category requires correction using orthopedic. Category 3, selected transverse discrepancy, complete unilateral or bilateral crossbite, or vertical discrepancy with FMA greater than 35 degrees or less than 20 degrees. Category 4 and 5 are selected cases of candidate choice with degree of difficulty very high. At least one case above 5 should be a case where all 4 extractions of first premolars have to be done. And only one case among the above 5 cases can be a surgical case treated with orthognathic surgery. More than one case, surgical case is not permitted. And all your cases will be examined under these criteria. An aggregate of 150 will give you a beautiful status and a certificate, Diplomate of Indian Board of Orthodontics, as you see on this slide. So in conclusion, what I would like to tell you is the board promotes, and the board certification process, once you attain, will give you a earned self-esteem. It makes you a better clinician than yesterday yourself. And the board certification will teach you how never to give up. So the capacity to learn is a gift. The ability to learn is a skill, but willingness to learn is a choice. So you have to make your own choice, and your choice makes what you are. I have to be better than yesterday myself is our motto. So our mission is to make the Indian Board of Orthodontics as one of the global leaders on par to any other international organization. In an effort to globalize, we have taken our board promotional activities outside India. We have gone to Dubai, and also we have gone to Kuwait, and we have submitted a request to these countries' health authorities to recognize our board in these countries. Once it is done, probably our orthodontists who aspire to migrate to these countries will have an advantage, just like if you have an MAT or any other international degree. They will be considered on a priority basis, and probably the salaries also will be different from others. So that's our mission, and we are working towards that. So they are the current board of directors: Dr. Ashwin Jaj, Dr. Raja Ganesh, Dr. Salil, and Dr. Malaram Manohar. I'm thankful to them for all their support during this 1 year. So in conclusion, I would like to just say, failure increases knowledge. Therefore, I would rather try and fail than not try at all. So you all must try the board. All these gentlemen you see on the slide are people who have been very successful, but they all failed and then they became successful. Once the light bulb invention was Edison's. So when he invented the light bulb, he invented after 1,000 failures. So when he was asked about it, he said, I did not fail 1,000 times. The light bulb was an invention with 1,000 steps. And he also said, now I know how the 1,000 ways how it cannot make the light bulb. So become board certified, feel proud of yourself. It's a life-changing experience. It has changed my life, and I'm sure it will change yours. So thank you very much. On behalf of the Indian Board of Orthodontics, I would like to take this opportunity to thank the organizing committee, scientific committee chairman, and the IOS secretary and president for supporting us. Thank you very much.
Thank you, sir. I would now like to invite Dr. Girish Karandikar, sir, to give the iOS oration. Our chairperson, President, Indian Orthodontic Society, Dr. Sri Krishna Chalsani, to please come up on stage. It's not working.
Hello, hello, hello,
Hello, hello. Check one.
hello, hello. Thanks. Yeah, I go, sir. On that side. No, no, no. On that side.
Dear friends and delegates, everybody, welcome to the oration today. Dr. Girish Karandikar is going to lead the oration. I would like to say a few lines about Dr. Girish Karandikar. Dr. Girish has done his BDS 1976, MDS 1978 from Nair Dental, Bombay. He is a diplomat of Indian Board of Orthodontics, first died 1999. He has MRtho in 2000 from Royal College of Surgeons, Edinburgh. He was the best student of college BDS graduating class of 1976, Nair Dental. Champion table tennis, singles and doubles. Played 5 sports. He was the captain of 4 teams. He has widely read, published, awarded for presentations and clinical expertise at home and overseas. He made learning interesting for BDS, MDS students over 4 decades of iOS events like courses, CDE, PG students conventions, etc. and informal teaching also. He is the first Indian clinician invited to lecture at AAO, Australian Society of Orthodontists, North American Society of Study of Orthodontics, Australian Beg Orthodontic Society. He has taught CE courses in USA and guest lectured widely at overseas universities. He is the first Indian conferred honorary membership by Overseas Orthodontic Society, Taiwan. He was awarded by the Indian head office as the outstanding teacher, recipient of Dr. K. Chemistry's Scroll of Award. The stage is yours, Dr. Girish.
Thank you. Thank you, Mr. President, sir, for your kind words of introduction. There seems to be a glitch with the laptop being connected, so kindly indulge a little bit on the tech wizards trying to set it up. I'm absolutely a dumbo in many matters, and technology is one of them. So I have to be at their mercy to be able to hook me up on the laptop. So it's a privilege and an honor to be here. And although trying to put people to sleep has been my vocation over the last small matter of 46 years, this is more or less, if I take a cricketing analogy, you have 3 types of games. You have the 2020, which is the hot stuff running now. You have the limited over games, 50 overs, and then you have the test matches. To me, 1 hour presentations, aka orations, are like test matches. So far, I've had the opportunity of lecturing on the IIS forum, yes, but it has never been for a test match. So as I'm announcing more or less my retirement, I'm getting the honor of representing iOS in a test match, which, like Mike Hussey or even David Steele from UK, is really good. Oh, we are on. All right. Am I audible everywhere? Thank you. So the title of my talk was, and I have actually met them, is rather. And you might be worrying as to what this oration is all about, or wondering what the oration is all about. And it doesn't really take a Sherlock Holmes or an Hercule Poirot, which were sired by the two right at the bottom, or our own Indian Vyomkesh Bakshi, right? But What I'm going to do here today is to try to take you back in history and try and tell you as to how these members who are no more and have passed on have made a huge change in the way in which the society has grown from 7 members to almost 10,000 members, and how the science evolved from just 2 dental colleges that started way back in the 50s, late 50s, to 266 colleges, which right now are producing orthodontists. So we're just trying to do that. Now, reminiscing or recapitulating is pretty much the order of the day when you are somewhere up the tree and there is no further way to go, which is where I find myself in. So as I am at this stage, that's my twin, by the way, and I'm right there, what I find is that it's natural for my thoughts to wander. And I'll be looking back today in delivering this coveted oration with a perspective, like I told you, of a debut test match. And I'm going to talk about all those who have made a lasting impressions on my heart in doing what they did before they passed on. And I will speak of their help given to iOS and to the science of orthodontics that eventualized the robust health that we enjoy today. I mean, health of the profession. And their footprints in sand that were created, we are happy to tread today and feel that we are tall because we are walking or we are standing on shoulders of giants. That's what it is all about. I'm sure that my thoughts hopefully will be a little more mature than what my past actions might have been in that point in time. This is the best my family could do to try to make me a little more mature over the last 5 decades. So despite starting out in the early days more like a combination of Forrest Gump or even Richard Jewell, what I did do was make huge mistakes for quite some time in early part of my life, which I'm going to share with you a bit. But I still ended up having had the love and friendship of so many of you and the privilege of delivering this lovely oration. So I'm very thankful for that. Now, I expect that I'll be able to transcend to a little different level today and therefore be in a position to try and take you along with it at least part of the way. By the way, you have set up my computer so that audio file as well as video file will play there, correct? I told you. If not, please do that. I'm taking a time out, sir. So what I'm going to talk about is the contribution of all these people. They were the Magnificent Seven which got started. Our society kick-started in way back in 1964. Actually, the precursor was something which started 65 actually. 63 was the time that they got together and started a study group. And nobody knows much about this then young man. I can probably talk about this person for about half an hour, but today is not the time. But I'll be still giving you a glimpse of the past. So how these all doyens put us on the right path. I'll be talking about some teachers of my time whom I came in close contact with, as you can see there, and some seniors as well as buddies of mine in the profession. More importantly, from the local perspective, my friend Ravi Sabre, who hails from this university, and he was a founder HOD in this particular college. So if we talk about governance of iOS, ladies and gentlemen, the most important fact for all of us to remember is it all started in Bombay. Mumbai, as we call it today, but then it was called as Bombay. That was a table of governance, and all of these people, turn by turn, they were the people who had the most important seats because they were the ones who were dedicated. The whole affairs of the iOS ran from the HOD room of Nair Hospital Dental College. Then, of course, there were other people like Dr. Sheikh who was absolutely a towering presence, and everybody had a perfect trust in each other's ability to contribute, and that's how we started everything. Then, of course, after these, no major decisions were taken by Dr. H.D. Merchant or Dr. Prem Prakash, obviously, unless they were asked. And that's how we started. Then later on came the Young Turks, the then Young Turks, M.K. Prakash and Vinod Verma. Dr. Samraj was identified by Dr. Naishat Parikh as a person with tremendous capabilities in terms of management. He joined, and then all these people, Dr. R.S. Nanda, Dr. D.S. Gupta, D.N. Kapoor, Dr. V. Surendra Shetty, later Dr. Ashima Malethan Madam, and all these dignitaries here, they joined in too. I'm going to take you through what they did for us. So let's talk a little bit about how this MDS ortho stuff began, right? So this started way back in 59 to 61 was the first batch which came through. It came through at simultaneously at Nair Hospital Dental College and Government Dental College, which was CEM Dental College in those days, but for reasons of connecting better, we'll call it GDC, that is Government Dental College from Bombay. Dr. H.D. Merchant was the head of the department, and here Dr. K.L. Shori, who was the dean, and Dr. V.S. Iyer, they were the people who were the teachers. Dr. V.S. Iyer was a teacher par excellence, who unfortunately, because of some issues, interpersonal issues, had to leave after a year, and he chose to go back. And then the GDC graduates were left in limbo. They were transferred to Nair. And then they did their MDS from Nair. That is what the history was. Let me see if this gadget works. Dr. Modi, Dr. Naishat Parikh, and Dr. M.K. Prakash began their associations at different point in time, and the department soon identified as Dr. Modi's department, because he was the longest serving HOD of our generation. The next department that came through, I'm okay, thanks, was KGMC Lucknow. What happened? Yeah, which began in 65 and not in 64, as it is mentioned in some places. It began in 64. The reason I am saying so with impunity is that I have taken the trouble of talking to Dr. Pradeep Jaina, who was a wealth of information, and these were the people who started the program, Dr. R.S. Nanda and Dr. D.S. Gupta, with Ravi Nanda, Pradeep Jaina, and Dr. Malhotra and Dr. T.S. Roy as the first bunch of students, out of which only 2 passed in the first shot. GDC Bangalore came next in 65, but not in 66, as it is mentioned at places. This is basically because though the program began in 65, they appeared and passed only in 68. So if you just look at the date that 68 they passed out, you feel that they started in 66. They know they started in 65. The first head of the department was Dr. Rajendra Prasad, who did his LDSC, BDS and MDS from Bombay Nair. Then he went over to GDC Bangalore. Before him, Dr. Mohandas Bhatt had already finished and gone, and he was working there. But for some reason, as happens usually, he was beaten to the post by Dr. Rajendra Prasad, and he became the first HOD. When that happened, it killed something inside the heart of Dr. Bhatt. He decided to step away and immerse himself headlong into completely another branch of community dentistry and started that department for GDC Bangalore, the first department to start. He also went to 2 different continents later and started departments in preventive dentistry, as well as did PhD in various many things. Okay, he was quite a person who was lost to Indian Orthodontic Society, and probably I feel that he was the only person who could hold a candle to Dr. H.S. Sheikh. GDC Ahmedabad, under the tutelage of Dr. M.R. Joshi, who was a second batch student of GDC Bombay, and that's what I mean by G Nair, that is started out in GDC, then came to Nair and passed out through Nair. That's how it went by. And those were the first batch students. The next department to start after Ahmedabad were 2 departments, Trivandrum GDC in 72 and not in 69. The first student was Dr. Keshav Bhatt, under the tutelage of Dr. P.P. Jacob sir and Dr. Haridas, who happened to come to Nair for exams. And of course, Manipal, which was the first private dental college to begin a program under Dr. S.L. Shori, who had by that time shifted from GDC to this place. and Dr. P.V. Rao. And the first batch of students were Dr. Surendra Shetty sir, as well as Dr. Shamla madam, who later went to work with Dr. S. Rangachari in, I think, Savita. GDC Madras, as it used to be called then, was the next program which began. That was with the contemporaries, Dr. Kannappan and Dr. Rangachari. Dr. Kannappan was senior by a year to Dr. Rangachari in service. So after MDS, he became the head of the department, and he started under his tutelage the first department, and Dr. Venkatraman, Dr. Julius, and Ravindran were the first batch students. Dr. Sheshadri began the program in Hyderabad in 80 and not in 79, as is confirmed by Dr. Hariprasad Rao, who was the first batch student, as well as Dr. G.C. Chandrasekhar, who was a few years junior to him. Dr. Pushpa Hazare was unique. She was my classmate in MDS, but more evolved than me, because she is 1 year elder to me, and passed out in 75, and these were the first batch students, because Dr. Deshkar was a BDS lecturer under Pushpa Hazare madam, but because it was a government institution and GDC, and with 3 seats, despite the fact that madam was the only postgraduate teacher at that time. That is how history is. And then came the AIMS with Dr. Sher Singh Sidhu sir, SS Sidhu sir getting on, and Rupa Raghavan was the first batch student of Sidhu sir. And then DCI stepped in and began in 93 a 3-year program which was uniform across the country. Till then, only AIMS had a 3-year MDS program, and no other place had a 3-year program. I think it interested me huge. I thought it might interest some of you at least a little bit. So he was a founder president of iOS in 65 to 67. We had a 2-year term for the first 5 or 6, 10 years actually, five terms. And he fathered orthodontics in India in no uncertain manner. Though LDSC began in R. Ahmed Dental College in 20, and then it became from a 2-year program to a 3-year program in 22, and then a 4-year program in 36, 37. It started LDSC in Nair in 33 and GDC in 44 at Bombay. BDS started first time in India in 1957 at Nair Dental. That is the history of what education is, so far as we are concerned. Sir went and trained in Germany for a DMD in the 30s under Gustav Korkos. Those of you who remember our 3D calipers and orthometer orthocrosses will remember this name. At least I do. Lectures began in 33, and as a formal subject, the subject was introduced in 34, 35. He was a very kind-hearted and soft-spoken person. I have had interactions with him for at least 6, 7 years, despite him liking Hitler's disciplinarian ways. But he was very kind-hearted. He got Dr. Stahl from Heidelberg University to Nair Dental in those days as a visiting teacher. And he was a HOD, as is said, for a long time, and a dean after Dr. V.M. Desai he was a founder dean. More interested in administration towards the later part of life, and Dr. Modi then kicked on for the period that you will see later. He was academician to the core and the first editor of JIOS from 68 to 74. He was the architect of the iOS constitution with Dr. Naishat Parikh's help, and the first person who set the ball rolling. He won the inaugural Dentist of the Year award way back in 76 from Pierre Fauchard Academy. So he's quite a distinguished gentleman. And he made functional jaw orthopedics and active removal appliances a force to reckon with. And his legacy is still being carried out because no exam is complete unless you have a functional exam component. So you can figure that out from what time to what time we are. To note, this is Dr. H.D. Merchant, that is Dr. Sheikh, that is my boss, Dr. Modi. This is Dr. Prem Prakash. Can you believe this? Cassius Clay-like looking person. This is Dr. M.K. Prakash, right? Good old days. And there should be somewhere Dr. S.B. Shetty, that's Dr. Jaleli, that's Dr. M.R. Joshi, that's V.O. Sanghvi, that's Dr. Naishat Parikh without a bow tie and a tie or a pipe, and that's Dr. Madam Daksha Chitre. This is quite another group, and you can see that person with a funny looking hairstyle. That's me. I am in first year. This happened in Bombay in CCI, the cons. And that's Dr. Modi again. Very difficult to get these pictures, but somehow I pursued and got to the beg appliance and stayed till he stopped practice. He was our first IBO examiner along with Dr. Rangachari sir in the 99 conference at Bangalore, and that's Dr. Prem Prakash sitting with Dr. Jaidev, who happened to be the first chairman, and that's a young Jyotindra Kumar and a younger me. So he was a trendsetter in many things in terms of charges. You can't believe the kind of money that he would demand, and he would get paid handsomely. His patients were all royalty, and he charged about 15 to 20 times more than any person could imagine. Okay, so I'm not letting out the figure. Not that he's going to be hounded by the IT people, but still, there's no reason. So his clientele was who's who. He was masterful in office design, and a lot of doctors used to come, and he was a very great investment advisor. And the only person I can think of is Dr. Pradeep Jaina. If I had a chance to sit near their feet and learn, I would not have worked for as long as I needed to work to make a living and set up my family. So he invested in pleasant, efficient, and well-paid staff being employed. He was very open and upfront about fees for doctors. He never, ever treated any person for free. He upfront, the first visit, he would say that, okay, you're a doctor, I'll give you this much discount, these are my charges, pay me right now, sort of. He never went for that 500 rupees or 200 rupees kind of a regime that many of us go through. He wrote detailed periodic letters to patients and family on all aspects to explain facts. I've had a chance to meet him over at least about 10 years and had personal chats with him. So he sent personally signed letters, I know, because some were given by my patients' mothers to me saying that this is how he did it. So I know. He was the one who initiated, kick-started the program as twice a weekly person stepping away from practice and coming and teaching the students there. And he worked with Dr. Shori, and he gave course material from Beck file, demonstrated wire bending when he came back after taking a Beck course. And in those days of non-disposables, he used to use tape on fingers as gloves and throw it after every patient, and used to use toothpick for bonding as, you know, eco-friendly kind of a thing. And all this he would demonstrate to those PGs who wanted to go, as my friend Vaishali tells me. She was lucky from GDC to go and see his work. I was not. And he visited Pune for quite some time as a consultant, but with a setup of having an assistant and a lab technician to be in tow with him. So that was the kind of a man that he was. He was very helpful, and he secured admissions through only one telephone call for Dr. Prakash Lulla and for Navroz Kotwal, and gave correct advice to Hema Kapadia to be the first pedodontist practicing in the entire country by telling her there is nobody, there is a huge vacuum, do this, don't do ortho or don't do any other subject. That's how he was. He was very, very, very helpful person. This is my boss. I wish I had a chance to say so many things to him today. When I go, wherever I go, I will and meet him after this world, I'll probably say so. That, well, these are his normal, parameters in terms of academics. And he was a HOD for N number of years. His wishes held sway in iOS forever. From 64 to 94, there was nothing which moved unless Dr. Modi has said yes to it. Not that he opposed things, but he had a unique way of working, and he made sure that he got everybody along like nobody else can and nobody else will in iOS. He was the liveliest founder member who knew the pulse of the people. He led by example and spent for others' enjoyments. He was a management guru, and he recognized and nurtured talent as he took on Dr. M.K. Prakash from GDC and gave him a free run, and that's how he grew. And many of us who are here today is because of MK. Protective and supportive, and rarely got angry. And he was the king of good times, and he unshackled minds like few did. So when he was our chairman, and for 2 years in student association, so I learned to know the pleasure of working for others' benefit. And he was instrumental in leading us to make some charity shows and collect money so we could sort of realize our dreams as students association committee members. He was an avid sports fan, and along with these two gentlemen, Dr. Appa Kher, VM Kher, who had the license to practice in Japan, USA, and India, conservative man, and Dr. Kali Kapadia, They used to take us after cricket games to places and feed us with all kinds of stuff, including amber-colored liquids in chilled glasses. And we had fun. We had great fun. This is the younger version of Sanjeev Shevde, my friend, who's now, like me, balding a bit. So how do I say that he was, and how do I prove it to you that he was a king of good times? Bear with me. So this was Lucknow conference. I don't know how many of you were there at that particular conference way back, and the local organizing committee had kept a program. You know what is the USP of Lucknow? Mujras. You know what Mujra dances are? So one evening they took us for Mujra dances, and we were sitting there, and most of the people in the audience were sitting there as if they are at a condolence meeting. They didn't know what to do because all the bosses were there. So how can you enjoy, sort of, And then this lady comes along. And she starts grooving. Does it sound a bell? Is this a familiar song? So Dr. Modi gets up and, like Amitabh Bachchan, puts on a cap and starts dancing there along with this babe. And then the ice is broken and everybody starts. I remember Dr. Vinod Verma and all this. They were young. I mean, I was even younger, but they were the young Turks of that era. And if he was there, he would probably corroborate my statement that that was Dr. Modi. That was his magic. He even made our train journeys memorable because we didn't have the wherewithal to fly in those days. We used to go by second class, or we used to call it third class in those days. Sleeper compartments, non-air conditioned, and the coaches used to be wooden coaches with no padding. Remember that, right? But he would not prefer VIP treatment in first class, although he was booked there. He would come and sit with us. And his magic was that along the train route, every place the train would halt, he would know somebody. So somebody would come with baskets and even ice for us and glasses, and made sure that we had a great time with mood elevators of the liquid kind. So we got spiritual only because of Dr. Modi, sir. So he traveled Janta class with us. He used to sit there and chat with us. Dr. Parikh, Dr. Prakash would not come there and sit with us more often than not. A cursory 5, 10, 15 minutes was fine. But sir stayed there and cracked joke with us, and he was the soul of the party. So there was no hardship because everything was made and we had a great rollicking party. So that was the power of Dr. Modi, even those things. So he had the ability to forgive and forget and move on, and didn't carry past baggage. That was his greatest strength. And a lot of us carry past baggage into our lives and make our life unnecessarily troubled. So he ran a very tight ship, as it is called, and students were a disciplined lot and had abundant and best imported materials. And people used to come from all over the place to look at our library, departmental library, and our stores, the kind of materials that we had in those days. He relegated the work for staff very well. We had multiple disciplines like removable active appliances. We have done maybe 50 to 60 cases of 4-4 extractions, first premolar extractions with removable appliances in those days. We were encouraged to put out at least one case with removable appliance for sure amongst the 5 cases. We would not be allowed to appear otherwise. And we had to have 1 cases treated by edgewise, the Jarabek component of it, and then whatever cases you wanted. So he ensured that we had a very structured academics along with Dr. Naishat Parikh, and we had seminars, case presentation in those days, the importance of cephalometrics, photographs, immaculate records. Some of it I took into my life and did a little bit to be able to support myself later and to be tolerated by some of my friends. But what I did not do at that point in time is all these things I did not do. I did not mind my business. I should not have really voiced unnecessary thoughts, made needless comparison between techniques, allowing others to quote me wrongly to further their careers, using me as a doormat. That's my fault, not their fault. Who doesn't do it? And seemingly interfering in departmental affairs, and not hitting the signs and teaching UGs and stuff like that, which I should have done only after checking with him and taking his permission first. So I didn't do that, but he still did forgive me. That was his USP. So if you think of inseparables across, I swing with sports, and they're a part of my life. So you think of the limerick, ashes to ashes, dust to dust. If Thomo don't get ya, Lily must. So this was the power of these, and then the inseparable doubles combinations in tennis with their trophies that they won, including Mac the Mouth, McEnroe. These are some of the ones because, I mean, although I can't sing or play music, I really like music. So these are some of the immortals from music, not necessarily these. And then I dig into comics. So you remember Lothar and Mandrake and Obelix and Asterix and Batman and Robin. We had some fantastic pairs in orthodontics in those days. And what are those? Dr. Modi sir and Dr. Parikh sir, who I never, ever saw them disagree on anything. Anything. I don't know much about them, but I do know a fair bit about them, that they were very fair people, especially for guests when they arrived, and only the students would know. But I'm pretty sure that they have great respect for these teachers as well. And likewise, they were Dr. Surendra Shetty and Dr. Subraya Mogra. So this was a landmark 1-week course which was put out at Sir's College, Surendra Shetty Sir's College, and these two initiated it, and the Australian Beck Society had sent all these people whom I became friends later with. They were amazing people, and this was a great event, and so was Surendra Shetty Sir, magnanimous enough to take the boards despite being so senior. As you can see, these are people who are going to be receiving the certificates in the same batch later. And also, he put the seat of learning for postgraduates that you enjoy today, which was the first iOS PG convention. And these were the faculty. That's Dr. Prakash Lulla, by the way. You won't see too many pictures of him because he's not very regular. And NRK Krishna was one of the few people who carried pink from those days in the most graceful manner, and continues to do so, I guess. So founder, secretary, and treasurer was Dr. Naishad Parikh, my boss. He was my guide and expert in administration matters and constitution for both IDA and iOS. He was unique that he was a president of All India IDA as well as Indian Orthodontic Society at the same time between that tenure. I don't think there is anybody who has done that so far. He used to be involved with Pierre Pochard Academy and then instilled all these things, virtues, which are normal, but but what we used to hate was his angulator called Rampuri bias that he used to use for, judging the symmetry of study models and throw them from every window that was possible to be thrown. And it was, really, really sad for us. So the greatest influence that I had during my PG days were these people that they're staring at you. So you have known about them. You haven't heard me talk about him. Dr. Bhaktani madam was like the agony aunt for us, during the entire term. And Dr. Anil Malik, those of you who are from Yenapoya or Mangalore, you would probably have bumped into him. He was more like the friendly neighborhood Spider-Man for us. That's why I've written Spider-Man there. And if I have to talk about him, I'll take an oration of an hour to be able to tell you about what magic he was and he is. So I'm not going to touch on that. What I'm going to touch about is Dr. Jagdish Kulkarni, because he's lost. Nobody knows about him. But he was the only person who taught something during our entire PG program with his hands, standing right next to us. So he is contemporary of Dr. A.B. Modi, exactly same stats that you will see everywhere. He loved music, of different genres, right from KL Sehgal to Rafi to Hemant Kumar to Elvis to Cliff Richards, you name it. He really lived life what do you say? Lived life king size, 4 square kings, right? I'm not paid by them to promote, by the way. He taught nuances of removable appliance, active and functionals with his own hands. He stood there, he made us do it. So, for example, if it was PGs, as PGs we stood by, he gave us demos for how to take a construction bite in various ways, of trimming the activator, whether it is vertical trimming or anterior posterior trimming, advantages, disadvantages. He made sure he was standing there next to us. And that was his commitment. So he was very calm, kind-hearted, and helpful. And he was very, very witty, and he made your day. He always made your day. He made sure that he made your day. And he was classy in everything that he did, and he was a rock star personality. So whom do I feel I equate this gentleman to in today's parlance that you can understand? My friend Krishna. I think he's also a rock star. I mean, he combines humor with scientific content like nobody else can. So I feel that if I could go back in time machine and learn from him, I would love to be associated in that department. That was Sir's family. And Sunil was a student of mine when I was doing a small bit of teaching at Nair. And he's now in Israel, settled there. He was an honorary secretary and then the president of the Endodontic Society there. He's an endodontist. This gentleman came as an examiner for BDS and MDS during our times and actually taught us. And how many examiners who come will go and teach the kids who are doing MDS at that point in time? He was an exception. I don't know if there is anybody here who has had the good fortune to be associated with him, but he was an amazing person. Very unassuming, very similar to the properties or other qualities of the giant that we know, which is Dr. Jayade. And then he had a 2-year term. And he was one of the few people who has chaired 2 conferences. Incidentally, trivia question, who are the others? Dr. Jaleli is one of them, and Dr. Pradeep Jaina is another, to my knowledge. Let me now come to this man, superhuman. I thought he was the incomparable teacher. Never come across a person like him in my entire life. He was the first person with a distinction in MDS from a government college. And I've had chats with Dr. Prem Prakash sir, who was his examiner, and he said that he had an excellent hand, a quick grasp, a sharp memory, cool and unflustered mind, and thoroughly well-read, and he could master any technique by only reading the text. Only reading the text, because there were no teachers in those days. His teacher was somebody who did PhD in dentistry and came and started the department, Dr. Shauri. And his teacher left after a year, Dr. Iyer, and there was nobody to teach at that point in time. So if you think of GDC Bombay, Dr. Sheikh is ever pervading. Nobody can come even close to Dr. Sheikh. He was completely dedicated and very, very friendly towards students, and even paid for their fees at times from his own pockets, and that is something which is so amazing. And his tireless efforts in quality and longevity were far beyond the traditional role that most teachers play. That was what he was during his younger days. Like I said, he was a gifted visionary who imbibed and mastered pretty much anything and everything. He switched from edgewise to beg, and then again embraced PA when he went out to Libya, and then beyond there to, where did he go? Saudi Arabia. And he then insisted for MKP sir to follow him, which he did. And then after that, with Sadashiv and a whole bunch of people joining in, the rest is history. I think PA rules the roost by far today, pretty much anywhere and everywhere. He commanded, not demanded, respect. He loved sports. He was good with wrestling, played cricket and table tennis. He was accommodative. There was one Dr. Sorabji, who was a general dentist, who was an associate member in good old days. We had that category of dentists, and now we don't have that, and he's no more. So he used to come to GDC and teach. He and Dr. Prem Prakash used to come and teach because they were the people who had taken the same course at the same place from the same faculty. And he used to come and teach. So he practiced all these techniques without an issue, right? So he was really a thinker par excellence and a person with a great heart. And he was an impartial examiner too. He recognized the merits without any hang-ups about which college he came from. Those were his, that is a young Dr. Shetye from Goa. And he bonded without any hang-ups with his contemporaries. So despite him being senior, he's standing at the back. So he reminds me of a duo in terms of their deeds, in terms of having got their distinction from a government college, not a private college. No disrespect meant to any private college, but the facts are facts. My friend Dr. Prem, that is Sridhar Prem Kumar, and Sanjay Suri, who is the only tenured professor, a student of Dr. Utreja and SP Singh, that they feel proud of, I'm sure. And he was the one, he's now in the only tenured professor in Toronto after Donald Woodside. Very young and very nice. So what is the philosophy of life? I would like you to just take a small bit of, diversion. Let me see if I can get this right. Oops. If I don't get it, we'll skip it. Oops. My mouse should go there. It's not going there. Can you just take it to that picture there? Have you heard of Aziz Naza? No, don't do that. Don't do that. Don't do that. ये जिंदगी का सारांश है. This was like the anthem for us in hostel days in college in the 70s. If you cannot understand this, Google it. It has got translations in every language imaginable. I can take a half-an-hour lecture on this one song itself. This is not Aziz Naza. He's my cousin. But he sung it better than even Aziz Naza, I feel. Just listen to only 2 lines. I'm not going to take you through the whole song.
आज जवानी पर इतराने वाले पछताएगा आज जवानी पर इतराने वाले पछताएगा चढ़ता सूरज धीरे धीरे ढलता है ढल जाएगा
Fact of life. That is what the lyrics say, in case you could not get it. And well, what does every teacher strive for, ladies and gentlemen? There are so many teachers here. Isn't this what they aspire for?
जहाँ गम भी न हो आंसू भी न हो बस प्यार ही प्यार पले आ चल के तुझे मैं ले
That was Dr. Sheikh. The best. Now, if you think in terms of this art, which has gone around on WhatsApp University, as we say, quite a lot, this is actually created out of mud. This is not anything else. So if you like this, okay, as I said, if this wows you, so should the virtuosity of this unsung battler royal, who sculpted his own life. And who was he? No other person than our forgotten member, Dr. Mohandas Bhatt. He has a unique story. He was a first batch from GDC. He took admission with Avinash Babbar. You know the Times Group, Jains. He was a nephew of the Jains. He was very connected. So he got in. There was this Dr. Menezes, who was a big boss in BARC. And then we had Dr. Sheikh, HS Sheikh, of course. And that is Dr. Shauri. And that is Dr. Iyer. Dr. Iyer was a great man that Dr. Shetty tells me that once his patient vomited. Dr. Shetty had some other patients going, so he stepped out of the department, went elsewhere. By the time he came, Dr. Iyer had cleaned up all the puke himself. Now picture this. He is the head of the department, he's a professor, and he's doing that. He kept no work untidy for any others to do. But he had to go because there were issues. We're not going to get into past. I'm only a person recounting the history for you. I'm not taking sides, right? Over something tall and amber, maybe, but not here. So this is Dr. Mohandas Bhatt. Unfortunately, in part 1 exam, he failed in statistics. The examiner could not understand what he had written, the way to approach the answer. So the method being wrong, he was held back. He was not allowed to appear, and he appeared with the second batch and he passed. That was his bad luck. जिसको बोलते हैं ना bad luck ही खराब था. That is how it was. Then of course I had these people who were examiners at that point in time. Dr. Kannappan, who was quite pluripotential in his energies. Dr. Sheshadri, who also was quite an old guard. And these are some of the pictures. I think these two and maybe Gangadhar come across to me as probably the most avid golfers that I have known from senior people. Vinod would always, and Sudhindra would always go and play golf whenever they wanted to. And this is Dr. Gulati, that is Dr. Sabre. I think this is Hari Prasad from Hyderabad. And Dr. Gross had come at that time as a chief guest. This statue I still have. One side it is like Navrang cinema जैसा एक side से बंदा है और एक side से lady है. I still have it in my clinic, you know. So these are little things that I remember. I thought it might interest you as a part of history because I'll be a part of history soon. Never know when. So who's going to tell you this? I thought I should tell you that rather than putting you to sleep some orthodontics and artificial intelligence. I don't have any intelligence, so I don't have any artificial intelligence to have any. Anyways, most of it goes away every time I sneeze. So Haridas sir was actually a second in command to P.P. Jacob sir, and that's how that department progressed. And later, I think Ashima Valayathan madam went there too. He was a very smiling and a gentle person, and quite a gentleman to deal with. So Shipurkar, amongst my contemporaries, was the first person who had 6-chair office in 80s. Have you heard that? I don't think other than Pradeep Jaina sir, anybody must have had that kind of an office, in those days. So he was amazing. And he was quite talented, as you can read there. And he actually believed in the occult science and was writing a book about what his thoughts were, but it remained incomplete when he was taken away from us. Then there was this gentleman who was Yaro Ka Yar types, Dr. D.K. Sabarwal, extremely cheerful person. Remember this? He embodied it. He really embodied it. How do I shut this? Oh, it's telling me to shut. Anyway, we'll go away. So, Major Moghe was a fantastic guy. He was major at that time. He must have signed a zillion photocopies because other than the office superintendent and dean, he was the only gazetted officer around. So patiently he testified or all the true copies in those days. He went on to teach later. This gentleman, Anil Devgare, was known to me, or I was known to him since I was in primary school. Very, very harsh-looking, fierce-looking guy. Absolute army types, but he had a soft side, wrote poetry and stuff, and the kind of mustaches, etc., and determination and steel in the eyes was like Tanaji. That's why I call him Tanaji incarnate, Tanaji tough. So he was a very, very nice guy. Then came Sachin Karnakar, who was quite close to Dr. M.K. Prakash. Anybody who's has the respect of Dr. M.K. Prakash has to have some intellect and ability in him. This was, I assume. And although I didn't know him much, he was still a very nice guy. And he was a regular in our BOSG programs. Jagdish Bhai Udani was the ultimate storyteller that I have heard in my life. He had chutkulas which he could bring out at command, which will rock you. You will start having a headache behind your ears as you do if you laugh for a very long time. I don't know if any of you have experienced that, at least I do. And Jagdish Bhai was like that, and he had an inexhaustible rib ticklers at his command. And then, of course, there was Dr. Savnoor, who never neglected BDS. teaching, and then, of course, was my buddy, everybody's buddy, Ravi Sabre. And you can see us, Ravi, myself, Dr. Bhaskar Rao, Dr. Jayade, a younger version of Sadashiv here, and not so much Khati Pite Ghar Ka, but Jyoti in person there. You remember this, Sadashiv, right? The first course that we gave, right? And then you have all the people here. That is Dr. Jagdish Udani, that is Dr. Savnoor, this is Usha, Malkani, Mirchandani, this probably is Bhuma, and Nikhil, this is Kalyani. But of course, the photograph is not that great, so I'm sorry, I can't bring it out to you in the way that it should. Ravi Sabre was somebody who was an amazing guy. He went to Libya with Sheikh Sir, and he was the first one to say that it changed his life. And do you know what he asked his parents after he became first? He came first in the district in SSC. How humble and what roots he came from. He said, "Buy me a pair of chappals." Till SSC, he had never worn chappals in his life. So from those roots, to stay balanced and to be, sorry. So he was the founder HOD and the most dedicated, respected person. He followed us into Indian Board of Orthodontics, that was automatic, and he also became a chairman, and he delivered the iOS oration at that particular point in time in 50th IOC, and he was adorned, unfortunately, posthumously after he had passed on by iOS in 2017 as the outstanding professor of. His simplicity is this song in Marathi. It's from Sadhi Mansa. If you know Marathi, you should Google this. Go through. Ultimate. And then his favorite food was dal roti, which is like, what can be simpler than that, right? That was my friend Ravi Sabre. And he loved all kinds of activities which were physical, like running and yoga and marathons. He ran half a marathon at the age of 41. How many of us can do that? That was Ravi. Smile was somebody who took wildlife photography and nature to another level, but he fizzled out too fast. His thesis under Rangachari sir on herbs started a revolution, and herbs came back in a big way. Sadashiv will remember probably that started using herbs at a particular point in time before it went fizzled out again. So Smile was then. And then you have my friend Anil, where he was an expert at mixing cocktails. That's not the only reason why Asha and Vinod are sitting next to him, I'm sure. But he was an expert. You would know how lively a character he was, you know, and that is his classmate. And there is, in fact, a trophy which is now being started in IDA in his name. And he was a great simpleton. And that's his wife, Ritu, and Dr. Shreya, who's an endodontist now. These people, if you remember, I mean, I have been to all the departments, and these three people I have been to their departments, but the person who inadvertently provided the greatest mimicry support was when I was a president, and there were issues going on, and there were lots of opinions expressed, and this guy was rocking. I mean, he had probably a hip flask to carry, and he indulged in it, and he really rocked. And it was not planned, Asha madam. It was not planned. I'm telling you that. Trust me on that. But a loss that gutted me for weeks, and even if I think of it today, still was this guy. Well, these are not the things which are important. The important part is coming later. You can read through this. These are all mundane. You can get this through any journal or whoever you ask. He created positives out of negatives coming his way, and without cribbing. So he was made to wait for a few hours by the EC as organizing chair of a PG convention. He decided that he wanted to get into iOS administration. In 4 years' time, he became a president. 4 successive wins and he became a president. That was the power of the man. So he redefined pulling away the rug under the feet. You know what the feeling is? I've had that feeling a few times. So I know it's pretty bad. But I've not done this to people, but people have done it to me. Don't get me wrong. Okay. So it so happened that as the incumbent secretary, Arun had already decided, my friend, that he's going to run for president at a particular point in time. And he was on active campaign for 4 years. If any would have asked Gangadhar, are you standing for, are you contesting for president-elect? He would say, kya baat karta hai? Are you kidding or what? So that is the kind of thing he had. But once he got it into his brain, yeah, in a month's time, he beat impossible odds and pulled the rug out of under the feet of Arun. And he was, I mean, he could make anybody laugh. You can see he's making me also laugh. So it's not a big deal. He was Yaro ka Yar, and he was quite an amazing person. And these three ensured that the 50th IOC was not a fiasco. Otherwise, it would have been really, history would have been different. So, well, he sort of joined everywhere. There can be some boys, can be boys kind of thing. You can actually see Shailesh flashing his smile with his upper incisor missing. He's very happy there, as you can see. Otherwise, he normally doesn't. So he was a very introverted personality and never realized what was on. I think he personified this song. I hope some of you at least understand a little bit of Hindi to appreciate what this gentleman is saying at that time. One of the best movies that you can see, Earth. So, talking about regrets, I'm probably going to keep some seconds on the clock or might exceed maybe a minute, sir. Right? Do I have the permission? Thank you. So some of the regrets that I have is I wanted to be a career teacher, which I couldn't. I would have loved to join the services, which I couldn't for several reasons. I wish I could understand music nuances better. It would have been so much easier if I would have been able to play at least some instrument like Nikhil does, or be able to sing or dance. Did you notice I have a birth defect? I am born with 2 left feet. I don't have a right foot. So I can't dance for nuts. And in short, be a little less dumb if possible. I mean, that's asking too much, I know, but then that's how it is. You at least wish, in wishful thinking, at least you should not be stingy about. And in spite of shortcomings in my life, if my life did pan out right, I chose the right girl to marry me. I mean, that's a game changer. So look at me and look at her. So there were many moments where when old photographs were being thumbed through by my daughters, they would turn around and say, "Oh, Mama, how did you marry this guy? Come on, you should have thought better." But then they would turn around and say, "Oh, between the three of us, we did a fairly decent job. We made him almost presentable to people, no?" So anyways, that's how it is. So, so regrets are in tandem with feelings of gratitude, always are in life. And there is intense gratitude that I have, and I'm acknowledging help first, that Shailesh and Jayesh and their committee thought of me to deliver an oration when I don't think I remember too much orthodontics anymore, and whatever little I knew was not relevant anyways for too many people. It doesn't matter. And then, of course, Dr. Sri Krishna Chalasani, Madam Secretary, and the EC okayed their choice, and here am I standing you today, trying to put you to sleep. All right? There were some other people who helped me along. Dr. Kharbanda's book was invaluable, as he himself is a book, and we interacted quite a lot, and we were in a position to try and get the facts as much as they could and piece them together for me to put them across to you. I must have quizzed a hell lot of people more than them, but these are just representatives, my classmates and my seniors, and then some of the younger people who are extremely capable. And I must have troubled these people probably the maximum. Ajit Kalia, Cleve, Santosh Ramegowda, Shubhakar, as well as Vignesh. They also humored me quite a lot. But the youngest lot who gave me nuggets were Dr. Suresh S.B. Shetty sir, Dr. Samraj, Dr. Jacob sir, Dr. Pradeep Jaina, Dr. Rangachari sir, Nandu Jaikar, Jayade sir, and Daksha Chitre madam. So they are responsible for whatever little I am able to bring across to you. They tolerated me and they made sure that there is something to talk about this entire oration in my laptop. Well, acknowledging thankfulness always goes to the family as well. And the family suffered a lot because I think gave much more than I should have given to them as well as to practice and gave so much time for iOS. But I did it willingly, of course, so there are no regrets. I do have some friends. I do have an audience. I mean, this is amazing to have an audience in iOS lectures. Otherwise, you don't have more than 5 or 10 people in an audience. So this is great. And these two made us realize that you can gain a son without losing a daughter. They are my young Jamais. These are the apple of Anita's and my eyes. Deepika and Niharika are grandkids. A gift from Pankaj and Aditi. That's our younger daughter. And despite being in Singapore and having a good time, I was still on my laptop all the time and trying to work my facts through research and making this presentation. They allowed me to do so. So thank you very much, ma'am. This is my professional family because now I'm in the process of Baton exchange. I have told them that you carry on and I'll be here and where, but I want to smell the roses now. And I have a good bar, so I want to make sure that that will keep on going. I'm almost through. So what I would like to leave you with is the fact that I have had interactions with young friends who tolerated me in teaching colleges as well as in iOS activities over a period of time. And
तो ये हक है तुमको मेरी बात और है मैंने तो मोहब्बत की है तुम मुझे भूल भी जाओ तो ये हक है
finally, I leave you with these thoughts that जाने अनजाने में बोल, वाणी, विचार, भावों, व्यवहार और कार्यों से किसी मित्र और परिजन के मन को ठेस या हृदय को पहुंचा हुआ दुख अल्प या अपार तो दोनों हाथों पर मस्तक रखकर आप सबकी मैं क्षमा मांगता। थैंक यू।
Karandikar. Thank you, Dr. Karandikar, for the wonderful presentation. I would now like to call Dr. Sri Krishna sir to please felicitate our speaker. Dr. Sridevi ma'am, please can you felicitate our chairperson, Dr. Sri Krishna.
Just to add a word to Dr. Girish Karankar's oration, in 1 hour he took us the entire life, how the life goes on, everything. And another thing I noticed, his eyes, his face, his body, legs, hands, everything was sinking to every part of his lecture. That means he was totally involved into it. Yes.
May I invite the chairpersons for the next session? Dr. Sadashiv Shetty, sir, the stalwart who's taught us PA, former principal and professor, Bapuji Dental College, Davangere. Dr. E.T. Roy, also former professor, Bapuji Dental College, Davangere. So please introduce our next speaker, Dr. Junji Sugawara, sir.
Raise your pointer.
Good afternoon, dear colleagues. It's a pleasure and honor to introduce Dr. Junji Sugawara. I'm hearing him for the second time. First, I heard him in the Iranian National Conference. He's an icon in the World Orthodontic Group. Dr. Junji Sugawara is currently the director at the Junji Sugawara Clinic in Sendai, Japan. He graduated from Tohoku University in Sendai, Japan in the year 1973 and worked there for nearly 30 years. He is an active member of the Edward Angle Society North Atlantic Group since 2004. He was the one who introduced the skeletal anchorage system, utilizing the titanium plates as a temporary anchorage device, and surgery first are recent key interests, and he has given many lectures on these subjects all around the world. Over to you, Dr. Sugawara.
Namaste. Hello, everyone. Thank you very much for your kind introduction. Thank you. I'd like to begin my talk by thanking the organizers for inviting me this 56th Indian Orthodontic Conference. So it is my great pleasure to be here to share the knowledge and the experience with all of you in this conference room. This is the title, very simple, Sendai Surgery First. For the next 60 minutes, I'd like to talk about our surgery first. I'm from Sendai, Japan. Probably you know the Tokyo, right? Tokyo is the center of Japan, and Sendai is located 300 kilometers north of Tokyo. So if you jump on Shinkansen in Tokyo, it takes about 90 minutes, an hour and a half. So our city is here. This is our city. Its population is about 1 million. And Sendai is political, economical, and academic headquarters of northeast of Japan. This is my clinic. I'm 74 years old now. I opened my clinic 3 months ago. Thank you. So it's just a brand new. In our clinic, live operation seminar conference is holding, and many participants are coming every month. Very exciting. So I show you our recent surgery first. Please take a look this computer graphics. Does work. Yes, it stopped. Class 3 patient. dental compensation. This is our BSSO design. And before surgery, just to, coupling hook is bonded and set back, a T shape on plate. In addition, 4 orthodontic mini plates were placed. In some center surgery first, immediately after orthodontic OGS, occlusion is very unstable because no orthodontic treatment. So therefore, surgical splint is essential. After OGS, braces are bonded, and the surgical splint was removed immediately, and the bond paste or resin is built up at the upper posterior teeth to stabilize the posterior support. And then digitalization of the upper posterior teeth and mesialization of the entire dentition started. So in 6 months, posterior support is stabilized, and finally, anterior teeth are retracted and debonded. Compared before and after. Very simple. I show you the classic example. He is 24 years old Japanese man, young man. He complained of prognatic profile and a little bit mandibular asymmetry he had. Occlusion, anterior crossbite, and deviation of mandibular dental midline. Class 3 denture, as you can see here, dental compensation is clear. Upper incisors, proclination, lower incisors, retroclination. Here's cephalometric analysis. Here is our template analysis. I don't use numbers, cephalometric measurements much. This is overall superimposition, and here is maxillary and mandibular superimposition. You can tell at a glance what's the problem of this case. You can see he has a large mandible, mandibular excess, and the mandibular protrusion. What about the maxilla? Maxilla size is average, and the position is average. He didn't have any problem in the maxilla. And okay. So this template analysis is very similar to McNamara analysis. I use in a vertical line. And his width appraisal was minus 14 millimeters. Is a clear indication for jaw surgery. So I established a treatment goal two-dimensional or by using cephalometric prediction. So this is immediately after, figure A shows immediately after OGS. So his mandible setback 10 millimeters. He showed a class 2 occlusion, skeletally class 1 already, but he showed class 2 denture with open bite because he showed before treatment, he showed a clear dental compensation. So therefore, he showed a large overjet and open bite. This is the prediction at the debonding immediately after treatment. So during the post-surgical orthodontic treatment, his mandible showed a counterclockwise rotation, and class 2 denture will be fixed with the application of skeletal anchorage system. This is treatment goal with the 3D prediction. Actually, it's a dolphin software immediately after jaw surgery. And model prediction, we do the separate prediction and 3D prediction and model prediction. Right now, we are very transitional stage. We do not decide the treatment goal, only 3D prediction using everything. So this is also important, very important prediction. 10 millimeter setback. It's a setback in parallel to functional occlusal plane. So he showed class 2 denture and the large overjet. So at the same time, he needs, because the occlusion is unstable, so therefore the surgical splint is essential, as I shown you computer graphics. Okay, this immediately after orthognathic surgery, he showed the skeletal class 1, class 2 denture, large overjet, large buccal overjet, and open bite, 2-point contact, only here and here. It's functional cusp contact. So immediately before orthognathic surgery, I bonded this Kaplan hook only, and no braces, no wires. Because of immediately after, the patient is very uncomfortable with the braces, wires. So they cannot to clean their teeth. So this is much comfortable for them. So OGS was carried out. It's a stepwise DSSO bilaterally. And the anchor plate were placed zygomatic buttress bilaterally, and between 3 and 4 L-type mini plate, anchor plates were placed in order to visualize the entire lower dentition. In the upper, it's entire maxillary dentition is distalized, and the posterior teeth will be intruded. OGS and SAS. In surgery, our surgery first, most important one is, of course, orthognathic surgery and anchor plate. Skeletal anchorage is the most important in the post-surgical orthodontic treatment. So therefore, those anchor plates were placed during OGS simultaneously. This is the photos immediately after surgery, OGS. As we planned, he showed the class 2 denture with open bite. And did with the class 2-ish profile temporarily. And those Kaplan hook was used just for the training elastics. This superimposition showed the changes during the OGS, before and after OGS. So as we planned, class 2 profile and the class 2 denture with open bite. So look at this occlusion, very unstable. But we can fix this occlusion without bicuspid extraction with the application of skeletal anchorage system. Sorry. So objectives of post-surgical orthodontics in early stage of Sendai surgery first is firstly transverse decompensation. Usually maxillary arch is much wider than the lower arch. So transverse decompensation needed to stabilize the posterior support. Secondly, digitization of maxillary posteriors. Thirdly, intrusion of maxillary molars in order to correct his open bite. Then, at the same time, number 4, mesialization of the entire mandibular dentition. Here, transverse decompensation is very important at the early stage. As you can see here, this is frontal section of the number 7. Only two, as I said, only 2-point contact in surgery first. So immediately after surgery first, it's functional cuts of the upper molar and the lower molar, just contact like that. So maxillary arch is relatively much wider than the lower arch. So therefore, transverse decompensation is essential at the early stage. So there are various types of mechanics, biomechanics for transverse decompensation. One is cross elastics. This is used for training elastics at the same time. And the constriction linear arch. This is activated like this to constrict the upper posterior teeth. And sometimes we use expansion of the lower arch using expansion labial arch. And occasionally we use, we are placed mini plate and mandibular body. So therefore, we can use this mini plate like that. So I show you the treatment progress of this case. 11 days after OGS, I started post-surgical orthodontics. For, as I shown in the computer graphics, CG, they're using this, so surgical splint was removed already. And band paste or raising build-up was carried out in the upper posterior teeth to stabilize or to get vertical stop. And then leveling and aligning started in the upper and lower dentition. At that time, this arch wire is copper nitride 016 by 022. This is the initial wire. And this wire is mandibular use for constriction. This lower arch is maxillary use. Copper nitride was put in place. Then, 1.5 months after OGS, transverse decompensation with close elastics and constriction ring arch was then distalization and intrusion, you can see here, of maxillary posteriors and using coil spring, mesialization, and intrusion of mandibular posteriors. So that means class 2 denture and anti-open bite will be quickly improved. This is constriction arch. So 3.4 months after, open bite is gradually, slowly corrected, as you can see here. And the distalization and the intrusion of the upper posterior teeth or lateral teeth is almost completed. So the mesialization of the entire mandibular dentition continued. Okay, and 5 months after OGS, here's the space. Following the distalization of the posterior teeth, there's some space between 2 and 3, so to close, and decompensation of upper incisors, this vertical loop was used. 6 months after OGS, So what I did at that time is correction of mandibular dental midline. So mandibular midline is still deviated to the left a little bit. So therefore, the mesialization, unilateral mesialization of the lower dentition is carried out at that moment. Okay, like this. So anchor plate is very versatile. You know, we can do anything in 4 places. We can, how they say, distalize, mesialize, or intrude, or correction of dental midline is we can fix it quickly. So 6 months after, this is the facial photos, 6 months after OGS. So during this 6 months post-surgical orthodontics, his mandible showed a counterclockwise rotation following the correction of open bite. And she could have the good incising function. 7.7 months after OGS, it's already, detailing on the finishing stage. Minor mesialization of maxillomandibular entire dentition is carried out here. So this is photos to debonding. This is our occlusion and all of photos of the immediately after post-surgical orthodontics, debonding. So our retention protocol is the linear bonded retainer in the upper and the lower anterior teeth. And at the nighttime, patient is instructed to use a vacuum form clear retainer. That is our protocol, recent protocol. Okay, this is the panel X immediately after debonding. So we did several metric analysis at this time. It's a post-surgical, post-operative evaluation. So you can see here, this is again template analysis. Is well-balanced profile. I developed this analysis when I was in university. And we did many researches. This norm is available in daily orthodontic practice. So if patient profile is very close to the average face, without exception, their man is handsome and woman is beautiful. So we make sure that using multivariate analysis. So he showed the well-balanced profile. Which appraisal was changed from minus 14 to minus 4 millimeters. This is superimposition 6 months after OGS and at debonding. Skeletally, almost no change, very minor changes. And dentally, also minor changes. Minor changes were observed. That means within in 6 months after OGS, patient profile and occlusion is almost established very quickly. 6 months to at the end of debonding, it's just detailing, finishing. With the application of the skeletal anchoring system, detailing in the finishing phase, we can quickly, finish, as I said, before. This is superimposition before and after. Overall superimposition. Thanks to the orthodontic surgery and the skeletal anchoring system, his dentofacial problem was predictably improved, corrected. Here is mandibular superimposition. As we planned, his mandibular dentition, entire mandibular dentition was successfully, nicely mesialized. thanks to skeletal anchorage system. So here is he's talking, unfortunately in Japanese, not English. Sound? You look at mouse function when he's talking, completely different. Okay, it's his problem is not only morphological problem, but also his functional problem is nicely improved. Here is a photos comparison before and after profile. He would have well balanced profile, and occlusion is as you can see here. Dental compensation was observed before treatment, but decompensation was nicely accomplished. Total treatment time from bonding to debonding, actually after OGS to debonding, was 8.7 months. He's very pleased reading the outcome of this Sendai surgery first. Okay, in 2009, first ever surgery first case using skeletal anchorage system post-operatively was reported by our team. This is the first paper, talk about surgery first in the history of orthodontics and surgical orthodontics. So this is the first paper on surgery first, and then a lot of papers were published all over the world. And I read most of these papers, and I realized that the surgery first, they're using term of surgery first. We invented or created the surgery first term, first three. They use also surgery first. But their surgery first, it's not same. So after reading those papers, I realized that surgery first is classified or divided into two groups. Two styles of surgery first. One is surgery-driven style. This definition is as many skeletal and dental problems are solved by surgery as possible. It's not only jaw surgery, but also the corticotomy and some other, segmental osteotomy. Also after surgery, orthodontists can just leveling, aligning, that's it. Very simple way. But the surgical intervention is very severe. On the other hand, the other group is ortho-driven style. As definition, the skeletal problems are solved by OGS, and the dental problems are fixed orthodontically. Our team belongs to ortho-driven style. I'll show you the, compare two groups, two styles, using this example case. She's a simple class 3 case, prognostic profile and class 3 denture. Almost no crowding in the upper and the lower dentition. Her skeletal and dental problems are shown here. Width appraisal was minus 12 millimeters and large mandible, prognostic profile, and average size maxilla, and maxilla has no problem in the size and the position. So that means for us, for orthodontic-driven style, this is a clear indication for one-jaw surgery, mandibular setback surgery. But in the surgery-driven style, if this is before OGS. In surgery-driven style, concept is different. Immediately after orthodontic surgery, this is a transitional occlusion just after OGS. In the surgery-driven style, this occlusion should be a treatable class 1 malocclusion with class 1 denture. And hopefully, the patient has tripod contact. Tripod contact means at the molar region, bilaterally, and incisor region, one point. But in this case, probably 2-point contact, no contact in the upper, but class 1 denture, as you can see here. The problem of this surgery-driven style is difficult to decompensate incisors and nicely correct prognatic profile because patient occlusion is compensated, dental compensation before treatment. So therefore, the class 1 molar relationship means just a small amount of mandibular setback, right? So this is the CD template analysis. The norm is red, and patient is black. But still, she had a class 3 profile, skeletal class 3. So need some solution, right, to correct this patient's profile. So what they thought, it's a solution is clockwise rotation of maxillomandibular complex. That means two-jaw surgery is essential. Please take a look this Shiji prediction. So using by application of two-jaw surgery, the posterior or maxillary posterior region is impacted. So therefore, maxillomandibular complex can clockwise rotate clockwise. So by this method, the dental compensation is performed surgically, and chin is set back beautifully. So this is treatment goal in this after the solution of this problem. But still, there is a problem here. Patient's maxilla has no problem before treatment. So there, the Hernandez Alfaro group published a paper about their surgery first. They belong to surgery-driven style team. So total of 239 patients. That means 84.7%. It's a large percent underwent bimaxillary surgery. So most of the cases in the surgery-driven team needs two-jaw surgery. More surgical intervention is more severe. So Sendai surgery first, on the other hand, is the ortho-driven style. So this is transitional occlusion. Somebody calls it surgical occlusion, but I prefer transitional occlusion. Just after OGS, shows class 2 open bite because the setback of the mandible is much larger than the surgery-driven style. So the purpose of this, transitional occlusion is reveal the true extent of decompensation based on the treatment goals. We aimed, to make the appropriate overjet to nicely correct the dental compensation. Of course, there is a problem. Unstable occlusion with class 2 open bite. That is a problem in also driven style. This is just after OGS. So big difference between the two groups. Solution is, as I already shown you, the computer graphics and classic example, intrusion and distalization of maxillary molars and the mesialization of mandibular molars. So, but occlusal splint is essential in this approach. So this slide shows the features of Sendai surgery first. OGS in Sendai surgery first. One-jaw surgery is 73.3%. Two-jaw surgery is only 26.7%. That means a less invasive approach. And surgery first ratio in all surgical cases, surgery cases, the surgery first is more than 90%. So also first, that means the conventional or surgical orthodontics is less than 10%. Of course, surgery first, the indication for surgery first is not 100%. That means there are some contraindications. It's less than 10%. That means a broader indication range compared to the surgery-driven style. PES, in our approach, skeletal anchorage system is essential. Therefore, orthodontic mini plate is more than almost 75% patient underwent SS treatment in a postoperative treatment. Minuscule 20%, and non-TAT is only 4.8%. That means using the TAT skeletal anchorage system, we can shorten the treatment time. These are our features of Sendai surgery first. I show you some cases which show the less invasive OGS. The first case is 22 years old Japanese man. He complained of long face and large interlabial gap class 3 profile and open bite. Usually in such a case, two jaws, he's in a conventional approach, he's in a clear indication for two-jaw surgery. Probably you agree, because he's a long face, a large mandible, and VME, vertical maxillary excess. So we establish a treatment goal by the one-jaw surgery, following after the establishing treatment goal two-dimensionally and three-dimensionally. And the surgical splint is, of course, essential in such a case. So orthodontic surgery was BSSO and genioplasty for the chin height reduction. The treatment progress, immediately after OGS, he showed a severe open bite because of just 1 point contact. But thanks to the skeletal anchorage system, his anti-open bite and little bit class 2 denture is nicely corrected in 8.1 months. Okay, at BSSO and genioplasty and the 4-anchor plate, this is our usual pattern in the Sendai surgery first. So, and wisdom teeth of the upper wisdom teeth were extracted during surgery. This is the photos immediately after debonding. So, and here is his superimposition. So, total treatment time was less than 1 year. I show you another case, a less invasive case. As you can see, he showed a class 3 profile and counting the occlusal plane. So his occlusal plane is left-hand side is up. And the class 3 denture and some crowding in the lower dentition. So in this case, we try to apply the just to mandibular asymmetric mandibular setback. 10 millimeter setback on the right side and 5.5 millimeters in the left. So asymmetric this is setback. And also the 4 anchor plates are placed at the molar region during orthodontic surgery. Using this anchor plate, his occlusal canting will be corrected orthodontically. Okay, this is treatment progress. Here, 0.5, immediately, just started at that time. And this is a correction of canting occlusal plane. And here is biomechanics for the extrusion of the upper posterior teeth. So using this anchor plate, buccal tube was bonded vertically, and this is extrusion helix using 17 by 25 CNA. And this is a neutral position and the hook here between the 6 and 7. So this is photos at that time. And 13.9 months later, his occlusion was nicely corrected. This is photos after debonding. Here is a superimposition. His canting occlusal plane was successfully corrected without surgery by using the skeletal anchorage. So, but the treatment time was a little longer than average in the surgery first, 15 months. So next cases show the broader indication range. So Mahmood reported, mentioned in their publication, surgery first is limited to patients with minimal arch length discrepancy, so almost no crowding, normal incisor inclination, that means no dental compensation, and mild to moderate sagittal, vertical, and transverse discrepancies. Hence, the patient selection is critical. They mentioned about it. I think this is, yes, in a surgery-driven style team, but not in also driven style team. I show you two cases. He showed a vertical problem, vertically and anteroposteriorly. She had problems. Long face, very large interlabial gap, severe open bite, crowding in the upper and the lower anterior teeth. So you can see here, compared to the norm, see clearly the indication for jaw surgery. But probably this is not the indication for for OGS in the surgery-driven style. We decided to apply two-jaw surgery, of course, for the impaction of the maxilla and this setback of the mandible. This is, the orthodontic surgery. Mini plates are placed at 4 places, as usual. Treatment progress, 1.4 month later. Here is band paste to stabilize the posterior support. And 3.2, her open bite was significantly corrected. This is the photos at the 6.5 months later. Detailing and finishing started at that time. Okay, this is the photos immediately after debonding. Her large interlabial gap, severe large interlabial gap was improved. Nice smile, no gummy smile, and the class 1, good occlusion. This is a comparison before and after, superimposition, right? Her skeletal and dental problems was nicely corrected. 13.3 month, the total treatment time. Here is another case, more severe case. Probably this is usually not indication for the surgery first. But he required short treatment, the shorten the treatment time as short as possible. So he showed a long face, facial asymmetry, and the problematic profile. Occlusion is, terrible. He has a severe crowding in the upper and hopeless first molar and the apical region here, and then severe clouding in the lower dentition. So we decided to apply the surgery first, standard surgery first. So two-jaw surgery is required for the advancement of the maxilla, 5 millimeters, and setback mandible, but asymmetric setback. This is average, 5 millimeter. And 4 mini plates, anchor plates were placed during surgery. And this is treatment progress 1 month later, making a space for canine and lateral incisors. And distalization and the intrusion of the mandible, maxillary molars was carried out at that time. 5.4 months. So the major dental problems were corrected. In 11 months, his occlusion is almost detailing in the finishing stage. So for using for anchor plate, in this case, the upper first molar was extracted, and second molar mesialized, and third molar is erupting. So I'm using this one at the finally. This is the photos after debonding. Not the perfect occlusion, but I said acceptable, not bad occlusion in this case. This is superimposition. Okay, it's treatment time. Total treatment time was 12.4 months. So Kwan said the selection criteria for the surgery first approach are largely dependent on the experience and the preference of the surgeons and the orthodontist. There is no consensus on the indications and the contraindications for the surgery first approach. I 100% agree with his opinion. And in a surgery first, tender surgery first, treatment time is short. I show you the statistics. So 292 cases. Here it's treatment time, it's a month, and the number of patients, it's y-axis. So average treatment time in tender surgery first. This is all surgery first case, tender surgery first. It's 14.7, and the median is 13.7. That means, as you can see, usually in tender surgery first, the treatment time is around here. Of course, there is some difficult cases, problem cases. I show you some example of the treatment time group. This case belongs to a very short treatment time group. She was a 15-year-old girl, and she showed VMD, vertical maxillary deficiency. When she smiles, upper teeth display was deficient. And crossbite, some minor crowding here, but very simple arch. We applied Tujo surgery in this case because of vertical maxillary deficiency to improve her incisor display. Advancement and disimpaction of the maxilla and the skeletal anchorage system are placed. Sorry, in this case, I didn't apply any anchorage mini plates because her dentition was very simple. We can expect the good occlusion immediately after surgery. So they said 2 weeks later, 4 weeks, and in 4 months, she had good occlusion already. This is photos after treatment. In this case, treatment time was 5.4 months, a very short group. And the occlusion is, the dental midline coincide with the facial midline, and beautiful class 1 occlusion were established. So short treatment time group. This is an example. She showed the class 3 profile, and similar to the first case, very short group case. Excuse me. She showed a simple class 3 denture. The clouding was very minor. This is she underwent BSSO for mandibular setback and 2 anchor plate in the upper dentition. The zygomatic buttress were the plate were put in place. Treatment progress, 2 weeks, the start of post-surgical orthodontics. And in 6 months, she could have a good occlusion, a nice occlusion. This is photos after debonding. Her treatment time was 8.7 months. So nice class 1 denture were obtained. So here's another case. It's average, he belonged to average treatment time group. He showed class 3 profile and the long face a little bit, and the crowding in the upper dentition, particularly the lateral incisors, the linearly positioned, linear version of the lateral or incisors and the high canine. Compared to the two cases, his dental problem is a little bit severe or moderate. SS skeletal anchorage was needed for 4 places. And his crowding were corrected without bicuspid extraction. And in 12 months, 4 months, this is the photos at debonding. So it took time for the desization of the upper posterior teeth. But treatment time is just average, 14.6 months. Okay, this is another case, long-term treatment group, more severe dental problem she had, a deep bite. 2 anchorage was placed, and this is the beginning. No extraction treatment. So desization of the upper posterior teeth and making a space for the high canine. It took 16.5 months for the detailing in the finishing stage. This is the photos after debonding. Treatment time was 19.1 months. Okay, here is a very long treatment time group she belongs to. You can see here the smiling. She was not anterior crossbite, well compensated. The incisors, central incisors are not crossbite, but look at her chin, very strong chin. So therefore, she's an indication for surgery. This is a problem. Okay, a very long treatment time group, and the SS4 anchor plate and the BSSO was carried out. Treatment progress 7 days after OGS started, just for the distalization of upper posterior teeth. And it took a long time, 2 years. She was reluctant to be, the full bicuspid extraction, upper bicuspid extraction. So treatment time was prolonged. But fortunately, she could have a good result after 25 months. So treatment time is likely a spectrum. It simply depends on the severity of the transitional occlusion after OGS. Very simple. Here is average, and if there is no crowding, treatment time will be very short, but the severe crowding, very long. Okay, I will move on to the final topic. So, sorry, this is a summary of this treatment time. Surgery first can significantly reduce the treatment time because there are several factors. One is RAP. Second, SAP. This is a bone formation. It's quickly follow the RAP. And normalize the relationship between the jaws and the muscles. Okay, and natural and spontaneous decompensation of the dentition and this predictable and efficient OTM with skeletal anchorage. These factors in Sendai surgery first, we can reduce treatment time significantly. Okay, and this is the final, last topic. I will quickly talk about that. So acceleration of OTM, reduced treatment time is important, of course. But more important thing is long-term stability. Okay, and here is a systematic review. So far, lack of they indicated lack of prospective long-term follow-ups. But I show you the the long-term follow-up cases, 60 cases, and this is just a raw data. I don't know how to show you the long-term stability of Sendai surgery first. Statistically, it's very simple, but I want to show you the raw data, each case. Probably you can tell the Sendai surgery first, the long-term stability of the surgery first is, how after treatment, it's changed. Initial examination. So the class 3 cases, because we do not have much class 2 cases. Here is the selection of cases, 60 cases. So OGS, two-jaw surgery, 9, one-jaw surgery, 51. So no rigid, no IMF, rigid fixation, and all cases underwent surgery first with the skeletal anchorage. Extraction is only one. Other cases, 59 cases are no extraction. And orthodontist, I did the orthodont treatment, all of these cases. This is initial exam. Again, I show you. All cases show the skeletal class 3. In some cases, open bite, and the asymmetric cases are involved in these samples. Yellow flame means two-jaw surgery, 9 cases. Just after OGS, most cases showed class 2 open bite, as you can see here. Oh, time is up. 6 months after OGS, those class 2 open bite is correctly, in most cases, obtained stable posterior support, and some cases are almost detailing in the finishing stage. This is a debonding. Okay, all but one case was nicely corrected without bicuspid extraction. This one is only one extraction case in the upper posterior upper bicuspid bilaterally. No extraction in the lower, of course. This is 5-year follow-up. So I have no time to talk about detail. No recurrence of anterior crossbite in any case. But you can see the white frame. This case showed a shallow bite. Incising function remained, but lateral incisors showed a shallow bite. So what have we learned? Most skeletal class 3 cases showed very good dentofacial stability in the 5-year follow-up period, but it was difficult to maintain proper anterior guidance in one extremely severe case. Okay, this is a final message, the take-home message. The indication for Sendai surgery first are much broader at over 90%. Since only 27% were applied to two-jaw surgery, less surgical intervention is required in Sendai surgery first. This is one of the features. Thanks to the application of SS biomechanics, we can shorten overall treatment time. This application of SS biomechanics is the most important factor in our Sendai surgery first. Then, and most skeletal class 3 cases showed very good dentofacial stability in the 5-year follow-up period. Before closing my presentation, I'd like to thank Professor Ravinanda, Professor Tetsu Takahashi, Dr. Hiroshi Nagasaka, Dr. Satoshi Yamada, and Dr. Satoshi Yokota for their passion and professionalism and collaboration. Okay, thank you very much. This is the pictures, yesterday's pre-conference course. Okay, many thanks for your attention. ありがとうございます。Thank you.
Thank you, Doc.
Thank you. Thank you, Dr. Sugawara, for the wonderful presentation. Dr. E.T. Roy and Dr. Sadashiv Shetty. I would like to invite you to please felicitate our speaker. Chairpersons. Can I please call Dr. N.R. Krishnaswamy sir to please felicitate our chairpersons?
Bluetooth. नहीं 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 चाहिए ऑडियो नहीं चाहिए मैडम माइक की बात कर रहा हूँ अच्छा सर माइक या माइक
I would like to invite our next chairpersons for the session, Dr. Vasundhara Bhatt Madam, Professor and Head, Government Dental College, Nagpur, Dr. O.P. Kharbanda sir, former Head, Professor AIMS, New Delhi, currently Professor, Faculty of Dental Sciences, and Vice Chancellor, Health Sciences, Ramaiah University.
Hello. Hello, good afternoon. We have the next international speaker from Rome, Dr. Alessandro Greco. He has his dental practice in Rome, exclusive orthodontics. Dr. Greco took his dental degree from the University of Rome, Tor Vergata in 1999. He took his postgraduate degree from the University of Ferrara in 2007, and he's also a doctorate from the University of Rome. He's a visiting professor at the University of Ferrara from 2013. He's a member of the Italian Board of Orthodontics, European Board of Orthodontics, and the active member of the World Federation of Orthodontists. He's a past president from 2013 to 15 of the Italian Society of Bidimensional Technique. He's the past president in 2013 of the Italian Association of Orthodontist Specialists. He speaks on Invisalign, He is the author of many scientific papers in the national and international journal, and he is a speaker at national and international forums. So on to you, sir, for your presentation, Dr. Grieco.
Thank you so much. Thank you so much for your kind introduction. Thanks for this opportunity. First of all, to be with you in this incredible country. And second, thanks because for me was an honor and a privilege being on this stage after a living legend like Dr. Sugawara. So it was really another big pleasure for this reason to be here. I come from Rome, so I'm Italian, and what I'm going to share with you today will be, after a short introduction, trying to spend time in talking on early treatment, so something different from what we discussed until now. My city is a really complex city. I always say that the traffic that we have in Rome is similar to the traffic that we have in Mumbai or Delhi, but we are slightly less. But for this reason, as you can see, I'm going around as much as possible with a motorbike in order to arrive on time at work. And nowadays, my office, which is close to the center of the city, is a full digital office. So that means that I'm fully paperless and I'm trying to do everything without any other conventional system. So I don't use any impression trays or impression material anymore. My approach is fully digital for this reason. And I'm trying in particular, since I like the concept of working on the digital side, to treat all my patients with aligners. And in this moment, I'm reaching a really high percentage in what I'm doing. So I'm trying simply to realize what Bob Keim, the past editor of the JCO, the Journal of Clinical Orthodontics, was mentioning in 2018, facing the end of braces. And this is probably what we are facing nowadays, or probably what we will see in the future. For me, nowadays is something that comes to be a little bit more real, in particular when I'm treating patients on average difficulty, let's say. And of course, as I think all the orthodontists in this hall, my education comes from the most conventional possible approach. I had the opportunity to meet and spend time with my mentor, Professor Gianelli, the chairman of the Boston University, and the inventor of this technique on which I was president in Italy, the Italian Society of Bidimensional Technique, which is completely dedicated to the memory of Professor Gianelli. And so my approach at the beginning was fully conventional, let's say, using more than conventional system. But during the world, during all the procedure that comes here today, a lot of new things came in my profession, in our profession. All of these new things, in my opinion, were really useful to achieve a really interesting, better diagnosis, better treatment plan, trying to analyze the movements, trying to analyze the results of what we are doing and being always more and more precise. This is the beauty of the digital approach today. But still, without a mind, without the mind of the orthodontist, all this beautiful technology is nothing. For this reason, we need to guide all this new technology and try to give a precise direction in what we are doing. And I've been lucky a second time in my life because I met Dr. Sachdeva, that you probably know better than me. And Rohit is a big friend of mine. We met many, many years ago, and he was really an inspiration on the digital path. Because as you probably know, he wrote a really interesting chapter in the Graeber book edition of 2011, talking about how can we move from a traditional orthodontic approach to a digital orthodontic approach. And the real resolution and answer to these questions and to this path of movement is trying simply to change our mindset. From a reactive model, we should move on a proactive model, which is exactly the difference in our digital world. So instead of contrasting the collateral effects of the biomechanics we are applying on the teeth by means of our brackets, the suggestion is trying to prevent instead, because when you plan everything from day zero, even before starting the treatment, that means that if we know how the teeth are moving, we can prevent a problem instead of a contrast, a collateral problem. And this is exactly the idea behind the digital. And this is exactly how I'm managing today my personal approach. I treat everyone with this kind of digital system with aligners, and I spend pretty a lot of time on the digital side of what I'm doing. That means that I'm changing and I'm activating the 3D controls, and I'm changing the position of the teeth manually. And I'm going to do this for the amount of correction that I'm going to do in terms of using different kind of attachments, placing personally, changing the spaces in the IPR, and trying to work in particular in the finishing of my cases and working on the occlusal contacts as well. So that means that I'm spending pretty a lot of time in this side of the treatment, in the planning part of the treatment, which is the core actually, because it's not important how much we are good in placing attachments or doing IPR or doing ligatures or placing brackets. But the most important part of what we are doing should be planning, is the core, is our mind, is our thought, is our knowledge put inside a digital system. And this is the key. And this is also the reason why, pretty commonly, when I'm treating some complex condition, I can easily combine what I have in my hands and in my head as a knowledge to simplify the aligner treatment. So that means combining, for example, piezo-scission, combining some facilitation devices like perforations, or trying to combine TADs, exactly as well, something that we were discussing yesterday at the pre-conference course. But this also means that somehow I can treat not only complex patients, but I can start thinking about an early treatment with this kind of system. And before understanding how can we do this with aligners, let's try to introduce the topic of the timing, which is one of the most discussed topic in our orthodontic congresses. Phase 1 versus phase 2, which is the best solution. And exactly the question is this one: when is time to start an orthodontic treatment, an ideal timing? And it's really tough questions to answer. And if we try to see or literature what happened, we can find a lot of information. But let me refer once again to my mentor, to Professor Gianelli. Professor Gianelli told us that ideally, when we start an orthodontic treatment in whatever age, we should be as much as possible efficient. And being efficient means trying to treat all the patients in the shortened treatment time with less waste of energy and the maximum satisfaction for our patient. And this ideal timing has been indicated in the literature to be exactly close to the maximum dental velar growth between 11 and 14. This is what we know from literature. This is what we know from the beautiful paper from Professor Franchi from University of Florence, for example. So there is some reason why we should start before the pubertal peak, as indicated the literature. We need to understand this one if we have the possibility to start in advance before the pubertal ideal peak of treatment. And when we ask these questions and when we put these questions on the literature and we ask, okay, should we start before, for example, to achieve a better skeletal changes? So if we start earlier at 7, 8, and we do a phase 1 of treatment, probably we can have a better skeletal changes. Well, if you look at this literature, the answer is no, unfortunately. Okay, but let's ask another question. If we start early, before the pubertal peak, can we have a better arch modification, for example? Using lip bumpers, using space gainer, using a lot of things. And again, unfortunately, the answer is no. There is no reason to start earlier if our goal is a better arch modification. But probably when we are looking at a better outcome, at this point, if we plan 2 phases of orthodontics instead of only 1, we can achieve a better outcome. Again, unfortunately, it's not. And there are some beautiful papers, in particular from Professor Tallock, telling us that normally they are trying to compare group of patients treated with 2 phases of orthodontics and only 1 phases of orthodontics. And the difference was absolutely nothing. There were no significant differences between the 2 groups. So actually the literature is telling us there is no justification in starting a treatment before the ideal timing that should be the pubertal peak. So that means that we are not treating kids, actually. But there is always from Giannelli a nice indication, in my opinion. And the one is asking ourselves, when can be useful start a treatment before the ideal timing? Or again, when is needed sometimes to start a treatment before the ideal timing? And in this way, trying to answer these questions, we can find some interesting solution. And so we have some indication, which are fundamental. First of all the time that we found a cross bite with a mandibular shift is an indication to start early. All the time that we have a maxillary constriction without a cross bite malocclusion. All the time in which we have some, let's call, eruption anomalies. And so we need to manage the space or regain the space because we have a premature loss of some deciduous teeth, for example, or some eruption anomalies of the incisor with some anterior crossbite, which is also pretty common in kids. Or finally, and this is always an interesting solution, when we have a class 3. So when we have a class 3, we need to start early. And so we have some clear indication on the early treatment, on the literature. But from the literature, we also know that the ideal appliance to manage all this problem is this one, because we all use it probably this kind of approach with an IREX, with a maxillary expander. Today, this is changing, not because we are changing completely approach, but because I'm personally changing the approach of the kind of appliance. I'm not using bands anymore. I simply ask my lab to give him some customized bands. They are not going into the interproximal contacts. They are more comfortable. The appliance is more precise. So the digital approach is also changing the way in which we are doing things. Always the same things, but in a better resolution. And we know that this applies advantages to our patients from the nasal volume perspective, from the tongue posture perspective, from the airways perspective. But pay attention, because we can cover all this problem only exclusively if our expansion is rapid. And when we say rapid, we mean 10 millimeter in 16 days, not an activation of one per day in 1 month. That is a slow maxillary expansion. If you want a rapid maxillary expansion, if you want to see a significant skeletal changes, we need to be rapid. And in particular, not only rapid, we need to overexpand. Look at this recent paper published by Professor Bashang, and we have a lot of information that there is a discrepancy between the amount of expansion that we do on the dental and the amount of expansion that we can see on the nasal cavity. So if you want to achieve a correction for the breathing problems, we need an over expansion. So we have all this information nowadays in the literature that are pretty clear. And so that's the reason why still these remain a fundamental appliance for what we are doing. But let's try to understand when we can use an aligner approach in our early treatment. And of course, when we compare these two different appliances that we can use in kids, we have on the rapid expansion on the side, we have, of course, a big orthopedic effect and a slight dental effects, while we have exactly the opposite when we are doing a slow expansion with a removable appliance, which is completely different. And in particular, we don't have any breathing effect. But of course, we need also to have compliance from our little patients when we are using this kind of system, of course. But generally, the overall experience is that kids are really so much compliant when we are asking for their collaboration. That means that looking at the previous indication I was giving to you, we can probably combine Invisalign first, but when we have a crossbite with a mandibular shift, we can probably use after. When we have a maxillary constriction, we can probably use after, depending on the severity of the constriction. When we have the space management, we can start immediately when we don't have a space problem or a bone volume problem. We can immediately treat patients only with aligners, kids. And in particular, when we have class 3, we can at the same time apply the system after the rapid maxillary expansion. Let's try to understand how this system is working. First of all, our indication can be always the same. So treating patients in the age between 7 to 9, let's say. We have the possibility to manage a proper arch development, and this is an easy indication, and an expansion that should be dental. For this reason, it could not be an expansion larger than 4 to 5 millimeter because it's only dental. But we can manage the spacing, we can manage the premature loss of the deciduous dentition, we can manage the crowding, and in particular, we can easily manage the anterior crossbite, for example, which is absolutely interesting in this kind of our patient. In particular, anterior crossbite means trying to create a better arch development with an expansion and a proclination of the incisor. And that will be helpful, for example, when we are going to manage the permanent dentition in the future, preparing, for example, the arch and leaving some spaces for the future eruption. So we can think in this direction. And this is exactly the way in which Invisalign First is working. We have different protocol of expansion. One is the conventional simultaneous expansion. One expansion that has been used in the literature, in the paper published on Invisalign First, is this kind of sequential protocol of expansion. So we first expand the 6, and only then we prepare an expansion of the deciduous teeth, C, D, and E. This is exactly the most common staging and protocol for expansion with this system. So we use the deciduous teeth to have the anchorage, and we start expanding the first molar, and then after we expanded the first molar, we have an expansion of the deciduous teeth, C, D, and E. To control this expansion, exactly as all the other smart force features of the system, we have some specific attachments that are creating extrusion at the same time of the expansion in order to control and minimize the effects of flaring of the posterior teeth. This is fundamental, in particular when we are trying to avoid any excessive expansion in the posterior. And finally, we have also, like we know very well, for all the kind of treatment of teenager, some compensation for eruption. So that means that, for example, if still we have lateral in a condition of eruption, we can plan an eruption compensator, so just a system that is waiting and preparing the space for the future eruption of the lateral incisor, canine, premolars, and whatever. But again, since I love to work at what the literature is suggesting and trying to apply as much as possible a scientific evidence in what I'm doing, let's see if we can find something on the literature about Invisalign first. And we found, interestingly, only paper coming from Italy. I don't know why, but the first one was this one from University of Varese in 2021 on the European Journal of Pediatric Dentistry, and they treated a small group of patients, 20, and they found that in case of mild or limited transverse maxillary deficiency, Invisalign First can be a nice option to have a slow maxillary expansion. At the same time, in another paper recently published from University of Rome Tor Vergata, which is exactly my university, with Professoressa Cozza, we know that when we are looking at the expansion with Invisalign First, they found that normally the greater expansion with this system is in the area of the deciduous molar. And this is pretty common. This is exactly what happened when we are expanding arch in an adult patients or teenager patients, and we see that the maximum expansion happens in the premolar area, exactly the same. And again, from this same university, the last paper was really interesting because was trying to compare the effects from a slow maxillary expansion with a conventional IRAX system with Invisalign First. And what they find is really interesting because they found that actually when you are looking at the arch shape with the IRAX, maintained the same triangular shape, while the Invisalign First was able to create, of course, a better arch shape. Well, this is pretty normal, I will say, to understand, because we are not comparing a rapid expansion with Invisalign First, but we are comparing properly a slow maxillary expansion with a conventional system like IRAX, or a slow maxillary expansion with a different system like the Invisalign First. So we have a lot of interesting information, but as you can see, they are all fresh papers published a few weeks ago, actually. So for this reason, we can select what to use in our daily activity, in our daily practice. When we have breathing problems, we know exactly what to do. When we have class 3 or a really severe crossbite. On the other side, when we don't have these really severe problems, we know precisely what we can do. Or even more interestingly, we can start a phase, an early treatment with aligners immediately after the rapid palatal expansion, for example. This could be a nice solution. And this is exactly what I did at the beginning with this system, trying to combine together the rapid maxillary expansion with Invisalign First. And this is exactly what I did in particular when looking at the maxillary constriction and when looking at class 3. So let me give you a clinical example of a young guy, 8 years old. We see immediately the small nose, the eyes, and so we realize that there is probably a non-perfect breathing procedure in this guy. we look at the profile, which is typical profile of a class 3 with a mid face, which is a little bit retruded. The situation is this one. So we don't have space for the eruption of all teeth. Look at the 2.2, which is exactly in a condition of crossbite in this moment. When we look at the panoramic, we have a really maxillary constriction, which is pretty severe because we don't have even the eruption for the lateral incisor. And when we look at the lateral X-rays, and in particular, we focus on the numbers. I like the numbers, even though they are not always giving us the proper direction. However, we are in a tendency of class 3 in this guy. So, of course, I'm focused in trying to do the best for this to fix this problem. And I know that the best in this moment can be only at the beginning, at least a rapid maxillary expansion, and then see what happens. And when I'm doing this in this kind of patient, I try to don't waste my time, but in particular, their time. And so for this reason, I use an expansion, as you can see, only on the ease, and this is my common approach. I remove the expander after 3 months only, and immediately I give a patient a temporary Essex retainer, as you can see, just to freeze and keep the position of the dentition after the expansion. And at that point, when I finally have the aligners, the Invisalign aligners in my office, I can start the treatment. So this is exactly the protocol. I'm trying to squeeze the time. I don't leave the IRAX after the rapid expansion for 5 to 6 months, but I try to be a little bit faster and see what happens. When I start, this is the shape of the maxilla after the expansion, but still, unfortunately, I have the lateral crossbite, the 2.2 crossbite. So for this reason, I'm using an aligner face. This is the slight expansion, as you can see. Most of the expansion was done with the IRAX, but look at the lower. I need some torque correction and some expansion. Why? Because we know that with IRAX, normally there will be a spontaneous self-expansion of the lower. This is what we learned. But when you remove the appliance a little bit earlier, and then when you put plastic, you can miss this effect. So for this reason, I'm compensating this effect by doing a torque correction and a slight space management and expansion of the lower jaw. Kids are wonderfully compliant, and this is what happened. Look at the beginning, sometimes in treatment, when we start aligners, finally we see the correction immediately of the lateral crossbite, and after a few months, only 30 aligners means 5 months of treatment, we can finish with a correction on transverse, sagittal, and vertical dimension of the malocclusion. When we are going to check if this one is matching precisely the digital, we should find always a really high superimposition between what we achieved in the real and what we were planning on the digital. This is fundamental. Let's take a look at the face of the patient in particular. This is the transverse profile change when we are looking at the smile in particular, but even more interesting when we are looking at the class 3 profile. And we see here how the combination of two systems created the proper profile at the end. So a more projection of the upper thanks to the expansion, but also thanks to the torque correction and the proclination of the upper incisor. So we can control the malocclusion even better. But this is for, let's say, mild class 3. What about a little bit more complex class 3? Look at this girl, 6 years and a half. When I see this kind of condition of class 3 at 6 years and a half, I need to start as much as possible. Also because, as you can see, we have vertical problems. There is no incisor guidance. There is no normal overlapping. We have not really a problem of space, actually, but we have a problem of class 3 tendency again. Let's see the space into the arch on the panoramic. As you can see, we have a constricted maxilla, not so severe, but we don't have the final space. Let me see the lateral X-rays to understand. Look at the proclination of the upper incisor. We have an edge-to-edge contact on the incisor with a clear tendency and a clear horizontal growth of the mandible. Let me show you in the numbers here. This is a little bit more severe class 3, in my opinion. Look at the number that we can see of the A and B, which is no more than 1 degree. And at this point, when we are looking at the shape of the mandible, we are in a condition of an horizontal grower. So, in situation like this one, I don't see so many options, to be honest. And so my plan here, again, is to create a transverse correction by means of a rapid maxillary expansion. And in order to be even more precise, I don't know if you had the opportunity to read this paper, which is pretty interesting. They are using a new system to assess the Walla ridge, which is one of the Andrews keys, actually, for the ideal occlusion. And if you trace on this picture, on the frontal picture, if you identify easily the line between the attached gingiva and the mucosa, and you try to measure between upper and lower, these two lines, blue and red, ideally should be equal. If they are not equal, and if the lower is a little bit longer than the upper, as you can see in this girl, that means that we have a transverse skeletal discrepancy. This is something easy that we can do simply with a frontal picture. We immediately understand if we have a transverse problem or not, looking at the Walla ridge. And this is exactly the problem of this girl. So there is a transverse constriction, even though when we're looking at the panoramic, seems that we have more or less the space for the canine eruption. So for this reason, again, I decided first to put a rapid maxillary expansion on the ease. Second, to use a face mask to have a little bit more protraction of the maxilla. And finally, I will remove the RMA after 3 months and starting with the same kind of protocol, a temporary S6 retainer until I wait for the Invisalign first to come in the office. And this is exactly what I'm doing. Look at the amount of expansion, 10 millimeters in 16 days. This is my rapid maxillary expansion. As I told you, I never, when I'm treating from 6 to 8, touch the 6. I only expand on the ease, and we know pretty well from the literature that this is working. So the 6 are following the deciduous molar expansion. But of course, at this point, what happened? Look at the big space between the central incisor. First of all, it happened that the parents call immediately and say, something strange happened in the face of my kid. I see a big window, a big space between the central incisor. Second, of course, if we don't pay attention, what is happening is that immediately we see a mesial tipping of the central incisor, and so that are trying to close this big gap. So for this reason, I published recently in the number of July of the JCO this system that is a way to avoid exactly this mesial tipping of the crown of the central incisor after a big expansion like this one, after a rapid expansion like this one. What I'm doing is creating a bridge of composite, which is connecting the two central incisor. Then I simply cut this bridge, and every month until I'm going, to remove the appliance, I reduce the space and I cut again every month this bridge. In this way, the central incisor are going to touch month by month, and this will minimize at least the mesial tipping coming from a rapid maxillary expansion. This is exactly what happened in this girl that I was showing to you. This is the big expansion with it. This is the G bridge. This is called the bridge. And this is what happened month by month in, let's say, 3 months from the expansion. So we can easily control the mesial tipping. At this point, I can start, since still I have an anterior contact and I have to manage the space, as you can see here, and I have to manage also the lower space because I have a lot of spacing in this girl, and it is a class 3. So I remove the IREX, I remove the face mask, and at this point, I am ready to start with my Invisalign treatment. The number of aligner is around 20. Generally, when I'm treating kids, I'm changing every 5 days because of the level of cytokines and the bone turnover, which is faster than teenager. So no problem in changing every 5. And in particular, as you can see, I'm trying to minimize the movement. I only move the teeth I really need to be moved. Okay, this is this fundamental approach. As you can see, I'm always leaving some spaces, mesial and distal, to the deciduous canine, because we know that the eruption of the permanent canine can be a problem because permanent canine are larger. And so I'm trying to control this one. Look at the expansion. A big expansion on the E's with a scissor bite doesn't mean that the 6 are following. Normally the 6 are in a perfect occlusion when you expand so much. So this is the situation once I started the treatment. See the number of attachments needed to control the fitting of the aligners in kids. We can easily combine elastics in a patient like this one. And also in this, we have a lot of cooperation from the patient using class 3 elastics, I will say short, from the first molar in the upper to the canine in the lower. And in this case, we can easily control also the inclination of the incisor. So we can increase proclination of the upper, we can increase the retraction on the lower. And this is what happened when we are mostly at the end of this treatment. See the space that I'm leaving for the canine eruption. I have no interest in creating a perfect occlusion now. This is an interceptive treatment. I just need to remove the problem and then leave the nature do the rest. And this is exactly the approach. Look at the difference. Now we created a normal overjet, a normal overbite with a larger and a bigger, wider expansion of the maxilla, re-equilibrating the transverse skeletal discrepancy. And this is exactly following what I plan on my clean check. So again, there is a nice superimposition of results. But this is when we are combining these two appliances. There are some easier, let's say, condition in which we can start immediately instead with only with aligner, with an early aligner treatment. For example, when we have a missing space for the lateral incisors, missing space for the lower canine, we have a constricted condition, but we have some missing second premolar, so we are not so worried about the space. But in a case like this one, we can use our system, again, with the same more or less number of aligners, never more than 30, trying to recreate the proper space for the eruption of the lateral incisor. So in this case, I'm not worried about creating an expansion if I don't have a breathing problems. I can manage everything with a dental expansion. I can manage only creating the proper space for the future eruption of the lateral incisor in this case and canine in the lower. This is exactly what happened in 6 months. You see the space that we are able to open. The lateral incisor is arriving thanks to this space, and this is what happened as well on the opposite side. When we control the panoramic, we see easily how can we manage to achieve a nice results in this kind of patient. But another common indication, in my opinion, when we are treating kids with this system is the anterior crossbite. And it's pretty common. It's pretty common. In particular, in my country, it's pretty common that we see kids with an anterior crossbite. Can be one incisor, can be one central, one lateral. But however, pretty commonly, I see kids with this kind of anomalies of eruption, let's call. And this is always a problem that sometimes is bringing together not only the wearing on the enamel of the central incisor, but also some periodontal problems sometimes into the because of the contact with the lower incisor. And of course, the question is always the same. Do we need an expansion? Look at the space here. We don't have any problem of space in this girl. Let's see the lateral X-rays, because again, it's always the diagnosis that should lead our choices. And when we look at the numbers here, we are in a class 1, so there are no problem at all. There is a normal development in the growth of this girl. So for this reason, my problem is only dental. If the problem is only dental, I can treat in 3 to 4 months this problem. How? I start immediately asking for an Invisalign, an aligner system with Invisalign. I'm asking for 17 aligners, in which, again, as you see, I'm proclining the upper incisor. I fix the crossbite by a proclination of the central incisor, and I'm expanding also the rest of the maxillary arch. Look at that. But it's a slight expansion. We can control even better expansion with this system than any other slow maxillary expansion. I do distal rotation of the 6, distal rotation of the D, and in the lower, I'm just moving what I need to be moved. Look at that. In this way, I minimize the movement. I can be more efficient and, in particular, more predictable. And this is exactly the reason why anytime I'm treating kids with Invisalign, I'm trying to be fast as much as possible. Remember, compliance is fundamental in a removable system. And for this reason, if we can go faster, this is even more interesting. I change every 5 days, as I told you, in kids. There were 17 aligners in this girl. So that means that in 3 months, I can achieve this immediately result. Nothing special, easy case. But of course, this easy case is bringing a better smile for this girl. And so this means, in particular for us, a better incisor relationship. That means avoiding any problems in terms of wearing in the future. When we look at the X-rays at the end, this is first of all before and after, as we can see here. And in particular, how this before and after is following exactly the digital project. Look again at the X-rays and we find exactly that we have no need and we did the right choice in non-expanding. As you can see, there is a normal eruption stage. And in particular, we are still in a condition of class 1. So it's exactly a easy condition treated in a really, really fast way. But we are not always so lucky, because sometimes can happen to manage complex conditions. And let me show you this guy that represented a really complex malocclusion as a phase 1 treatment. First of all, because unfortunately this guy has got some special need, let's say. And second, because he came to me with this kind of strange condition, a class 1, a really severe V-bite, but we know that this is not a common condition to start the treatment early. But what is really strange is the space management in the lower. So this is a really severe crowding. In the upper, when you compare the maxilla and the mandible, seems to be 2 different patients, actually. They don't seem to be the same mouth. I look at this panoramic, and probably he did something not with me in the upper, but this is the crowding that we have in the lower. So we have a big problem of space management in this patient. And when we look at the lateral X-rays, look at that. We are in a class 1, but let's try to understand better in numbers what happened. So we are in a class 1, in a class 2 really condition. We have a normal FMA, but when we are looking at overjet and overbite, we are in a really large number. 9 overjet, 6 overbite, and the upper and lower incisor inclination seems to be too much vertical, in particular, the inclination of the lower incisor. So the problems is mainly the crowding, and we know that not always crowding is a condition for an indication for the early treatment. But we also know that in a crowded condition like this one, the hygiene problems are really high. So, and in particular, as I told you at the beginning, this is a kid with some special need. So it's not easy to treat him. It's not easy, and in particular, we don't have space in this area. What we can do alternatively, because in my treatment plan, I can think about an extraction, for example, on one incisor. Or in my treatment plan, I can think about serial extraction. So first the deciduous first molar and then the first premolar. But of course, I have a problem to manage, which is the poor cooperation in terms of supporting the anesthetics of this guy. So let me think about something alternative. That could be, for example, a lower expansion. Look at how negative is the torque of the posterior teeth when we are looking at the model. And so we can find probably some space by giving a torque correction, or even more interestingly, we can procline. But the huge problem here is not only a proclination that can give us the space. The problem is the distance of the apexes of the lateral incisor from their initial position to their ideal final position. This is the big, big, complex problem. So if we try to avoid any extraction for this guy, because this is in particular the request for the parents, the huge problem would be how can we manage this movement? And in particular, the problem of management of this movement is not related to the appliance we are using. Because if we try to do the same with a fixed appliance, it will be complex as well. So there are no complexity related to the tool we are using, but is a complexity itself. So for this reason, we tried, however, to plan an Invisalign treatment around 13 aligners, 30, 31, that are doing this one. First of all, slight expansion in the upper with the protocol, first the 6 and then the CDNE. And this is easy, reliable. And in the lower, first the transverse correction with expansion and the torque correction of the lateral sector, as you can see, and then the proclination of the incisor. Of course, it's a long, long, long journey that this lateral incisor should do in order to arrive to an ideal final position. When we look at the number, there is more than 4 millimeters of displacement of the apex of this lateral incisor, which is pretty big and it's really complex. But however, I try to do my best. I try also to plan the attachments, as you can see here from the lingual side, in order to control this movement. I'm pushing from the lingual side, I place attachment on the lingual surface. And I try in this way, as much as I can, as much as the system can give me, to achieve a correction that will move the apexes in a more buccal position. So giving buccal root torque. This is the beginning. And this is what happened after the first set of aligners. Look at the deep bite that has been improved, but look at the 3.2. Now is in a more interesting position. But when we look at the 4.2, we still are in a non-ideal condition. Actually, was probably the less favorable movement that we have in this specific treatment plan. At this point, since I spent only 5 months, I decided to have an additional phase. Generally, I don't do so much additional phase in kids, but in this case, since the movement was really, really complex, let me try again. So let me spend other 5 months in order to control, and in this case, as you can see here on this specific movement, trying to over-engineer what I'm doing. What does it mean over-engineer? Let me overcorrect the final position of the lateral incisor in order to really move the apex in a more buccal position. Most commonly, what happens when we need a root movement is that we are obliged to overcorrect. This is something that we do anytime when we are extracting, when we want to exert more torque. So we need to give a final position on the digital setup, which is a little bit more exaggerated than the final position that we do expect in the real. And this is exactly what I'm going to do in this guy in this moment with other 31 aligners changed every 5 days. And this is the final result. You see here in the upper, we are changing the exfoliation of the deciduous molar as well as is happening in the lower. We are in a correction of the bite. Is not, of course, a perfect class 1, but for sure, now I can stop and I can leave the nature do the rest. And I will fix everything in the phase 2 of the treatment. So we don't need to be too long in our phase 1. This is the smile of the guy at the end with the same profile. And if you think that I expanded too much, when I'm going to check really what happened, on the molar, I will expand 3 millimeters on the permanent molar. Exactly as the indication from the work of Professor Cozza from the comparison, the maximum expansion is in the premolar, in the deciduous molar area. And you see here the 6 millimeters of the second deciduous molar and the 6 millimeters in the area of the first deciduous molar. This is the difference when we are going to see the pre and post between pre and post in the upper, pre and post in the lower. Still, as I told you, not perfect, but was not the goal of the treatment. The goal of the treatment was trying to give this guy, this kid, the opportunity to better clean his dentition. This is the situation when we are going to compare the real and the digital. And as you can see, there is some discrepancy between real and digital in the region of the 4.2 in particular. But what about the skeletal effects of what we did? Still, incisors are inside the bone, the lower. So the proclination has been planned, but as you can see, was a change of 6 degrees, and still, when we are looking at the position of the lower incisor, they are in a healthy position inside the symphysis. When we look at the overall malocclusion, we have a reduction of the class 2. We have a reduction of the FMA because of the thickness of the plastic, probably. And we see, for all the rest, an improvement in the value of the overjet and overbite at the end. And this is exactly what we expected in when we are going to see the comparison between pre and post lateral cephalometrics and the superimposition together with the morphing effect of what happened in this guy. So I can, of course, now retain this condition. So I leave the patient with an Essex retainer nighttime for at least 4 to 5 months, and then I will stop and I will wait some years for the phase 2 of the treatment. We see here the difference in the space distribution between upper and lower and between pre and post treatment of this guy. So, trying to achieve some conclusion in the time I have. As I always say by joking, I'm Italian, but I try to be always on time because probably there is a Swiss origin in my DNA. So for this reason, I'm getting to the conclusion easily. Okay, first of all, when we have the indication, and in my opinion, this is the most important part, when we found an indication for an early treatment, we should always understand from the scientific evidence which indication we have. And in particular, we should try to follow also the indication to use an aligner in the early treatment stage. And I hope that I gave you this information on when we can easily and successfully use aligners in the early treatment. But if you are going to do that, pay attention. One thing which is fundamental is that we don't need more than 5 days change. Why? The answer is in this beautiful paper published from the Nijmegen School from Professor Kupes Jachtman that you can easily check on the Journal of Periodontology. And what is interesting that they measured the level of the cytokines in teenagers, adults, and kids subjected to orthodontic treatment. And the level of cytokines that are the mediators for the turnover of the cells, osteoclast and osteoblast, is pretty high in kids and is pretty low in adults. For this reason, there is no sense in changing every 7 days in these patients. The only problem is that we normally are working with short clinical crowns. And of course, that means that the retention of the aligners can be less. For this reason, we should compensate the short clinical crown with a large number of attachments. And since we are treating kids and we can manage the spaces for the future eruption, it makes sense that when we are facing this kind of treatment, we leave a proper space, mesial and distal, to the deciduous canine, so that the permanent canines can find all the proper space when they will erupt. And as you notice from what I showed to you, one fundamental approach is trying to remove all the non-necessary movement on the deciduous teeth. This is fundamental because, again, we are not looking to change everything. And since the software is giving us a lot of movements, if you want to be more efficient and if you want really to be as much as possible predictable, we need to remove all the movements that we don't think are absolutely necessary. For example, on the deciduous teeth, So that means root tipping, some specific amount of intrusion of extrusion which is exceeding 0.5 millimeter, and some rotation which is exceeding 5 degrees if we don't really need, again. In this way, we can increase predictability and we can be more efficient and more fast. And finally, concluding, pay attention also to how much expansion you are planning, because sometimes can be a violation to the biological limit of our patient. So for this reason, it's fundamental that we still follow all the tools that we have to understand how much we are expanding. And today in the software, we have the possibility to measure immediately before approving a clean check. We have an idea on how much we are expanding. Thanks to the use of this dynamic ruler, we can understand precisely how much we are expanding, and we can set or sometimes reduce our expansion in order to avoid any possible problem. So in the word of Gianelli, aka or my mentor, the ideal treatment in kids is the shortest, less energy waste, highest patient satisfaction. And I strongly believe that in a combination or even with an exclusive approach of this system, we can reach a really successful treatment in a really short time. I thank you so much for your kind attention at this conference. Thank you so much.
Thank you very much.
Thank you, Dr. Greco, for a wonderful presentation on interceptive orthodontics using Invisalign first approach. Now I would request our chairpersons, Dr. O.P. Kharbanda and Dr. Vasundhara Bhatt, to please hand over the certificate of appreciation to Professor Alessandro Greco. Now I would request our scientific convener, Dr. Gauri Vichare, to please hand over the certificate of appreciation to our chairpersons, Dr. O.P. Kharbanda and Dr. Vasundhara Bhatt. Our next lecture is the Sable Memorial Lecture, which is being delivered by ex-chairman IBO, Dr. Ketan Vakil sir. I welcome our chairpersons for this session, Dr. M.K. Prakash sir and Dr. Usha Malkhani. Well, Dr. M.K. Prakash does not really require an introduction. I have been asked to introduce Dr. M.K. Prakash, but he really does not require an introduction. But as a protocol, I would still say a few words about Dr. M.K. Prakash. Dr. Prakash is the giant of orthodontics in our country, who has been practicing for last 54 years, or probably more than that. He is currently director at Dental Specialty Center, Bombay Hospital Institute of Medical Science and Research Center. He was professor at Nair Dental College, and subsequently he has been a professor at D.Y. Patil Dental College, Navi Mumbai, for the Department of Orthodontics. Dr. M.K. Prakash was the first one to introduce the concept of straight wire appliance in our country. He is the one who also introduced all of us to skeletal anchorage system, or the TADS. Dr. Prakash has been the ex-chairman of Indian Board of Orthodontics, a fine clinician with a lot of passion for orthodontics. He was the first Indian to attend the Moer Symposium. I think 2 minutes are too less to introduce Dr. M.K. Prakash. Dr. Usha Malkhani is a student of Dr. M.K. Prakash from Nair Dental College. And she is a fine orthodontist who is now into social work. Welcome, sir.
Good afternoon. It's nice to be here. And it's an honor that has been bestowed on me to pay tribute to one of my best friends, a loyal, honest, upfront clinician. And his Karma Bhumi was this very place. I like to relive his life for the next 10 minutes, next 4 minutes. And I will give the honor to Ketan's hand. In 1951, in the hinterland of Maharashtra, in a small village, a farmer's family had a son who was 1 in 5. He had 4 siblings, 5 siblings, if I'm right, and in a very small household which they had allowed some land, and they cultivated vegetables and sold it in Bombay. That's how he started life. And from there, he surprised the entire village by saying that I need to go to school, finish school, and yet end up in a college, which was unheard in that particular village. But this man, nothing could stop. So he went on, he finished his SSC and went on to SP College in Pune, this very city. Finished his into science, and his ambitions did not stop there. He wanted to do dentistry. Remember, not medicine, dentistry. And nobody knew what he's up to. However, somehow he managed to get into Bombay, get into Government Dental College, which was the prime college then, as a student in early 80s, early 70s. And what he did is the family was so poor, they had a shop in a wholesale market in Baikala. And his brother was living, and this guy went and lived with him. And I still remember, he has told me that he read Gray's Anatomy sitting in the street light. That's where he came from. And he got his BDS, top of the class. And those days, when you're top of the class, you become an orthodontist. You don't even think of anything else, right? He became an orthodontist. Unfortunately, that's the year I left GDC and I joined NAR. But this man was always loyal, great student of Dr. Sheikh. Finished his BDS, got into orthodontics, finished his program first shot in 2 years. Those 2 years program was there. And I was his examiner. And he amazed me with the dearth of knowledge. End of the day, he became a lecturer in GDC. And Dr. Sheikh was our teacher, my teacher, his teacher. He went away to Libya, and he wanted an assistant. I was slated to go. But the old man said, no, not you, him. I mean, of course, my question was why? It's because he deserves that more than you. Hands up. He goes to Libya. He works with the old man for 3 years. And 1985, he comes back. Then he says, straight comes to my office. He says, what do you want to do? I want to start practice. I says, you had the teaching in you. Yes, but I need to practice clinically. He opens up a clinic in this very city in 75, and concentrates on only orthodontics. He's one of the few orthodontists in Pune that time. Dr. S.S. Joshi was the one, and number 2 was he. And absolute dedication to clinical work. Then he goes on to do higher things. What do you mean by higher things? He gets his board, he becomes a director, he becomes a chairman. But I tell you, his passion was teaching. He goes back to this institution later and starts the orthodontic department. and he has graduated so many students from this particular. Such a straight and a strict disciplinarian. I'm sure a lot of students were there. Yeah. There are a lot of students who are here who will remember that's him in his undergrad days with some of his friends. Those were the days. We had the long side locks, remember? You never cut your hair. An absolute fitness addict. He would run marathon, he would do long distance, he would be slim as ever, eat as less as he can. All this, unfortunately, somewhere down the line, he turned diabetic, but not a single sign, everything under control. And the moment he passed out and he wanted to do something in life, that was the thing. I'm sure he has graduated more than 40 students from this institution. Let me ask one student here, wasn't he impossible? I'm sure you guys were scared of him because that's the level of, strictness he did. He brought even the worst student to do the needful. But at the end of the day, if you go with some problem, he was the first man to help you out. But the fate had other things to him. We lost him. So sad. And I'm here to relive his memory, and I'm sure you will all enjoy it too. I'll hand over to Usha to introduce the speaker. Thank you so much.
Dr. Ketan Vakil has had the honor of giving this Dr. Sable Memorial Lecture today, and he is like another Dr. Sable. He has graduated from Nair Hospital Dental College, Mumbai in 1978 and finished his MDS from the same Nair Hospital Dental College in 1980. He is a diplomate of the Indian Board of Orthodontics in 2001 and former head of department and PG guide in Department of Orthodontics, SMBT Dental College. He is the past chairman, Indian Board Orthodontics from 2019 to 2021. He presently holds the position of Professor Emeritus, SMBT Dental College, Sangamner. He has lectured exclusively at national and international conferences and conducted workshops for orthodontists and published several articles in national and international journals. Friends, please join me to welcome Dr. Ketan Vakil.
Thank you so much, M.K. Prakash sir and Dr. Usha Malkani for the kind words of introduction. First and foremost, I would like to thank the COD of the 56th IOC, particularly the scientific committee, for inviting me to deliver the prestigious R.B. Sable Memorial keynote lecture. Now, before I begin with my talk, let me recollect my memories with Dr. Sable. In fact, Dr. Sable must be about 5 to 6 years senior to me, and I never met him, I never interacted with him, because I passed from the Nair Hospital Dental College way back in 1980, and immediately after passing, both of us had one thing in common, that both of us had one thing in common, that we did not have any base in Mumbai, nor did we have any financial muscle to settle down in Mumbai. So he went to Libya, and I went to my native place, Surat, in search of greener pastures. We did not interact with each other for almost a decade, and I did not know. Then the first tsunami came almost after a decade into our practice, and we were practice what we knew best, the bake technique. So after about a decade, we were all exposed to the pre-adjusted edgewise appliance, And we were probably the first few who recognized that it is time to change for the better. And we started learning and exploring the pre-adjusted appliance. So we were the common audience, whether there was a course conducted by Dr. Dale Wade on bioprogressive or Dr. Vic Alexander on the Alexander discipline or by our own Dr. M.K. Prakash sir. Then it so happened he is a wonderful person. That is when we started interacting with each other. A great clinician, passionate teacher, an enthusiastic learner, and honest and humble human being whose aim in life was excellence, improvement, and upgradation. This is when Dr. Sable traveled to Sangamner when Dr. M.K. Prakash conducted a hands-on course on microimplants at the college. In fact, quite often it used to happen that Dr. Sable used to travel from Pune to Mumbai. I used to come from Surat to Mumbai just to attend a half-day meaningful scientific program conducted by the Bombay Orthodontic Study Group. Little did I know that this would be my last banquet with him. Now, what do we look for as a clinician? One, non-compliant appliances, clinician-friendly appliance, predictable results, and minimal or no side effects. So we normally look for, I'm talking about my practice, every time when I evolve, I look for these 4 factors and then adapt to a new appliance or a new modality of treatment. Now, before I start with the TADs and other things, one topic which was very close to Dr. Sable's heart was finishing, detailing, and stability of results. So let me start with a very simple case, a case which we come across in our day-to-day practice every day and which forms a large bulk of our practice. Typical bimaxillary protrusion case, bimax profile, incompetent lips. Intraorally, she had quite a few problems. There was initial signs of periodontal breakdown, particularly on both the lower canines and the lateral incisor. There was incisal damage on the upper right lateral incisor. Because of the position of the teeth, we did some atypical extractions and finished the treatment predictably with the standard mechanics that we all follow day in and day out. And we achieved good results way back in 2014. So we started in about 2012, and this is where we finished. Then usually what happens, these patients bring along their relatives and other patients for treatment. She came back almost after about 29 months, and the results were stable. The periodontal health also was maintained fairly well, and we were quite happy with the results. The profile of the patient after 29 months, and then she came back after 8 years. The profile was well maintained. She had become a woman, and the occlusion also was very well settled there. This is the case 8 years post-retention. Now, plain simple bread and butter case. Now, how do we do it a little differently in our practice? Because the moment I shifted from Beck to pre-adjusted appliance, we were all very much influenced by Dr. Vic Alexander. So most of us, and even today, I prefer a 18 slot over a 22 slot. The models, patient at 2012, 14, and 2022. So what do we do a little differently because of the problems associated in space closure? One, torque loss of the anteriors, either due to an undersized wire or heavy force or frequent activations. This is all this we face day in and day out. Tipping of the second premolars if it is not engaged properly, and binding of the wires if at all there is any kink. So you never, when you give a curve also, never do it with a plier, do it with the fingers. So we started using the Gianelli bidimensional technique almost 12 to 14 years ago because it was just a minor shift from what we were doing. We were using a 18 slot, so we started using a 22 slot in the posterior segment and did retraction as popularized by Dr. Maria Grasso way back in 2007. Posteriorly 22 slot, anteriorly 18 slot. So what are the advantages? One, better torque control because you have inserted a 1725 wire into a 18 slot. So you have just a play of 001, so torque loss of about 4 degrees. As compared to a 1925 in a 22 slot, you lose about 12 degrees or 13 degrees of torque. So biomechanically, this is much better. Posterior segment 22 slot, 1725 in a 22 slot, better sliding. And finally, the arch form is maintained because it is a continuous arch wire. But it has its disadvantage in the form of additional cost. But we had little additional cost because we were always using a 18 slot. But we had to maintain the inventory separately, specifically. Then again, after about a decade or so later, the second and a bigger tsunami came in the form of TADS. And we started learning TADS, whether we went to Korea or we listened to the Korean speakers here, or whether we attended the courses conducted by Dr. M.K. Prakash, many times. So microimplants and bone screws have brought about renaissance in the field of orthodontics. They are an added armamentarium for the clinician, especially when treating complex and challenging cases. Now, there was an interesting study done in the JCO where they asked as to what was the biggest game changer in orthodontics for the past 25 years. Undoubtedly, it was TADS. Even in textbook way back in 1988, and the bioprogressive technique by Dr. Robert Murray Ricketts, Bench, Gugino, and Hilgers, they also said that the posterior anchorage is much less in the upper arch as compared to the lower. Second, the bone porosity is much more. So inherently, you have less anchorage in the upper segment. So quite often, even when beginning a bimaxillary protrusion case, even if the molars are seated properly in good class 1, you might have to use a microimplant to enhance the anchorage, or at the end of treatment, if you feel that there is a little slippage of the molar anchorage. Because unknowingly, before the TADS, we used to use some class 2 elastics because there was a little slippage of the posterior occlusion. This is very important. We have to understand this. Earlier, we used to retract the canines individually, followed by anterior retraction, or a lot of us had started using the distalization appliance. But all this was always causing some amount of round tripping to a smaller or a greater extent, depending upon the anchorage used. Not anymore. You can retract the 6 antennas simultaneously, or you can retract the entire maxillary or mandibular dentation simultaneously. The other myth which has been cleared was about categorizing each and every case into 3 categories: maximum anchorage, moderate, and minimum anchorage. Minimum anchorage, we had learned that you extract the second premolars, do a little bit of decrowding, and maintain the profile of the patient. Not anymore. Now, the extraction of or sacrificing 4 second bicuspids is out of our clinical syllabus now. A good study was done by Dr. Minho Jung, where the amount of retraction was similar with second premolar extraction or in cases with en masse distalization. Now, let us begin with certain cases where TADs were used and which probably would have been very difficult with the conventional mechanics which we are so used to day in and day out. A patient with a gummy smile, and the patient also complained of retruded upper anteriors. The pre-treatment photographs of the patient. Intraorally, there was 100% deep bite, contraction of the upper and lower arches, particularly the lower arch was severely contracted. 7 millimeters of overbite, V-shaped upper arch, which was symmetrical. Lower arch was also symmetrical, but there was a crowding of about 4 millimeters. Curve of P was flat. The pre-treatment cephalogram, the tracing. Cephalometric analysis showed that she had a class 2-ish skeletal pattern because of the mild retrusion of the lower jaw and retroclination of the upper and lower incisors. We placed 2 microimplants in the anterior region distal to the lateral incisor to bring about intrusion of the anteriors. Nowadays, what we do is we prefer to place the post in an inverted direction so that you can easily apply a single strand of elastomeric over there so that it is better to maintain good oral hygiene. That is one thing. 2 strands of elastomerics probably will cause some gingival inflammation, because in this particular case, the oral hygiene was fairly good. But sometimes when there is some gingival overgrowth, both the strands may not stay. Secondly, it is also very important that when we place the microimplants in the anterior region, particularly 2 microimplants, it is very important to place it at the same level in order to prevent any iatrogenic damage to the arch. The smile of the patient after intrusion of the anteriors and the occlusion at the end of treatment. Earlier, it was so difficult to intrude the anteriors. We used 3-piece intrusion arches or cantilever springs and other things, and we could hardly get some amount of intrusion. The patient at the beginning and at the end of treatment. The probable reason for stability was good posterior occlusion and correction of the axial inclination of the anteriors. Models of the patient. In the textbook, it is clearly mentioned that bilateral microimplants, one has to be very careful that you don't cause any iatrogenic canting of the occlusal plane. That is why now with the post pointed downwards, it doesn't happen. But we always tell the patient that if the elastomeric on any one side comes out, he has to report immediately so that we can place the force bilaterally simultaneously. So it prevents any side effects. Secondly, in the textbook, it is written that you might place the microimplants in any of the 3 positions between the central incisors if you want intrusion of the anteriors and labial flaring as is required in the case. Most preferred place is distal to the lateral incisor, where the force is passing through the center of resistance of the anteriors so that you get bodily intrusion of the anterior teeth. Because as it is, you have a rectangular wire, so you have already controlled the torque. So it is only bodily intrusion that is required in the case. If the implant is placed distal to the canine, you get intrusion and distal movement because the force is away from the center of resistance on the lingual aspect. Another case, same girls, similar smile, similar result. You can see the distance between the implant and the arch wire also reduces. And this has to be followed with gingival surgery, crown lengthening surgeries. The other thing, therefore, in clinical practice also, it is very important to identify as to how much intrusion one wants. So whatever intrusion is required for the particular patient, it is advisable to place the microimplant about a millimeter above that area, so that in practice you don't have to reposition the implant which the patient may not like. Then the implants can also be used for anterior posterior movement of the posterior segment. The microimplants or the interradicular screws. Now normally it is advised to place it between the second premolar and first molar, most common site, and we mark the center line. We normally mark it with the periodontal probe, and we mark the mucogingival junction. So we know where the center line is, we know where the mucogingival junction is. I've never ever used any grids. And after we mark that line, biomechanically, one can place the implants in any one of the following places, A, B, C, D, or E. So it is better to do the homework, check in the patient's model, cephalogram, whatever, to find out as to what is the requirement for the microimplant. Therefore, where do I place it? If you have to place it in position A, which is at a higher level, it is good for anterior retraction and intrusion because the implant is at a higher level, so it will inherently have an intrusive force with it. Position B will be for anterior retraction with less amount of intrusion. D would be posterior, C would be posterior protraction and intrusion. D would be posterior protraction bodily if you don't want any intrusion. And position E is advisable for posterior intrusion in open bite cases. Of course, this has to be complemented with the anterior post which has to be used so that you can alter the occlusal plane. Interesting textbook by John Sung Lee, Vanasdal, Yongchel Park. A girl, typical bimaxillary protrusion, incompetent lips. The patient was also concerned about the shift of the upper midline to the right side. The patient specifically told that the midline is shifted and it doesn't like, apart from crowding. Intraorally, there was crowding in the upper and lower arches. Because of that, the oral hygiene also was compromised. Canine was completely blocked. That is why the upper midline is shifted to the right side. This was probably one of the rare cases where on the day of bonding, we placed the microimplant. We placed the microimplant, started with leveling and aligning in the anterior segment, and also started the blocked out lateral incisor. So in order to slightly reduce the treatment time. Then when we finished with the leveling and aligning and we went to the rectangular wires, most of the space on the upper right side had closed, but rest of the space had to be closed with the support of the microimplants in the upper arch and conventional sliding mechanics in the lower arch, because more space had to be closed on the left side and the midline got automatically corrected. See, the patient was a high angle case to begin with, so we did not use any class 2 elastics in her case. The patient at the end of treatment, there was some amount of gingival loss at the start of treatment, but it was maintained fairly well. The profile of the patient at the end of treatment, the comparison of the cephalogram. Now, I'm not going into the details of the cephalometric analysis because I think this both the cephalograms are self-explanatory, that the implants have completely retracted the anterior segment. The patient, after 1 year, the occlusion had settled very well. The midline was matching. Patient was happy. The smile of the patient was good, even better. So patient at the start of treatment, at the end of treatment, and a year later. Another case, similar result, bimaxillary protrusion, incompetent lips, short upper lip, and everted upper lip. So these are difficult cases, but she did not have any gummy smile. Again, bad crowding, bad oral hygiene, some amount of recession of the central incisor and the canine. Again, atypical extractions and retraction in the upper arch completely with the help of microimplants after leveling and aligning. The patient midway into the treatment and the change in the patient's profile at the end of treatment. Complete retraction was done. Normally what we do is, even after the complete space closure, we continue with the retraction for about 1 to 2 visits so that we get en masse distalization even further if that is available. That will be for our advantage. Here you can see on the left side, the molar relation is super class 1. So we had done slight amount of overcorrection in her case also. The upper and lower arches, models, comparative cephalograms. Again, no need for cephalometric analysis in this case. One can easily make out that the anterior segment has been retracted completely with the help of microimplant. So this is a big boon. Earlier we were applying so many auxiliaries to control the anchorage. Now life has become simple for us, simple for the patient. Comparison. And again, the patient after a year, everything was settled well. Patient smile improved even further. There was more competence of the lips because the child was growing. Now, we also tried to place microimplants, interradicular screws for en masse retraction in cases where the molar relationship was completely class 2. And there are a lot of case reports, particularly by Chung et al. Or Singo Koruda and others, where they have shown series of case reports by placing implants first between the second premolar and first molar, start with the retraction. After some time, when you feel that the retraction is settled down or it has slowed down slightly, they relocate the implant distal to the first molar between the first and second molar. Now, I even tried in my practice to slightly angulate the bracket of the second premolar by about say 5 degrees or so that you get more interradicular distance in an attempt to retract even further. But relocating the implant distal to the first molar, in some of the cases, it causes a little problem, particularly in a curvy child, where you have to retract the lip cheeks further and place the implant distal to the first molar. In that case, it will be quite difficult sometimes to place it exactly at 90 degrees. And because of the pressure of the cheeks, the handle might move slightly forward by about, say, about 5 degrees, and the chances of hitting the root of the second molar may increase. So we had done a few cases. Then we thought, let us start placing microimplants on the palatal aspect. So we placed the implants on the mid-palatal region, and we also placed the implants on the palatal alveolar region. A girl, growing girl, severe proclination of the upper teeth, maxillary protrusion, mandible was fairly normal. She had a gummy smile, so anterior posterior correction and gummy correction, that was both the things were necessary in her case. Intraorally, she had 13 millimeters of overjet and a single deciduous lateral canine which was over-retained. So we had a little bit of space in the upper arch. After consolidating the space, we placed just a single microimplant in the mid-palatal region and retracted the entire maxillary dentition with the amount of force that has to be given for en masse distalization of the entire arch. In 2011, this is where we could finish her non-extraction. The occlusion of the patient at the end of treatment, I'll come to how did we do the anterior posterior correction, how did we bring about the class 2, full cusp class 2 relationship into class 1, and how did we correct the gummy smile, and how did we get the intrusion and correction of the deep bite with a single mid-palatal implant. The cephalogram, again, it shows the amount of proclination to begin with, 13 millimeters overjet and corrected very well. She was a patient with high mandibular plane angle, gummy smile, so we did not use any class 2 elastics in her case. The analysis itself tells skeletal, there was a class 2 correction with the help of implants, good correction of class 2, and the GOGN to SN, which was 37, remained 37. Practically, it is 37. So we did not open the mandibular plane. That is important. Dental correction, tremendous. Upper 1 to NA from 45 to 24, 16 millimeters to 6 millimeters, and definitely a good correction of the nasolabial angle. Treatment before and at the end. Now, in literature also it is written that when you place a microimplant in the mid-palatal region, the line of force passes to the center of resistance of the maxillary dentition. That is the reason why you can get a retraction and intrusion simultaneously. Now this is true only for placing implants in the mid-palatal region. I'm not talking about the entire palate. Now if we divide it into anterior 40%, middle 40%, and distal 20%, the middle 40% of the mid-palatal sagittal area is a safe area to place the mid-palatal screws. Good amount of cortical bone availability. Now this was the cephalogram of the same patient, where you can see the head of the microimplant there and the line of force which is passing from the head of the implant and the lingual aspect of the central incisor. So there is a distalization intrusive effect in the entire maxillary dentition. That brought about the change. Now, what are the advantages of palatal implants? Good primary stability because availability of cortical bone, does not impede in the amount of tooth movement. Unlimited tooth movement is possible with this. And because of the availability of ample palatal space, the line of force of application can be altered according to the type of tooth movement that is required. It has its disadvantages. Discomfort because of the encroachment of the tongue space. Line of action of force, if it is not correct, not properly oriented, will cause more problems than good. For example, it is said in books also that if in a dolichofacial patient, if the vault of the palate is very deep, the line of force will be away from the CR or the maxillary dentation, and that will cause distal tipping of the posterior. So it may not be advantageous in all cases. Hard bone, strong cortical bone will have more insertion torque, and the chances of breakage of the microimplant might increase because it is a titanium alloy. And in growing patient, maybe it may affect the sutural growth. So normally in growing patient, what we do is we place it about 2 millimeters away from the mid-palatal area and then angulate the head of the implant so that it remains in the mid-palatal region. It can be corrected that way also. Incidentally, this was published. Then long-term results of this case. Patient came back after 11 years just last month because she saw the difference in the exterior of my clinic. So she just came inside to just find out whether we are still working or not. And this was her profile, and we took her pictures and scan. Everything was well balanced. Everything was intact. All the bonded retainers had come out. She was not wearing any retainers now. The models of the patient. The patient at the start of treatment, this is where we ended after 4 years and after 11 years of retention. Then in practice, we had a little problem that when you place the mid-palatal screws, it definitely caused problems in speech. There, secondly, some mischievous children, they used to interfere with the tongue all the time, and quite often the ligature also might come out. So in that case, the night-eye call spring would hang in the palate and it could cause an emergency. So for that reason, we stopped using it in the mid-palatal region and started placing it in the palatal alveolar region. Why? Because the quantity and quality of cortical bone is much better. Better keratinized gingiva so that you get no soft tissue problem when you place a microimplant. More mesodistal space available in the palatal region compared to the buccal region. Now, CT scan studies in the textbook also has showed that the slice at 4 millimeter level from the CEJ, buccally, the amount of interradicular distance available is 2.7 millimeters between the 5 and 6, which increases to 3.8 millimeters on the palatal aspect. And when we go at 8 millimeters from the CEJ, the interradicular distance increases from 3.7 on the buccal aspect to almost 5 millimeters on the palatal aspect. So you get a large interradicular distance, so that much more retraction is possible. This boy again came with proclination of the upper anteriors. Chief complaint of protrusion of upper teeth on smiling and mild crowding in the upper jaw. Lips were incompetent, short lips, everted lips. Rest of the medical and dental history was all normal and insignificant. The extraoral pictures of the patient at the start of treatment, young growing boy, and intraorally mixed dentition. These were the x-rays of the patient. So looking at the x-rays, just because he was in a late mixed dentition stage, I told the patients and the parent to wait for some time, and maybe we would start the treatment after some time once all the permanent syrups, and we'll do the treatment in a single phase, because good for the patient, good for us. But the parents were very apprehensive and they wanted some treatment at the earliest, because if you see the intraorals, he had already broken a central incisor. The parents were a little apprehensive because of that. So we gave him a twin block appliance. Then if we look at the cephalometric analysis, the mandible was a little retrognathic, mandibular plane was normal, skeletal class 2 definitely, and mandibular incisor was slightly proclined, not much, slightly. The patient came back after 6 to 8 months, did not wear the twin block. So we started with the fixed appliance, started only with the maxillary arch, and placed 2 palatal microimplants for en masse distalization and retraction in the upper arch. We did not do anything in the mandibular arch because very little treatment was required in the lower arch. So we normally start a little later and attack the problem area first. Then midway into the treatment, after about 5 or 6 months, strapped up the lower arch and continued with the retraction with the microimplants on the palatal aspect and started further retraction. The patient midway into the treatment, this is where we finished him. At the end of the treatment, the occlusion, we got a good anterior posterior correction which was required. And the most important thing probably for me was there was no change in the inclination of the lower incisors because we did not run any class 2 elastics in case. And there was no taxation of the anchorage in the lower arch. So that brought greater skeletal correction and lesser dental problem, dental compensation. Upper incisor proclination was normal. The superimposition showed some headgear effect in the upper arch and good favorable downward and forward growth of the mandible. Composite analysis. The patient before and at the end of treatment. Here purposely I have kept the photograph of the two central incisors because he had a broken central which might appreciate a little difference. There is a temporary composite buildup done which has to be replaced later. But I don't know. It's a good color matching, so I don't know he'll get it replaced or not. Total arch distalization has been very well documented by Dr. Shingo Koroda in angle, where he has showed that there is a distal tipping and bodily movement of the anteriors as well as the posteriors. He says that you get a 2.7 millimeter distalization of the incisor tip, 0.2 millimeters extrusion, 2.8 millimeter distalization, 0.6 millimeters intrusion. So effectively it causes a mild rotation, mild clockwise rotation of the occlusal plane. The tip also moves back bodily by 1.2 and 1.1 millimeter, and there is palatal tipping, which was expected. Then we had a little problem with palatal implant because one of my friend, he had placed palatal implants and the blood vessel had ruptured. So it caused a lot of bleeding. Normally when I place the palatal implants, we normally palpate. We can get the pulsation of the arteries there. And we can safely place the palatal implant between the 5 and 6 at about between 6 and 8 millimeters from the gingival margin, which is safe to place the palatal implant. I think sir has placed a lot of palatal implants. So because of this, we said, let me try some extra radicular screws. Because the screws are a little longer, about 10 to 14 millimeters long, extra away from the roots, so unlimited distalization, and mainly because the diameter is about 2 millimeters, so you get better primary stability. Again, the elastic modulus is much better. The screws here are made of stainless steel, so the chances of breakage are almost zero. Full arch distalization in class 2, class 3 cases, and retreatment cases also one can do it. Enhanced distalization, as can be seen in this particular case. Distalization using extra radicular screws. Now in this case, if you see, the bite is not deep. So what we had done is we had placed the extra radicular screws, placed the anterior post at a higher level, and passed a force which was parallel to the occlusal plane as close to the CR of the upper arch, so that you get minimal rotation of the occlusal plane. So then you can get predictable results in such cases. So one has to find out what will be the biomechanics, and excellent biomechanics have been suggested by both these articles, one by Abhishek Ghosh in JIOS, and the other is by biomechanics by Marcio Almeida in the Dental Press Journal. Both the articles are worth reading. The main difference between intraradicular screws and the extraradicular screws are, intraradicular you have to go more apically because there is more intraradicular distance available. So naturally the head of the implant will be at a much lower level. So the intrusive forces can be applied very easily, but it may have some side effects in certain cases, apart from the limiting factor in the form of intraradicular space available. Extraradicular, the head of the implant is lying at a higher level. You are more close to the occlusal plane, So you can control the rotation of the occlusal plane better, and unlimited distalization of the entire arch will be possible. You can place it in one of the two areas, one as suggested by Eric Liu, near the mesobuccal cusp of the mesobuccal root of the first molar, or as suggested by John Lin, between the first and second molar. Now I follow both of them, but actually I palpate the infozygomatic crest area and mark the midpoint and place the implant. Sometimes it could be in loose area, sometimes it could be in the Lin area, but then practically just palpate and find out where the, in fact, years ago in the Salzman book also, he had mentioned the Atkinson's key ridge, which has a strong buttress of bone coming down. And he had mentioned that this bone, you have to palpate and find out whether the molar has drifted forward or it is at that particular position. So it is around the first molar and you can place it there. The placement also has been mentioned quite often, go perpendicularly and then angulate. A patient, adult, non-growing, severe deep bite, 100% deep bite, bilaterally molars for class 2. The models of the patient. Patient had all the 4 third molars which were impacted, and we had advised the patient to get them extracted. The biggest problem was the low mandibular plane angle, apart from skeletal class 2. So such almost flat, the mandibular plane and the palatal plane are almost flat. So in this case, the cephalometric analysis, severe retroclination of the upper anteriors, molars were in full cusp class 2. Profile was good, so we did not want to extract in his case. And probably if you would have extracted, space closure would have been a biggest problem. Problem list, severe overbite 7 millimeters, deep mentolabial sulcus, everted lower lip, class 2 division 2 pattern. Objectives to correct all this. So we strapped up the upper arch first, corrected the upper arch, leveled, aligned, expanded the upper arch, placed the extraradicular screws, started retraction, then bonded the lower arch and continued with the retraction. Most of the cases with deep bites, we love to place the composite bite turbos either initially behind the central incisors, or quite often when the class 2 division pattern, the upper incisor tend to procline, we shift placing the composite blocks at the canines so that you get the disocclusion, expansion, and as well as retraction of the entire arch. Only in cases where the upper 6 anteriors are properly aligned, we place a soldered bite plate because that is a little uncomfortable to the patient. Now, what happens when you give a composite bite turbo or a bite plate, as given in biomechanics by Jung and Kim, that you don't rotate the occlusal plane because the effect of the bite plate will have an intrusive effect on the anterior segment. Otherwise, without the bite plate, there would have been a clockwise rotation of the maxillary arch. So you can prevent it by placing a bite plate. If the patient doesn't have a gummy smile, you can continue with the treatment this way. The force application as suggested should be around 300 to 350 grams for upper arch distalization. Infrazygomatic screws, now where is it? It is a palpable pillar of cortical bone between the zygomatic process of the maxilla and the alveolar process. To palpate that area. Thickness, very good thickness, 5.5 to 8.8 millimeters in adults. 2 cortical plates, the buccal cortical plate and the floor or the lateral wall of the sinus with the cancellous bone in between. So you get bicortical anchorage theoretically. Therefore, better stability and you can load it immediately. The patient at the end of treatment maintained good smile. The lips did not protrude. The occlusion of the patient, good correction of the deep bite, with 100% deep bite which was there, got corrected. And comparison before and at the end of treatment. Otherwise, it is very difficult to treat such low angle cases effectively. Patient came back after 8 months. Occlusion was well settled. Now, if you see the cephalogram before and after, the third molar only in the upper arch was extracted because we went after him that you have to get them extracted, otherwise you will not be able to start with the distalization. Lower third molars, it still did not get it extracted. Models of the patient at the end of treatment, good class 1 relationship. Now, one thing one has to remember when placing extra radicular screws is, because the screw is lying away from the occlusal plane, it will inherently have some contracting effect on the arch. So you have to compensate that by expanding the arch wire to some extent. Now the expansion of the arch wire will depend on many factors. One, the dimension of the base arch wire that you are going to use. Secondly, the distance away of from the head to the arch wire. So the more the distance of the head away from the arch wire, greater is the expansion that should be compensated to prevent any lingual rolling or lingual crossbite that can be formed. So the rolling in effect has to be taken into consideration. The position of the crimpable loop. Now, quite often we started placing the crimpable loop mesial to the canine as is recommended. But quite often when we place the power chain or the night-eye coil spring and it turns around the canine region, it causes some gingival irritation to the patient. So we shifted it in quite a few cases distal to the canine so that the elastomeric which is applied is parallel and it does not impinge on the soft tissue. It is more comfortable to the patient. Of course, you can apply the amount of force which is recommended. Again, a good article on biomechanical considerations for total distalization of the maxillary arch using temporary skeletal anchorage devices in the seminars in orthodontics, where he has particularly mentioned that it is very, very important in total arch distalization to include the second molars, because even in cases where the line of force is at a higher level, the anterior post also is at a higher level, the bite is not deep, and you tend to retract, still the force is slightly away from the CR of the upper arch. So it causes some amount of clockwise rotation depending upon the moment that is created. So always include the second molars as early as possible before you go into heavy wires and see that the second molars are also aligned. Otherwise, a distinct, the more oblique the force, the greater will be the disparity between the first and second molar. When the distalization of the dentition is more than 2 to 2.5 millimeters, now we place the bone screws in such cases. Repositioning can be a little difficult in private practice. Arch distalization does not stop with extra radicular screws, so we are comfortable there. Textbook, it is also mentioned that you should check for the availability of the space in the tuberosity region. It is not necessary to extract the third molars in all the cases, depending upon the tuberosity space available. So it is safe to even retract, even if the third molars are completely present and there is some amount of space available in the tuberosity area. Of course, the treatment time will increase slightly. Another patient, typical class 2 division 1 pattern, protruded upper lip, intraoral picture, open bite, contracted upper arch. The lower lateral incisor was in a very, very bad position, so they had to be extracted later. Molars full cusp class 2, overjet of almost 9 millimeters. But OPG, she did not have the third molars. I think 3 third molars were missing, but what I was interested was absence of third molars in the upper arch. The patient has prognathic maxilla, normally positioned mandible, skeletal class 2 pattern, and she had a slight brachyfacial pattern also. The composite analysis showed proclination of the upper anteriors, overjet of about 7 to 8 millimeters. Again, we started with the upper arch first, attacked the upper arch first because that was the problem area. We did not do anything in the lower arch because the patient is more comfortable this way. Placed a micro implant, and here you can see we placed a oblique line of force. Now, why was that given? biomechanically, when the line of force is a little oblique and the post may be facing upwards or downwards, but if the force is oblique, it will have a clockwise rotation because the moment of force is away from the center of resistance, and which was advantageous for this particular case because she had an open bite. So when we see the first picture here, few months into retraction, we started with an open bite. Gradually, the bite was getting corrected. And as we retracted further, the bite deepened even further. Once we were happy with the molar relation, once we were happy with the overjet, then only we started with the lower arch for a few months and finished the case. Again, a read article, Marcio Almeida. Continued with some retraction with post distal to the canine. And this is where she ended. The pre and the post comparison. The comparison of the cephalogram, non-extraction, just because she did not have the third molars, we could distalize the entire arch, non-extraction. Cephalometrically, there was a positive class 2 relationship which was corrected. The skeletal class 2 relationship was corrected. Normal interincisal angle, upper incisors was slightly retroclined still because still she is a slight skeletal class 2. Comparison before and at the end of treatment. Now the last case, again severe proclination. This particular case, me and Jigar had a lot of discussion as to whether we extract or not. Because the smiling face of the patient, definite extract. When the patient comes in, we ask the chief complaint, we see how she smiles, and then 60-70% it is decided whether we are going to extract or not. We had a long discussion here. The intraoral picture, again severe overjet, but in photographs the patient tend to bring the mandible a little forward. One overeaten decidus molar tip, badly carious first molar. The cephalogram again about 8 to 9 millimeters of overjet. Again, this patient also did not have the third molars and root canal treated upper right first molar. Overjet, the digital models of the patient at the start of treatment. Missing one incisor in the lower arch. Multiple problems. She had a skeletal class 2 pattern. Mandibular plane was normal. Here if you see the cephalometric analysis, there is upper incisor proclination, lower incisors were normal. The mandibular plane was normal. She had a excessive incisal show to the extent that about 2 to 3 millimeters of the gingiva was also visible. So class 2 elastics in her case was contraindicated. There was increased overjet, increased overbite, 100% deep bite. Again, upright lower incisors as can be seen from the readings here, and lower facial height was normal. So literature also says that in such cases where the upper incisors are severely proclined, or you do not mind losing some amount of torque in such cases, you may use a mini screw combined with a slightly undersized continuous arch wire, which allows for free phase 1 tipping, which is indicated for bidental alveolar proclination. So this case was indicated for that. So we placed a 1622 arch wire in a 18 slot and started with the retraction, as suggested by Dr. Hyo-Sing Park in his textbook. Because this was the amount of proclination there, and we could safely lose some amount of torque there. Again, started only in the upper arch, extra radicular screws, and placed again slightly oblique line of force. So how do we correct this? Once we got the anterior posterior correction, we banded up the lower arch and we added a mid-palatal implant in her case. Now, why was this necessary in her case? For biomechanical advantage. We'll come to that. Now, it is said that whenever the line of force is oblique and we do not complement it with an anterior bite plate or an anterior bite turbo or whatever, the rotation of the occlusal plane in a clockwise direction will take place, and you will lose further some torque. Secondly, the incisors will come down slightly. The gingival show will increase. So in order to prevent a single midline implant is indicated so that it prevents the extrusion of the upper anteriors. At the same time, it intrudes and slightly proclines the upper incisors, which is indicated with such biomechanics. So after the two buccal infrazygomatic screws, en masse retraction, we added a single microimplant in the mid-palatal region. And this is where she ended up non-extraction. Cephalogram again before and at the end, retraction complete, total arch retraction with extra radicular screws. And what happened cephalometrically was correction of the class 2 relationship which was there. Upper incisor inclination was corrected, and most importantly, the lower incisor inclination was maintained as it is because no class 2 elastics were used, and very short time the lower arch was strapped up. So there was no proclination of the lower incisors at all. Models at the end of treatment because she had a one single incisor missing also. Comparison before and at the end. Now to conclude, now what do we, as a clinician, what do we aim for in day-to-day practice? We aim for improvement of smiles for the patient. For example, patient comes with this smile to begin with, and you feel really satisfied when you improve the smile for the patient. Non-compliant, predictable biomechanics. So whenever we are using any appliance, any screws, we should understand as to what will be the effect, and more importantly, what will be the side effects and how to counteract the side effects. It is very important to mainly place the microimplant, doing the homework before placing the microimplant and understanding how will be the tooth movements in this particular case and how will we be able to prevent the side effects. For example, placing the microimplant in the anterior region or increasing or decreasing the post in the anterior region to control the movement of the occlusal plane. So we have a non-compliant appliance here and upgrade with the advancement in the field of orthodontics. We are trying something like this now with aligners with extra radicular screws. Let's see how successful we will be with this. Let's see. Once again, I would like to thank all the teachers of the Department of Orthodontics, Bharati Vidyapet University, for continuing the legacy set by Dr. Sable. I would like to acknowledge that all the cases were treated in our clinic itself, either by me or Jigar. And I would also acknowledge that he has helped me a lot in preparing the presentation, even though he is my biggest critic. So with the advent of microimplants and extra radicular screws, the sky is the limit, and we have already expanded the horizons of what cases we can be treated with orthodontics and with additional armamentarium that is available to us. But I tried different things in the sky. Thank you so much.
Thank you. Thank you.
Thank you, Dr. Ketan Vakil, sir, for enthralling us with some wonderful cases treated using skeletal anchorage. Now I would request past chairman, Indian Board of Orthodontics, Dr. Vinod Verma, to please give the certificate of appreciation to Dr. Ketan Vakil, along with Dr. M.K. Prakash, sir, and Gauri Vichare, madam. I would request Dr. Vinod Verma to please hand over the certificate of appreciation for chairing the session to Dr. M.K. Prakash and Dr. Usha Malkhani. Thank you.
I would now like to invite the chairpersons for our next session. Dr. Silju Matthew, past president, IOS. Thus the Dean, Principal, Faculty of Dental Sciences, Ramaya Dental College, Bangalore. And Dr. Sanjay Kumar, excellent clinician and at par academician from Kolkata. Welcome, sir. So please could you introduce our speaker, Dr. Andres Felipe Perdomo.
No, I prefer this one. Okay. Perfect.
Hello.
Good evening, one and all. I welcome you all to the next session. And on behalf of the organizing committee, I welcome the next speaker, Dr. Andres Felipe Perdomo Ospina from Bogota, Colombia. Let me have the privilege of introducing the speaker. Dr. Andres Felipe Perdomo received his dental degree from Javerian University at Bogota, Colombia in the year 1987 and his certificate in orthodontics from Javerian University in 1998. From the beginning of his career as an orthodontist, he has taught in the Department of Orthodontics at the University Cooperativa of Colombia in Bogota, and his preferred topics are biomechanics, class 2 treatment, passive self-ligation system. Over to you, Dr. Andres, for the presentation.
Thank you so much, doctor. Okay, thank you so much for having me, and thank you to you for joining me. Today I'm gonna show you more than a scientific lecture. I'm gonna show you a series of clinical cases, how I treat my cases with the passive cell ligation with the Damon system. Just a few presentation of who am I, my country, Colombia, a little bit far from India, just 20 hours flying from Bogota to Mumbai. My place, Bogota, my family, my wife, Kathy, my son, Felipe, my daughter, Manuela, and my beautiful pet, Ron, which is a wonderful company as well. This is my city, Bogota, in the middle of the mountains in Colombia.
And this is my university when I'm teacher as well, Javeriana University in Bogota, Colombia. My best friend and classmate from the orthodontic department at the Javeriana University. This photo was taken about like 30 years ago, something like that. Wow. I'm professor at the Javeriana University, Department of Orthodontics in Bogota, Colombia. As well, I'm professor of biomechanics at the University Cooperativa of Colombia, Bogota, professor in the University of Las Americas in Quito, Ecuador, Cuenca, Ecuador as well, professor of biomechanics and passive cell ligation, as well in some universities and department of orthodontics in Argentina. So my life is teach and teach and teach, and I love teaching. It's part of my life. Well, I'm talking about Damon system. All of you I've heard, or you treat patients with the Damon system. So let me tell you some facts and some myths about Damon system. Number one, facial-driven treatment and some facts about extraction. Because most of the people consider and think that the Damon system is a non-extraction treatment. And I have seen like it's a fashion right now at the orthodontic field, the non-extraction cases, the non-extraction treatment. So there are a lot of myths and legend about this kind of system. Damon is a non-extraction treatment. Extraction in orthodontics is the past. Damon doesn't need IPR. Damon is too expensive. Just bond braces, place the wire, and let them cook. Something about wires, something about periodontal issues with the Damon system, and something about because of the non-extraction treatment that say that the relapse is imminent with this kind of treatment. I remember very well about 16, 17 years ago, my very first touch with the Damon system with the doctor. Dr. Bagden was like a kind of in office course in Argentina when my very first time that I saw a Damon case. I remember very well this patient. I call it the golden hair patient. So I saw in this weekend this patient with this kind of malocclusion was time that there are no tats at all, just passive cell ligation. Times of extraction treatment. 16 years ago. Okay, I saw when this doctor placed a bone Damon braces, placed a wire all over the teeth, and then like a magic, a beautiful finishing case. My God, I think to myself, this is amazing. So I take a taxi, run to the airport, and took a flight to my place, Colombia, because I wanted to start as possible a treatment with Damon system. My God, this is magic. This is beautiful. And I remember very well my very first patient with Damon system, 15, 16, 17 years ago. Laura, her name. She had as well a crowding even lesser than the golden hair patient, a kind of open bite. Okay, I wrote down the cookbook of the Damon, place braces, passive cell ligation, low thorax the upper, low thorax at the lower, a wire all over the place, all over the teeth. So I did the cookbook. Obviously, the next photo after that is going to be a beautiful finishing case because it's Damon. Look at the finishing case. My God. The American guy told me, just place the wire all over the feet. In this moment, I just had 3 options. Let me show you. 50-50, phone a friend, or ask to the audience, my God, the American guy cheated on me. No, my friend, Damon is an extraction system as well. Why? I call a friend. This lady, she needed extraction. Sometimes because of fashion, I don't know. Even in this kind of event, it's like annoying show extraction cases. But extraction, some patient needs extraction. I think it's the best treatment. Sometimes it's the best treatment. This lady, let me show you her facial chain. Look at her anterior facial height and her profile. Yes, because the extraction. And let me tell you, sometimes extraction cases are shorter than non-extraction cases. And if you save time, it's better for our patient. So, that's the dilemma. Extraction or not extraction? Yes, sometimes we made a lot of mistakes because extraction mechanics. For example, in this case, this patient came to my office because a kind of relapse about 15 years ago after her first orthodontic treatment. Look at for extraction at the upper, at the lower, but look at the end. I love this photo. A photo that I take like that. I call it the photo of the truth because at the frontal photos, it's impossible to see the truth of the overjet. It's an overjet 15, 16, maybe 14 years after the orthodontic treatment. How come? Because the loss of third control when you are closing spaces. Because of that, extraction sometimes is a challenging case as well. Most of the time at the bottom, there are a lot of loss of control when we are closing spaces. This is another patient. Look at her overbite. Her overbite is not because she has a vertical issue. Her overbite is because an extraction at the lower premolar is in a loss or a lack of control in the process of close the lower spaces. But what about this girl? This girl came to my office. Look at her mentalist muscle. Look at her lips. Look at her profile. And what about her upper and lower incisor? A huge proclination. I remember that she was maybe 12 years when she came to my office, class 1 by Max. She had an active mentalist muscle. And for me, the active mentalist muscle is a wonderful success predictor of the most of the patient. The best treatment is going to be an extraction. It's going to be extraction. What is it? This is pointer as well. Thank you. This computer has audio. Perfect. Thank you. This is a wonderful predictor. Yes, I know there are taps. I know there are a lot of distalization procedures. But again, as I told you, sometimes, even in 2022, an extraction case could be a wonderful result, could be a wonderful treatment to our patient. Let me show you. Laura, I show Laura right now. Laura, she needed extraction because her active mental emotion. So this lady came to my office with a 2x4 appliance, a mixed dentition from another town. She came from my city, from another town. So when she came to my office, I have some options of treatment. Let me show you. Options. A serial extraction protocol, I don't like it because most of the time I lose control of the space. I can't take advantage of the space in a serial extraction protocol. Second option, an orthopedic treatment. Finally, the patient was 12, but the patient didn't have any functional issue, just a dental problem, so an orthopedic treatment didn't fit in this kind of cases. Maybe a degainer. A degainer is a 2x4, but with diamond braces. No. What about wait until permanent dentition and reduce the treatment time? Could be maybe difficult to offer this kind of treatment to our patient, but fortunately, the patient and her relatives accept this kind of treatment. Let me show you. At the beginning, 12 years, if I were begin when she came to my office, when she was 12, this case, maybe I would have made a case of about 4, maybe 5 years until wait the final eruption of the second upper and lower molar. But I wait until the eruption of the permanent dentition. She came to my office when she was 14 years, 2 years later. And obviously, I knew that she or the case is going to be an extraction case of ID for extraction, upper and lower bicuspids. 2 years later, this is the prescription talking about the immune system, the perfect prescription when we are dealing with extraction cases to control the unwanted tipping at the lower and upper incisor, high torque at the upper, low torque at the lower. But what is the beautiful thing of the diamond system? Look at just 6 months later. Look at the change in her face. Look at her muscle mentally. The change in just 6 months is better than whatever kind of treatment because the patient requests for their faces. And the first thing that we must think is about the faces of the patient. So look at the change in her face, in her lower facial height, a little bit change in her lips as well. And let me show you the beautiful thing of the passive cell ligation. Without any phase of a space closure, you can see that the patient is still wearing night-tie copper wire. The spaces is almost closed. The question is, how come? Why? Because the force of the lips, just to zip the lips, and because it's a low friction system, the spaces is really easy. Not in all the patients. In most of the patients, we are going to close the spaces just with the force of the lips. Look at the inclination. 6 months later, in the second wire, the first one, 0.14. The second one, 14/25. And it's almost down. Almost down because of the force of the lips. Obviously, because her age, she was a young lady. 11-month lady, an 18/25, night-tie copper at the upper, at the lower. I'm talking about finishing right now, finishing orthodontics. I love this topic. Look at this overjet from upper canine to lower canine. How to fix this overjet, the overjet at the cuspid? Maybe you are thinking about torque. Maybe you are thinking about whatever kind of bend. Yes, why not? How I correct this kind of issue? Just modify the original R4. This is original. This is the modification. Let me show you why. Just with a plier, change a little bit the shape of the arch. Yes, with the plier, a little bit like an asymmetric arch, and that's all. That's perfect in finishing cases with passive ligation, and even with whatever twin bracket, with whatever conventional orthodontics. And that's all. Another issue at the finishing, a slight class 2 cuspid malocclusion, and maybe the engagement at the molar, upper molar, with the 6 lower molar. Maybe it's time to repo. I love reposition braces instead bends. How come? It's more predictable for me, the reposition of braces instead bends on the wire. Look at this kind of reposition. It's like a tip back bend, but reposition in molar tubes and brackets. And maybe some of class 2 elastics, because it's a mild class 2 relationship. The final, from here, a bimax to a almost a wonderful position of the upper and lower incisor. 20 months of treatment instead 4 years. If I were started what she came at the beginning to my office. Her ethnicity, but is a wonderful profile at the end of the treatment for her. A beautiful smile, even with 4 extraction, because this lady needed extraction instead other kind of treatment. Okay, beautiful class 1, cuspid class 1 relationship, her midline is on. Most of the time we talk about stability in our treatment. Okay, let's talk about stability 4 years later. Look at her smile 4 years later. The conclusion 4 years later, for me, is that the patient, yes, she needed extraction, because 4 years later, her smile is full of teeth. What about if I didn't extraction of her? Maybe she was or she's still a by protrusion. 4 years later, okay, you can see her smile with 4 extractions. So depend on the patient. I try to avoid bias with this kind of treatment and non-extraction treatment, just because of the sound of the new orthodontic conference, of the new orthodontics theories about non-extraction treatment. This photo was taken a few days ago. Extraction versus non-extraction. For me, number 1 characteristic is because of the face. Look at that, the lips and the anterior facial height. The activity of the mentalist muscle is a wonderful success predictor. Torque prescription in extraction case. If you are Damon users, high torque at the upper, low torque at the bottom, at the lower. Arch coordination plus tip back, finishing cases. And for me, the best conclusion about this case, extraction cases and Damon system can work together. Let me show you the next case. Look at her face. Look at her lips. Look at her mentally muscle. She didn't need extraction, even if she had a huge crowding, like at the upper. So in this case, we have to find whatever kind of biomechanics to avoid extraction. Without extraction, how come? Because of the face. Because of the face, this lady needs extraction. What is the treatment? My treatment, my protocol in these cases. Variable torques about Damon, open coils between the 4 and the 6. Sometimes, like the wonderful lecture of Dr. Ketan, sometimes that's marvelous, the tat, and by blocks. Sometimes IPR as well. Low torque, the green dots means low torque. Let me show you how. Braces, open coil between the 6 and the 4, low torque, the green dots, open coil at the first appointment, early elastics to avoid this gap like a triangle, yes, look at the first appointment to be as fast as possible in our orthodontic treatment. Okay, let's get going. Most of the time, I want a button and an elastic treat because of the expansion of the arch, because of the expansion of the passive cell ligation. I don't want that this premolar stay behind or stay so far from the main arch, okay? So even without space, it's advisable to tie an elastic thread from the bottom to the main arch of the page. And yes, it's to wait and open the space, some class 2 elastic. I love tongue tamers to avoid the tongue thrust, the habit. Elastic at the end of the treatment. Yes, looking the engagement of the upper to the bottom. I love repo. I love take photos on my patient. How come? Because I realize of my mistakes. Look at the position of this bracket. Look at the distance from the pad to the incisal edge and from the pad to the incisal edge. I realize automatically that I made a mistake. Solution, a reposition. And maybe in this premolar as well, because I need to extrude a little bit the premolar. Final 17 months of treatment, the patient had an issue with her enamel, like an hypoplasia. Because of that, the change of the color, you know that? And maybe an endodontic treatment because of that, the change of the color at the upper incisor. At the beginning, recently bonded the braces. Open the space, even enough space, more than enough. Perfect, rectangular wires, 1 year later, and at the end of the treatment. Without extraction, how come? Because the face of the patient. Without extraction, because the face of the patient is a wonderful treatment. Obviously, at the end of the treatment, the requirement of the patient was some kind of cosmetic treatment, which is common in my country, the cosmetic treatment. Important message about this lady. Extraction versus no extraction. Again, because of the face. Crowding in passive cell ligation diamond system means low torque. Low torque help us, not to prevent, help us to avoid proclination at the lower and upper incisor. Obviously, if the patient is wearing rectangular wires, not round wires, okay? Sometimes people make errors or mistakes about it. Open coil activation must be every 3 months. Tie displaced teeth with elastic thread and early elastic, avoiding unwanted effects. The next one, again, because of the face of the patient and because the age of the patient, my diagnosis, and because the patient had a Bimax, my diagnosis was extraction. But the patient, a little bit tough, look at class 1 Bimax, a patient a little big tough, his request was, I don't want any extraction. Oh my God, you don't want any extraction? Sometimes, please focus on this slide. sometimes people believe that with negative torque of whatever orthodontic system, or even with negative torque in the wires, you can change the position of this kind of teeth. It's a challenging because remember, this is biomechanics. When you are dealing a torque on a teeth, the center of rotation is in the crown, in the incisal edge. Because of that, expect more movement at the root instead at the crown. And most of the time, you can pull out the root from its bone, which is a dangerous, a periodontal issue, which is a problem. This is something that I call torque as an action versus torque as a protection. This is when you are talking about torque as an action. That's a mistake. Most of the time, we need the torque as a protection. Look at, sometimes somebody think that flip a bracket with a high torque, what do I mean? A super negative torque, you are going to move the crown in a palatal position, but look at the root. The root pull out from its bone, because think about that the negative torque is going to resolve our problems about, for example, in this case, of overjet. So which is a risky in the patient. So conclusion, in this case, patient reject extraction as a treatment option. Backup plan, TATs for TATs. TAT at the infrazygomatic crest, TAT at the shelf mandibular, 12 millimeter and variable torque. In this case, because it's like an extraction case, high torque at the upper, high torque at the lower. Torque as a protection. Maybe some of you think, why high torque? We need to retract. Yes, the retraction is going to be because of the elastic change, because of the upper and lower TATs, and the goal of the torque is to avoid the unwanted effect, which is the straightening of the upper and lower incisors. So let's get going. The wire sequence of the Damon system, in this case, of 14, then 14 by 25, then 18 by 25, and then at the bottom, 16 by 25, it to finish 18 by 25 at the bottom if we need more torque expression. These cases, in my way of thinking, are easy because it's just to chain every single appointment the elastic chain. No more. Just chain the elastic chain and chain the elastic chain and chain the elastic chain and wait until we get the proper inclination of the upper and upper and lower incisor. Obviously, again, in my way of thinking, would it be easier with 4 extractions? I don't know if the correct word is easier, instead shorter treatment time, okay? Obviously, the TATS works. Look at the inclination of the cuspids. It's better because of the TATS. Look at the inclination of the upper incisor. This kind of is a spring to help us with the negative torque. And at the end of the treatment, look at the challenge of the inclination of the upper cuspid. I need to correct because the upper cuspid are to flare. Another tip to correct this kind of flare, maybe negative torque. Remember, I told you, negative torque move more the roots than the crowns. So this is a tip. I bond a button at the lingual aspect of the cuspid and this kind of elastic, like a cross elastic, and that's all to finish this kind of case. Okay, this is the finishing 12 months of treatment. I think that is a wonderful occlusion, except because of this gap. I don't like this gap. I have to confess that. but on the right, I think it's almost perfect. I love it at the end of the treatment. 3 patients, 3 different treatments. Number 1, extraction. How come? Because of her face. Number 2, non-extraction. Damon, open coils, open spaces. How come? Because of her face. Number 3, non-extraction treatment. How come? Because of the patient request. In my case, maybe I would have been an extraction case. Important message. Look at, if we are going to make a mistake about extraction, the less bad mistake is don't do the extraction. Maybe it's really easy to fix the mistake, do the extraction. Why not? Okay, let's talk about something that I love because sometimes it's difficult, dealing with midline discrepancies. Dealing with midline discrepancies. There are a lot of etiological factors about midline discrepancies. Dental, functional, or skeletal. Today, I'm going to talk about just dental issues, okay? Agenesis, loss of teeth, wrong treatment, crowding, Bolton discrepancy. Most of the patient, this is the etiological factor of the midline discrepancy. Let me show you some cases about midline discrepancy. My God, the times fly. This clock is scare me. And this is another clock. Can you imagine? From here to here. Okay. Midline deviation of less than 3 millimeters. Less than 3 millimeters. Sometimes it's easy to correct them. Sometimes this is a tip. This is a tip. Look at the dot, the blue dot of a whatever night tie wire. Yes, place the dot, the blue dot or the whatever kind color of dot in the middle of the face, like an asymmetric arch. This tip helps us a little bit, maybe 1, maybe 2 millimeters to correct the midline. Okay? Mark center with midline face. Another maybe, I don't know if it's a Jurassic treatment, an old-fashioned treatment, I don't know, but it's the famous midline elastics. Why not? But I have seen in my 20 whatever years of experience that most of the time midline elastic create cant of the occlusal plane. At the end of the treatment, the midline is on, but the occlusal plane is gone. So, terrible. So let's talk about challenging midline discrepancies. Treatment options, open coils. What about IPR? What about TATs? Famous TAT. I cannot. Let me confess something. I could live without system, but I couldn't live without TATs. My God. Every single day, I put a TAT on my patient. And elastics. Yesterday, in a pre-conference course, I emphasized that the elastic is not a treatment per se. Elastic is a support of another treatment. For example, elastic is a support of a TAT, elastic is a support of an open coil, and so on. Okay, cases. A case of crowding, case of Bolton, a case of class 2, and a case of agenesis. Okay, agenesis. Crowding. This is a typical Damon case because we can take advantage of the passive cell ligation without that. Why not? Without that, okay, beautiful lady, yet watching her face is a no, even without any cephalometric measurements. Obviously, I do the cephalometric measurements. I am a professor of Sick University. But in this case, I just want to show you faces. It's a non-extraction treatment with a huge crowding at the upper. Okay? In most of these cases, I choose low torque to avoid unwanted moments if you are crowded. Midline discrepancy. Bolton, look at her face at the beginning of the treatment. I love this open coil and the elastic trick. No, like the golden hair that I showed to you at the beginning of the lecture with the wire all over the place, even until the nose. No, because of the biomechanic side effects. Please open the space and then elastic thread. No, this kind of mechanics. You can see in many Damon lectures, in many Damon papers, this kind of wire like a snake, for up to down. And what about the biomechanics side effects? I know with Damon there are no biomechanical side effects. It's an orthodontic system, like any orthodontic system. This is the side effects that we must to avoid: intrusion, proclination, and so on. So advantage of the open coil spring plus elastic thread: avoid binding, less side effects, get around early elastics. Okay. 22. This is amazing of the passive cell ligation. This is something that I love of the passive cell ligation, because when you place an open coil in whatever conventional or twin bracket, the canine and the premolar, the lateral and the premolar are going to rotate because of the moment to force that deliver the open coils. What about with a passive cell ligation like Damon? It's impossible because of the gate of the bracket, that the teeth rotate, or the tooth rotate because of the open coil. The passive cell ligation bracket architecture avoid this kind of side effect. Obviously, if the patient is wearing rectangular wires. At the end of the treatment, look at the wonderful case and a final 18 months of treatment, beautiful smile without extraction. Okay? And because of the treatment, the midline is on. Yes, with an open coil spring. Maybe a little bit procline at the end of the treatment, the upper lateral. This is a tooth, that I hate, because the upper lateral most of the time procline because it's a weak tooth. So please focus on the upper lateral. If you are using the Damon system, most of the time you must choose low torque at the bracket to avoid proclination at the upper laterals. Okay? Increase negative torque with this kind of braces. Sometimes you could use pretor wires, or what about torque spring, or what about stripping at the end of the treatment. I love this fashion of to use the elastic chain from cuspid to cuspid. You see an space because I did some IPR at the end of the treatment, and the elastic chain below the bracket to create a larger moment from the elastic chain to the center of resistance of the upper incisor. Okay? In search of a better position of the of the upper lateral incisor. Elastic chain from cuspid to cuspid in a 19 by 25 night tie copper pretor 20 degrees to create a little bit movement in a palatal way. Obviously, at the beginning, I must pretty sure from the distance to the root and the anterior aspect of the premaxilla, avoiding, as I told you, that the root pull out from its bone. If the distance is a short distance, please avoid this kind of negative torque, please. Okay. At the end of the treatment, nice arch form, nice class 1 cuspid and relationship. And what about her face? 3 years follow-up. 3 year follow-up. Look at her lips. What about if I did extraction? In this case, would it be a disaster? Would have been, a disaster. Initial Final, 3 years follow-up. Let me show another case. What about Bolton? This lady had an issue because of the size of her lateral incisor, a Bolton issue. Midline, I'm talking about midline. Look at her midline at the upper, a little deviation. Let me see the crowding. Okay, a severe crowding at the upper. Well, yes, severe crowding at the lower. Most of the time we can take advantage of the passive cell ligation, Damon system, low torque. Why not? This is an elastic that I love. I'm gonna show you. Rainbow elastics. IPR reshape because of the Bolton. Reshape the upper incisor. Yes, this is the rainbow elastic from laterals, lower laterals, central, and lower lateral to close open bite, in this case, to avoid open bite because of the Damon, because the crowding without extraction in an aligned and level line phase sometimes means create an open bite. If you want to avoid this kind of open bite, please prescribe this kind of rainbow elastics. Yes, always thinking about biomechanics. Rainbow, yes. Most of the times, 516, 3.5 ounces. Okay. Look at the midline is off, still off. So it's time to do IPR. Stripping IPR, okay? Because it's impossible with the shape of the upper central incisor to correct the midline. IPR advantages, something that I heard from the great Bjorn Sakrison in 2018 in an AAO. Beautiful feet, beautiful gingival papilla, create space needed for leveling, increase chances for improved stability. 12 months, the midline is almost on. A little bit space at the lower because I did IPR at the lower as well. Look at the shape at the beginning. Look at the shape of the foot, the center of the feet at the end of the treatment. Reshape. Think about cosmetic. Think about aesthetic. This kind of feet, there are no beautiful feet. With people prefer vertical feet instead square upper central incisors. Final, beautiful smile. Midline is on. Perfect. Look at the shape again of the upper, at the upper central incisor. Class 1, and the patient had a severe crowding at the upper and a severe crowding at the lower. 4-year follow-up. I love to check the stability of my patient. The inclination of the upper incisor is amazing. 4 years later. Fun. The patient needs right now extraction of the lower molars. I'm going to pass through treatment because of the time. Let me show you this case. This is a challenging case, a genesis, because this patient had a genesis of his, let me see, I don't remember very well, this upper right cuspid. Obviously, because of that, a huge midline deviation. Challenging case. Maybe a little bit easier because of the passive cell ligation, plots, tats. Okay, look at the midline deviation. It's huge. Class 2 at the right, at the left. Maybe if we convert these premolar in cuspid, obviously they are in a class 3. So we have to correct this kind of discrepancy or asymmetry, class 2. And class 3, the other side. Okay? That's the issue. Treatment, passive cell ligation, high torque in canines, cuspids, low torque at the upper incisor and low torque at the lower incisor because the patient had crowding. Crowding, yes, because we need space. That's at the infrazygomatic crest plus elastic chain. Why the tight in this side? Help us to correct the class 2 on the left. Help us to move the midline from the right to the left. I think that the best tool in this day to correct midline is the TATS. It's really easy, just with an elastic chain. It's just a matter of common sense. Yes, obviously checking the midline, the facial midline. Yes, to decide which is the problem, the upper or the lower. 2 months later, let's go in a faster way. I love this open coil. How I place this open coil, excuse me, between the 6 and the premolar. Because I want that the open coil help me to move in a frontal position, yes, to push the premolar and the upper incisor and help me to correct the open bite. Obviously, the side effect is that this molar is going to move in a distal way. I have to avoid this side effect with an elastic class C biomechanics. Okay, almost on the midline. Yes, even with a almost perfect system like Damon, at the end of the treatment, I was dealing with this kind of asymmetry. I don't know, maybe because they play between the slot and the wire. And remember, all of us, we are orthodontics. We must know how to deal with this kind of issues. Look at this photo. Can you see the discrepancy? Maybe because the shape of the central incisor. I don't know. Well, why a bend? A bend is not a sin. I'm professor of biomechanics. I love bends, a few of them, but I love bends at the final stage of my cases. Some stripping at the lower, the midline. The midline in this challenging case is on because of the tats, because of the open coil at the right, on the right, and because of the passive cell ligation, a less friction system that help me to move the teeth in a shorter time. Class 1 with the premolar, class 1 and the cuspid relationship, and the molar relationship as well. Final 17 months treatment. Look at his midline. Nice. Maybe 17 years ago, the treatment would have been extraction in this side, extraction and extraction, but fortunately, we are living in 2022. Take home measures in this section. Think about midline discrepancy, etiological factor. Why? Upper, lower. Please focus on the facial midline. IPR is a wonderful tool. Open coils and passive cell ligation works perfect to avoid side effect, to create a space, and elastic, always elastic as a support. That are the key. And as a Dr. Ketan said, with screws, this is my guru about the screw, and my friend, Professor Christian, it was a paradigm shift. The screws for me and for most of you. 9 minutes. What can I show you in 9 minutes? Yes, I want to show you one case about class 3. Why not? 9 minutes is 9 minutes. When I'm dealing with class 3, we have to think about the component of the class 3. Is the maxilla? Is the mandible? Both? Think about. Let me show you this challenging case. Wow! Severe crowding at the upper, almost an anterior crossbite. Huge crowding, look at the shape in her upper arch. Severe crowding at the lower as well. Remember, crowding means low torque. We are dealing with Damon, passive cell ligation, class 3 elastic, rainbow elastic, low torque. Maybe this is a TAT case, but I have sometimes another backup plan. And please, no extraction in this case. How come? Because of the face. The face of this patient don't need extraction. 8 minutes. Remember the golden hair? It's different. Because this guy is a little bit more difficult because this guy is almost an edge to edge. If you touch just like that, this guy, you are going to create an open bite. But this guy had a deep bite, so it's totally different, totally different. Please focus on the overbite. Let's get going. Low torque, 014. Rainbow elastic to avoid open bites. Open coil to create space. Avoid this kind of wires. This kind of wires are called tandem, piggybacks, something like that. This kind of wire creates something that I call, or Charles Buston called, and control tipping, even if this bracket has a super negative torque, but think that the patient is wearing a round wire. The negative torque doesn't work with round wire. Overlays is the name. This kind of overlay create this kind of periodontal issues, okay? Please avoid overlay with round wires and control tipping. Because of that, most of the time I want bottoms instead brackets. Because of the bottom, you can bond the bottom closer to the center of resistance and reduce the distance to the center of resistance. So reduce the moment to force, reduce the inclination, proclination of the teeth or the tooth, in this case of the lateral incisor or central incisor. Because of that, I prefer bottom instead brackets, because the bracket is a little bit is bigger, a little bit bigger. Okay. Let me show the case. 6 minutes. 6 minutes. Okay, open coil springs. 7 small later. Still class 2. Time to repo. I realized the mistake that I made. Repo. Avoid this kind of wire sometimes. Rectangular wire. 10 small later. Remember, the only treatment in this patient was class 3 elastic. Maybe on the right is almost done. But what about on the left? On the left is still a class 3 patient. So it's time, month number 10, it's time to take a decision about the treatment because the class 3 elastic didn't work. Okay? I love this spring. This spring is called CS4 for Dynaflex because it's like an elastic, like a class 3 elastic, but fixed to correct class 3 treatment in non-compliance patients. Look at the spring. It's a wonderful backup plan. If we don't want to place a TAT, if the patient is a non-compliant patient, so this is a wonderful solution. 16 months, final, beautiful case on the right. What about on the left? Passive cell ligation, class 3, and in this case, a spring called CS4. Final measurements, and final measure. In this. So let me finish, because the left is 4 minutes, with the class 2 treatment. It's It's a kind of treatment that I love, the class 2 treatment, because the class 2 treatment I have realized that in India there are a lot of class 2 cases. Because of that, I want to show you how in most of my patients, I try to correct the class 2 issues, the class 2 malocclusion. Okay, dokie. Look at this guy. This guy came to my office. Oh, this guy came to my office. I got scared. Really? It's louder. I'm scared about it. Bing! Okay. Yes. Excuse me, he was 14 years old. His request, obviously his bite, huge class 2 treatment, a huge class 2 treatment. Please focus in his did bite. Okay? When you are dealing, please, this is my way of thinking, obviously, but in my way of thinking, when you are dealing with a deep bite, plus a class 2 relationship, most of the time, the problem is on the mandible instead the maxilla. So the treatment is not attached at the infrazygomatic crest. The treatment is not isn't taught to intrude the upper incisor, because the problem, the issue is at the bottom. Conclusion, if the issue is at the bottom, we must treat the patient at the bottom, not at the upper maxilla. Obviously, avoid upper extraction, please, and avoid touch, in this case, at the upper. 2 minutes left. An overjet of about 12 millimeters. Maybe someone of you is thinking about surgery. Yes, why not? Would be a beautiful surgical case, but in my country, most of the class 2 patients reject surgery as a treatment option. A super overjet, look at his mandibular retrognatism, 1 minute left. 12 millimeter, acute class 2 case. I used to take CBCT, stomos at the beginning of the treatment. Options. Surgery, upper extraction plus intrusion, that's distalization, that's at the infrazygomatic crest. No, the problem is at the bottom. So, what is the treatment? The treatment is something that I love, mandibular propulsion with this appliance, an appliance that I love, which is called advancing. It's like a mini herbs. Let me show you the case. At the beginning of the treatment, the deep bind is gone, because the patient needed a mandibular propulsion instead intrusion. That's the solution. Look at just with the propulsion. Obviously, I bond the braces at the first appointment as well, obviously. And it's just to change, to continue with the wire sequencing until get, my friends, an anterior cross bite and wait about 2 months waiting for the change at the TMJ, the change in his condyle, the change in his temporomandibulary joint. I have did a lot of research about this topic, but we don't have time to show this research. 19 months later, beautiful smile. Look at his profile at the beginning, at the end of the treatment. At the beginning, at the end of the treatment. Look at the inclination at the upper and lower incisor. At the beginning, at the end of the treatment. It was a beauty. What about the measurement? From 8.5 in his A and B to 2.5, like a whatever surgical case. His final tomos showing a change in his TMJ, initial photos, and final photo. Somebody told me this case is going to relapse. Let me show you. Yes, could be. He's going to relapse. 11 years follow up. No relapse at all. Because most of the time, class 2 treatment are stable treatment with this kind of devices, with this kind of treatment. Look at his smile, excuse me. Look at his smile. 11 years of follow up. And what about his profile? What about his profile?
Dr. Andres, the time is up.
Okay, yeah. Initial, final, 11 years of follow up. Class 1, class 1, class 1, class 1. And his measurement, about his TMG is perfect. And the final photo, 11 years of after the final of his orthodontic treatment. When I was young, I became Beatles fan. I don't know if you know the Beatles, the most famous band, rock band, the British group. And I remember very well when the Beatles came to India. I saw about 30 years ago, a little bit more, a documental with the travel of the Beatles to India. And I fell in love with India, with the Beatles' influential musical, his beautiful musical. I don't know, no, doesn't work the audio. The Beatles and Indian music. This is the Beatles. Because of that, I was on my bucket list, visit India. The thing that I never thought that it would be as a lecturer. Because of that, I'm very grateful with you, with the Indian Orthodontic Society, with Orco, for having me, for joining me. Thank you so much. Just 2 minutes. Okay.
Thank you, Dr. Andres, for this wonderful, enthusiastic presentation. I request our chairpersons, Dr. Silju Matthew and Dr. Sanjay Kumar, to please felicitate our speaker. On behalf of 56th IOC Scientific Committee, I would now like to felicitate our chairpersons for the day.
Yeah, thank you. That was possible. Really? You like it?
Hello.
Hello. Hello. Hello. Hello. Hello. Hello. इको थोड़ा कम थोड़ा हेलो हेलो उधरला थोडा सहर्ष हेलो हेलो म्यूट केला ना
Hello, hello. हेलो 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 ठीक है हेलो 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 हेलो
Hello, check.
Anchor.
कोण आहे फक्त मला एकदा दाखवून दे.
ऐक ना.
Good evening, everybody. May I have your attention, please? I would just be calling out a few names, the award winners. I would request you all to meet Dr. Nyana Shamagumam on the right side of the auditorium here because your seating is in order. So we would like you all to just come to this side and meet him so that we can make you sit on your respective seats. Dr. Shivaratna Savadi, Miss Sandhya Sheshadri, Dr. Ashima Valithan.
The name of the award.
Okay. Dr. Mohammad Irfanullah Khan, Dr. Parmeshwaran TM, Dr. Vipul Sharma, Dr. Ashish Kamboj, Dr. Mona Prabhakar, Dr. Rosaline Tina Paul, Dr. Priyanka Kapoor, Dr. Pallavi Kusum, Dr. Mangesh Kakodkar, Dr. Neha Bhutani, Dr. Nivedika, Dr. Aarti Setia, Dr. Roshan Manjunath, Dr. Pradeep Kandiktala, Dr. Ramaya Mary Varghese, Dr. Samiksha Chopra, and Dr. Rajkumar Maurya. Thank you so much.
This is after that Vijay Mala Param.
You are on the phone or something. ठीक है. Yes, sir. Anand.
Hello. We wait for Deshmukh sir's cue. See, after I finish this, you start. Deshmukh Sharanam.
No, I'll start. Okay. A very good evening to everyone. I am Dr. Anand Sabne, Associate Professor, Department of Orthodontics, Bharati Vidyapeeth, deemed to be University Dental College and Hospital, Pune.
And I'm Dr. Shilpa Geminis, Professor, Department of Orthodontics, Sihoga Dental College and Hospital, Pune.
It gives us immense pleasure to welcome you all to this wonderful August gathering. The Indian Orthodontic Society is organizing its 56th National Conference in this beautiful city of Pune, a city with a rich cultural and educational heritage. We are meeting physically after a hiatus of 2 years because of the COVID pandemic, and that explains the phenomenal response this conference has received.
To begin today's formal inauguration of the 56th Indian Orthodontic Conference, we invite the Chief Executive Officer of the Indian Orthodontic Society, Honorary Secretary of the Indian Orthodontic Society, Professor Dr. Sridevi Padmanabhan, to adorn the jewels of the office on the Honorable President of the Indian Orthodontic Society, Professor Dr. Sri Krishna Chalasani. To begin this program on an auspicious note, we would like to invoke the blessings of Lord Ganesha by presenting in front of you a rendering of the Ganesh Vandana. I would request Dr. Rachna Mane to come up on the stage to recite the Ganesh Vandana.
गणपति
now request the dignitaries on the dais to kindly step forward for lighting the lamp of knowledge and seek blessings from our beloved founder chancellor, Honorable late Dr. Padang Raoji Kadam.
We now request the chairman of the organizing committee, Professor Dr. Shailesh Deshmukh, to address the gathering.
Good evening. I'd like to commence my speech today by quoting William Shakespeare. 100,000 welcomes, I could weep and I could laugh. I am light and heavy. Welcome. Respected dignitaries on the dais, Professor Dr. Sri Krishna Chalsani, President, Indian Orthodontic Society, our chief guest for today, Honorable Sri Prakash Javadekar, ex-Minister of Information and Broadcasting, Member of Parliament, former Minister of Information and Broadcasting, former Minister of Environment, former Minister of Education, guest of honors, Dr. Vishwajit Kadam, Pro Vice Chancellor, Bharati Vidyapit, deemed to be University and Secretary, Bharati Vidyapit, guest of honor, Dr. Asmita Jagtap, Executive Director, Bharati Vidyapit Medical Foundation, Pune, Navi Mumbai and Sangli, guest of honor, Professor Dr. Satish Kumar Reddy, Vice President, Dental Council of India, and President, Andhra Pradesh State Dental Council. Guest of honor, Professor Dr. Nikhilesh Ved, President, World Federation of Orthodontists, and Vice Dean, European University College, UAE, and our own very alumni. Dr. Sarabjit Singh, Vice President, Indian Orthodontic Society, Dr. Balwinder Thakkar, President-elect, Indian Orthodontic Society, Professor Dr. Sri Devi, Honorary Secretary, Indian Orthodontic Society, Professor Dr. Gauri Vichare and Professor Dr. Ajit Kalia, scientific conveners of this conference, Professor Dr. Jayesh Rahakar, organizing secretary of this conference. Dignitaries of the dais, Honorable Dr. Manikrao Salunke, Vice Chancellor, Bharati Vidyapit, deemed to be University, Dr. K.D. Jadhav, Joint Secretary, Bharati Vidyapit, Dr. Vasantrao Mehetre, Joint Secretary, Bharati Vidyapit, Dr. Mahadev Sagre, Joint Secretary, Bharati Vidyapit, Dr. S.F. Patil, Executive Director, International Affairs, Research and Training, Shri B.B. Kad, Chairman, Bharati Sahakari Bank Finance Director, Dr. Sanjay Lalwani, Medical Director, Bharati Hospital, Dr. Arundhati Tai Pawar, Business Development and Operations, Bharati Vidyapit Medical Foundation, Dr. Mandar Karmerkar, Dean and Principal, Bharati Vidyapit, deemed to be University Medical College, Dr. Shailesh Lele, Consultant, Academic Development and Quality Assurance, Dr. Rajesh Shirsagar, Dean and Principal, Bharati Vidyapit, deemed to be University Dental College. Dr. Vidula Sohni, Principal, Bharati Vidyapit, deemed to be University Engineering College. Mrs. Aishwarya Hardikar, Finance Officer, Bharati Vidyapit. And our special guest for today, Dr. Ashok Dhoble, Honorary Secretary, General Indian Dental Association. Dr. Nitin Barve, Past President, Indian Dental Association, Maharashtra State Branch. And the senior most orthodontist in Pune, gives me immense pleasure to welcome Dr. Sudhir Joshi, Dr. Rupa Abdullah, Dr. Colin Rosardo, and Dr. Prem Nanda. All the international faculty and delegates from Japan, Colombia, Korea, Nepal, and Sri Lanka, my mentors, teachers, and my orthodontic brethren, colleagues, and friends. It is my honor and privilege today to stand before this esteemed gathering to welcome all of you to this 56th Indian Orthodontic Conference at the grand premises of our Bharati Vidyapit Education Complex. I thank the Indian Orthodontic Society for allowing us to conduct this conference. As you are aware, I have been president of this August Society, and I'm aware of the significance of this annual national conference of the premier branch of dentistry, that is orthodontics. I've been teaching at Bharati Vidyapit Dental College, Pune for the past 28 years. This institute has given me everything, and it was my dream to give something back in a small measure to this beloved institute of mine. The retirement age for any teacher in this institute is 60, and I'm just 2 years shy of that. So this conference can be regarded as my farewell gesture to this wonderful institute and establishment. The past few months have been quite tumultuous for the organizing committee, but with the excellent efforts of my team and the wholehearted support of the management of Bharati Vidyapit deemed to be university, Bharati Vidyapit Medical Foundation, and Bharati Vidyapit, we have been successful in putting together a blend of excellent scientific deliberations, trade exhibition, and around 100 orthodontic and non-orthodontic exhibitors. Warm Puneri hospitality, and last but not the least, a fellowship of around 2,000 delegates after a hiatus of 2 sad-filled COVID years. The organizing team has worked extremely hard to make this conference a landmark event, and I'm sure your every need will be looked into by my team. If you find anything amiss, please let me and my team know immediately, and we will try our level best to solve your issue. Unfortunately, the rain gods have not been kind to us, especially today morning, and there was some sort of quite a bit of chaos. So my apologies to all my orthodontic brethren. But that was not in our hands. We have tried our level best. I would like to thank Honorable Sri Prakash Ji Zavadekar for consenting to be our chief guest. We are truly indebted to him. I would also like to thank the iOS head office for their guidance and support. A warm embrace of gratitude for Dr. Karmarkar and Dr. Shirsagar and their respective staff, their auxiliary staff, and the daily wage workers. Without their support, we would not have been able to organize this excellent conference. Sri Jayakumar sir, who is unfortunately not present here, has always been a person whom I can turn to for the relief and comfort he provides. Dr. Arundhati Tai Pawar has been our backbone. I bow my head to all our trade exhibitors. They are the financial pillars of this conference, and I truly appreciate their participation despite their financial woes due to the COVID pandemic. A special thank you to the workhorses of our orthodontic department, Dr. Veera Bhosle, my head of department, Doctors Gauri Vichare, Madhura Kard, Vinit Swami, Anand Sabne, Siddharth Shinde, Harshal Patil, and Sukumar Lipare, and all our postgraduate students and interns. A special mention must be made of the immense help provided by Mr. Anil Kadam and Mr. Suryavanshi. There are many of my committee members to thank. All have worked tirelessly. Professor Dr. Rahalkar will do those honors. I'm extremely proud of my team. Just words are not enough to express my gratitude to them. Please enjoy this conference, our hospitality and food, the banquet and the general bonhomie. Please enjoy the Chhatrapati Shivaji Maharaj show at the end of this inaugural function. I am also sure that your palates will be titillated every day by the delectable cuisine that we have to offer. We shall deliver we desire to extend a gracious and inclusive welcome to all of you. Let's celebrate what brings us together. The iOS conference is back. Jai Bharati Vidyapeeth, Jai iOS, Jai Maharashtra, Jai Hind. Thank you.
We now request the President of the Indian Orthodontic Society, Dr. Shri Krishna Chalasani, to deliver the presidential address. Sorry. We would now like to invite our chief guest, Honorable Shri Prakash Ji Javadekar, former Union Minister of Environment, Education, Information and Broadcasting, and Honorable Member of Parliament, to deliver his inaugural address.
Dr. Chelasni, Dr. Satish Reddy, Dr. Balwandi Singh Thakkar, Sarabjit Singh Ji, all Shailesh Deshmukh, the organizer, all the office bearers of the Orthodontic Association. I am very happy to be here for inauguration of your 56th convention. This is very important. Professional bodies and professionals need to come together, interact. टेक्नोलॉजी और ज्ञान इतना बदल रहा है गति से कि अगर हम उसको सीखेंगे नहीं, करेंगे नहीं, तो फिर हम पीछे छूट जाएंगे. और इसलिए मुझे डॉक्टर चेलासनी, आई मस्ट कॉन्ग्रेचुलेट यू फॉर वन थिंग, दैट 2 days you had workshops and all international experts in that field also had come and have given hands-on training. That is what is required. You must upskill. हर एक को स्किल भी होना है, अपस्किल भी होना है, रीस्किल भी होना है, और हर साल नया सीखना है. हम तो रोज नया सीखते हैं और सबको सीखना है. आप भी सीखते हो. हर पेशेंट को ट्रीट करना एक नई सीख ही होती है. दूसरा क्या होता है? तो it's very good occasion that more than 1,500, 2,000, nearly 2,000 doctors from all over India and some neighboring countries have come. I'm very happy to welcome you all in our city of Pune. And I must also let you know that the technology, particularly in medical sciences, all medical sciences, has changed so fast in last 50, 60, 70 years. लोगों को कभी कभी लगता है भारत की समझो जनसंख्या बढ़ गई. 30 करोड़ थी, हम स्कूल में थे तब, अब 130 करोड़ से ज्यादा हो गई. तो ऐसा नहीं कि आजादी मिलने के खुशी में लोगों को ज्यादा बच्चे होने लगे. हुआ ये कि मेडिकल साइंस के प्रोग्रेस से डेथ रेट कम हुआ, बर्थ रेट भी कम हुआ, लेकिन रिप्लेसमेंट रेशो को अभी पहुंचे हैं, तो इसलिए ग्रोथ हो रही थी. सो दैट इज हाउ. पहले दांत का क्या था? केवल दांत बहुत दुखने पर गिरता था या वो निकालते थे, बस इतना ही एक था. बाद में डेंचर आया, फिर बाद में रूट कैनाल आया, यू स्टार्टेड सेविंग टू. उसके बाद फिर ये ऑर्थोडेंटिक आया. उसके बाद अब नए तरीके से दांत नया इम्प्लांट करते हैं. उसके बाद ओरल सर्जरी आई. और आपका तो बहुत कलाकारी का काम है कि दांत टेढ़े मेढ़े है तो उसका बहुत परिणाम शरीर पर होता है. तो उसके लिए उसको ठीक करें. उससे एक लाभ होता है, दिखते भी अच्छे हो, लेकिन दिखना ये मुद्दा नहीं है. इट इज नॉट इंफीरियरिटी कॉम्प्लेक्स. इफ यू आर हम ज्यादा फेयर नहीं है तो हमें लज्जा होने का कोई जरूरत ही नहीं है. और इसलिए, लेकिन शरीर को जो हम खाते हैं, डाइजेशन, चूइंग, ग्राइंडिंग, ये सब कब होगा? जब आपके दांत अच्छे होंगे। और दांत जब अच्छे होते हैं तो ये करने का काम आप लोग करते हैं, तो आपको सबको मैं बहुत बधाई देता हूं, क्योंकि लोगों के दांत आप उपयोग में ला रहे हो, काम में ला रहे हो, ये नई बात है। और मैं डॉक्टर राहड़कर जी से बात कर रहा था, तो इसका हंसी पर भी परिणाम है, इसका नींद पर भी परिणाम होता है, और इसका स्नोरिंग पर भी परिणाम होता है। ये मुझे पता चला, बहुत ही अच्छा लगा, क्योंकि आधे घर के तो प्रॉब्लम सॉल्व हो जाएंगे उनके दांत अगर ठीक करेंगे तो ये होता है। और गम्स, जॉज, उसके जॉइंट्स, ये सब ठीक रहना, ये ओरल डेंटल केयर, दिस इज द एडवांस टेक्नोलॉजी। और वो आप सब प्रैक्टिस करते हो, आप सीखते हो, क्योंकि आपने जब डेंटिस्ट्री की तब जो आपने सीखा वो आप प्रैक्टिस नहीं कर रहे हो। आप जो प्रैक्टिस कर रहे हो, यूर एक्वायर्ड नॉलेज एवरी नाउ एंड देन। और उसमें ऐसे वर्कशॉप्स, ऐसे सेमिनार्स, ऐसे कन्वेंशंस बहुत उपयोगी रहते हैं, क्योंकि हम लोगों के अनुभव सुनते हैं, उससे बहुत महत्वपूर्ण मिलता है। अब अलाइनर्स और ब्रेसेस, ये इसके इतने रूप आ गए और इतने अच्छे। मेरी अभी पोती है, ग्रैंड डॉटर, उसको भी करना है, तो वो, अब मेरा बेटा ही डेंटिस्ट है तो वही करेगा। हाँ, यानी मैं डेंटिस्ट नहीं हूँ, मैं डेंटिस्ट नहीं हूँ, लेकिन डेंटिस्ट का बाप हूँ। मैं देख रहा हूं दुनिया में डेंटल ट्रीटमेंट इतनी महंगी हो रही है, तो जब एनआरआईज वापस आते हैं छुट्टी में, तो 2 महीने की छुट्टी है, तब हमारे यहाँ हाउसफुल रहता है, क्योंकि यहाँ आने जाने का खर्चा, बाकी सब खर्चा ट्रिप का होकर भी वहां के डेंटल कॉस्ट से कम कॉस्ट में होता है। लेकिन देर आर स्टिल इश्यूज ऑफ इंश्योरेंस नॉट बीइंग कवरिंग द करेक्ट थिंग। और मुझे पता चला कि सीजीएचएस में, हमारे इसमें भी डेंटल के रेट इतने कम है कि एक दांत निकलने को 15 रुपए देते उसमें। तो ये जो समस्याएं है, इसीलिए एसोसिएशन चाहिए कि जो अपने पक्ष को ढंग से रखे, क्योंकि दिस इज ओवरऑल रिलेटेड टू पब्लिक हेल्थ। देश का अच्छा हो, और मैं तो हमेशा देखता हूं, मैं इतना विदेश में घुमा हूं, 70-80 देशों से ज्यादा घुमा हूं, लेकिन कहीं भी कुल्ला नहीं करते। हम माउथ हर खाने के बाद, चबाने के बाद धोते हैं, वो नहीं करते ऐसा। तो वो कैसा होता होगा उनका मुझे पता नहीं, डेंटिस्ट ही बता पाएंगे, आप बता पाएंगे। लेकिन वी हैव बेस्ट हेल्दी प्रैक्टिस, वी मस्ट इम्प्रूव इट, बट वी मस्ट मेक अवेयर। और डॉक्टर चेल्सनी मुझे अभी दिखा रहे थे कि ऑर्थोडेंटिक्स के बारे में भी एक नया अवेयरनेस तैयार करना कि ये भी होता है, और ये आपके खर्चा जितना होता है उससे ज्यादा आपके सेहत को फायदा देता है। यही तो कन्विंस करना है ना। कोई भी सर्विस या प्रोडक्ट आपको अगर लोगों को लेने के लिए कहना है, तो उनको यही बताना पड़ेगा कि दिस इज रियली, इट विल बेनिफिट यू मोर देन व्हाट यू इनकर एक्सपेंडिचर। तो ये एक है। मुझे 2 मुद्दे में आज रखने वाला हूं जो अलग है। मुझे डॉक्टर ने जब लिख के थोड़ा सा एक नोट मैंने कहा कि क्या है, जरा मुझे बताइए आज के आपके प्रॉब्लम्स क्या है, तो उन्होंने शुरुआत की थी एरिस्टोटल और हिपोक्रेटिस से, कि दे सेड दैट स्ट्रेंथनिंग ऑफ टीथ इज वेरी इंपॉर्टेंट। कब? 300 BC, तो 2500 साल पहले कहा। अब मैं आपको एक, और ये किताब साइंटिफिक किताब है, द हिस्टोरिकल इवोल्यूशन ऑफ मेडिकल ट्रेडिशन इन एंशंट इंडिया, और उसमें research, the tradition of surgery in Ayurveda has a long history. Researchers in University of Missouri and Columbia, यानी अपने को क्या है, अगर मैं कहूंगा कि यह हमें हमारा ज्ञान है तो लोग विश्वास नहीं करते, लेकिन सर्टिफाइड बाय मिसोरी और कोलंबिया यूनिवर्सिटी, क्या कहते हैं वो, they discovered that physician in ancient India had developed technology to drill teeth and remove decay 8 to 9,000 years ago. यह हमें समझना चाहिए. अगर हमें पता ही नहीं है, क्योंकि हमें गलत सिखाया गया, और प्रधानमंत्री ने 15 अगस्त को जो कहा कि हमें वैचारिक गुलामी से मुक्त होना है, उसका मतलब है हम सच्चाई को समझे और उसको बोले. मैंने अरिस्टोटल और हिपोक्रेटिस का महत्व कम नहीं मैं करता, क्योंकि ये जो 7-8 हजार साल पहले हमारे यहाँ समझो विज्ञान था, तो वो बीच में लुप्त हो गया, यही तो प्रॉब्लम है ना. तो वो करेक्ट है, लेकिन ये था, ये भी हमें मालूम होना चाहिए. हमें भारत की ही जानकारी नहीं होती है. एक मुझे और इंटरेस्टिंग इसमें मिला, वो तो पुणे का है. द इंडियन रिनोप्लास्टी, नाक को करते क्या, रिनोप्लास्टी बोलते ना, हाँ राइनोप्लास्टी. तो द इंडियन राइनोप्लास्टी टेक्निक वाज डिस्कवर्ड बाय वेस्टर्न medicine in the 18th century. When the East India Company surgeons Thomas Crusoe and James Findlay witnessed Indian rhinoplasty procedures at the British residency in Pune. तो ये है, जब वो दिखाने के लिए आए थे तो यहाँ कर ही रहे थे. हमें पता नहीं है, हमने बीच में खोया, जो हमारा गलती है समाज करके देश करके भी. लेकिन we should be proud of our legacy and we must take it forward. और दुनिया में होता है, आर्यभट्ट का और बाकी सब, सुश्रुत का और बाकी लोगों का विदेशी यूनिवर्सिटी में स्टडी होता है. बीच बीच में हमें भी पढ़ना चाहिए. लेकिन मेरा मुख्य थीम है आज का कि ये डेंटल काउंसिल के लिए है कि आपके स्टडी में मुझे नहीं लगता रिसर्च एंड डेवलपमेंट का बहुत ज्यादा कोई है समावेश. दुनिया रिसर्च और डेवलपमेंट से चलती है. मैं तो, लेकिन देखो आपके मिनरल ट्राइऑक्साइड, ग्लास इनोमर सीमेंट, composite tooth materials, infused bone grafts, EPTF membranes, titanium dental implants, self-igniting brackets and coated brackets, periodontal dressing materials, core build-up materials, lining and luting cements. ये सब विदेश से आ रहा है ना, ये सब विदेश में आ रहा है ना. दिस इज माय प्रॉब्लम. हम आत्मनिर्भर भारत की बात करेंगे और सब इंपोर्ट करेंगे, इससे थोड़े भारत आत्मनिर्भर होगा. वी मस्ट इनोवेट. वी मस्ट, देयरफॉर फर्स्ट स्टेप इज टू इंक्लूड इमीडिएटली, एंड आई विल फॉलो इट अप विद द डेंटल काउंसिल एंड द गवर्नमेंट, दैट you must have the research and development wing and research and development curriculum. Then only students will be interested to do more. अभी आपका एक प्रदर्शनी भी लगा है जहां ट्रेडर्स सारे आए हैं. वो तो माल बेचने के लिए आए हैं, वो थोड़ा सा आपको डिस्काउंट देंगे, ये करेंगे, लेकिन उसका कोई मतलब नहीं ना. हमें ढूंढना है, हमें नया मटेरियल तैयार करना है. Only those countries prosper who innovate. और आज हम इनोवेट नहीं कर रहे हैं. कुछ जगह हम कॉपी कर रहे हैं, कुछ जगह हम बार्गेन करके थोड़ा सस्ता कर रहे हैं, लेकिन हम इनोवेट नहीं कर रहे. तो मेरी इच्छा है कि आपके ऐसे अधिवेशन में एक सेशन नहीं होगा तो लोगों को बोलने के लिए बुलाओ कि इनोवेशन कैसे होगा या कौन क्या प्रयास कर रहा है इनोवेशन के. कुछ लोगों ने किया है, हमने नेहरू फेलोशिप देते हैं, हम प्रधानमंत्री स्कॉलरशिप दे रहे हैं, इसमें ऐसे इनोवेशन करने वालों को बहुत दे रहे। इंजीनियरिंग में बहुत जोर पकड़ा है, लेकिन मैं देखता हूं कि मेडिकल में और डेंटिस्ट्री में ये नहीं होता है, और इसलिए शोध करो, उसके लिए चर्चा करो। और ये अगर अधिवेशन में, इस अधिवेशन से आप ज्यादा शुरू करेंगे, हम सब मिलके फॉलो करेंगे। और क्योंकि अभी मुझे एक प्रॉब्लम बताया कि ये भाई अलाइनर्स और ब्रेसेस है, ये अभी 3D प्रिंटिंग से ही लोग मैप करते हैं, ऑनलाइन से मैप करके वो तैयार करके आपको भेजेंगे, और भेजेंगे, आपको लगाना है, बाकी कुछ करना ही नहीं है। तो मुझे डॉक्टर क्या बता रहे थे कि बोले ये ऑर्थोडेंटिक्स को बाईपास कर रहे हैं। मैंने कहा ये कोई कंप्लेंट थोड़ी है, वी आर थिंकिंग ऑफ कस्टमर, ही हैज अ चॉइस टू टेक बेस्ट एंड चीप। So what we need to say is you have to prepare a case for the government कि ये ऐसा मशीन से होता है, लेकिन मशीन से होने से अगर सुपरविजन, मेडिकल सुपरविजन में डेंटिस्ट ने न देखते हुए और डायरेक्शन न देते हुए किया, तो उसका तकलीफ पेशेंट को होता है। ये यू हैव टू प्रूव दिस। अदरवाइज पेजर था, मोबाइल आया तो पेजर खत्म हुआ, तो उसको क्या करोगे? उसको क्या करोगे? ये तो दुनिया का नियम है। तो इसलिए आपको प्रभावी लॉबिंग भी करना चाहिए, उसके लिए ढंग से डॉक्यूमेंटेशन करना चाहिए, अवेयरनेस भी बढ़ाना चाहिए। और मेरा आग्रह है, पहले तो रिसर्च डेवलपमेंट का हिस्सा पोर्शन में आना चाहिए, सिलेबस में आना चाहिए, और सब आप इतने प्रैक्टिशनर्स हो, यू कैन रियली थिंक ऑफ न्यू इनोवेटिव सॉल्यूशंस। और ये न्यू इनोवेटिव सॉल्यूशंस के दिशा में एक इंजीनियर आपका मित्र ले लो, करो शुरू, और कुछ न कुछ इनोवेट करो। नेक्स्ट टाइम जब आप अधिवेशन करोगे तो कुछ न कुछ नया इनोवेशन का भी एक स्टॉल लगाओगे, और वहां इंडियन इनोवेशन हम देखेंगे। इतनी शुभकामना देता हूं। बहुत बहुत धन्यवाद।
Thank you, sir. We now request the President of the Indian Orthodontic Society, Dr. Shri Krishna Chalasani, to deliver the presidential address.
Greetings to one and all. Shubh Prabhata, you call, or Shubh Sandhya, whatever it is. We are in front of you, dignitaries on the dais, dignitaries off the dais, and my dear lovely fraternity colleagues and postgraduates, seniors, everybody, foreign delegates. Here I'm here to welcome you all to our 56th IOC, Pune 16th to 18th. We are very happy to see the gathering, big gathering here. After 3 years gap, that is COVID has restricted, has put us into houses. The virtual conference is nowhere comparable to the physical conference, I feel, because our Indian hospitality, seeing each other, greeting each other, smiling at each other, recognizing each other, nothing compared to this, I feel. Coming to dignitaries on the dais, I welcome Shri Prakash ji. He doesn't need any introduction. He is a part of our family, I would like to say, because he has a family member as a dentist, Dr. Ashutosh. And few things I want to mention about it. Karma Yatra, Seva or Sangathan, Pravakta, Parliamentarian, Union Minister, Global Imprint. These are all I went through, impressed by all these points under his social media. And other dignitaries, Shri Shivaji Rao Kadam Balasaheb ji, Shri Dr. Vishwajit Kadam ji, Dr. Satish Kumar Reddy, Dr. Niklesh Vaid, Dr. Ashmita Jagtap. Ma'am, may I recognize you? Okay. sorry, Dr. Manik Rao Salunke, Dr. Jay Kumar, Dr. Jayati Yadav, Srimati Vimala Kadamji. Thank you for hosting our 56th IOC at your place. And coming to other dignitaries, Dr. Satish Kumar Reddy, sir, my senior well-wisher, not only professionally one of the senior DCI Vice President and State Dental Council. He is one man whom I have been seeing from almost 30 years, who not only irrespective of whatever age is he moves and implements few things. And another man here quietly sitting, hands folded, Dr. Niklesh Vai. He, the WFO president, he has brought some changes, remarkable some changes into our thing, brought awareness, initial awareness all around India. Now, of course, to take us more internationally, he moved to WFO. But he is with us, his heart and soul with us. And our society, it is a society comprised of not just 5,000, nearly 10,000 members, including life members, student life members, everybody. I was, from couple of years, those all say, we have set new goals and we reach them. Normally, I don't use any papers or anything. I'm very open to tell you, but today I don't want to miss anybody. So I'm forced to use few things. One most important to innovative idea is public awareness. This year, from entire India, with Smile Rally, we have covered as much as people. I really appreciate our fraternity colleagues, life members, student members, everybody for owning this. Almost, you won't believe, through social media or directly, we have reached nearly 7 to 8 crore people. These figures given by the social media people. This is not, I am here as your representative, as a president, but the credit doesn't go to any one of us office bearers on the dais. The credit goes to all of you. You owned it. Because of you, the society is gaining recognition. I really thank you from entire EC side, with a bottom of my heart, I thank you. And another thing, Ajadika Amrutotsu. This year, those who have completed, to recognize our seniors, those who have completed or just crossed 75 years, we are going to their houses. This is an ongoing process. We are going to seniors' houses. We have taken this from Modi ji's idea. We are going to our seniors' houses. Whatever little bit we could do, we are felicitating them. We are coming to your doorsteps. We need your blessing, sir. Without you, our society is nowhere today. Thank you, sir, for being with us. And coming to innovations, just now Sri Prakash ji said innovations. We have our innovation committee. Hope the chairman is somewhere here. As we had, yes, the chairman is there. The innovation committee, we had one day full events, the innovations. As Mr. Prakash ji said, next year we will put a stall. We have been working, but we have to show our thing. We will do it and we'll bring it. That time we will request government's help more into PS, into public. Right. And our iOS workers, I won't call it workers. I mean, say, I myself am a worker. So we all took it as on our shoulders, iOS, and we brought. And another thing, iOS, our members. This is a new thing. This year we started, like every life member, including me, we were allotted 100 to 125 life members to each executive member. Like including myself, we were supposed to call 150 members and find out how are you. We are there for you. Society activities. This is also an ongoing process. I think some of you must have received the calls. We will be getting, not election. This is we are talking about iOS, our members. It's the innovative thing. And I recognize all my fellow EC members here who are here, because individually recognizing all 35 people will be very little tedious. And I request those small videos to be played here. Our most efforts where members have put. Very small video. See, here you can see honors its seniors and legends. Dr. Ved Prakash ji, then Sudhir Joshi ji. You can see all the names. Jayade sir, Shamla ma'am, Madan ji, Kamra sir, Surendra Shetty, sir. He is here in front of us. P.V. Rao, sir. P.P. Jacob, sir. Some of them, some of you youngsters must have seen in books only or legend. Very nice. MKP, sir. He is here. Yes, Narayana, sir. Rangachari, sir. Madam. George Jacob, sir. Baker, sir. K.K. Mistry, sir. Ahuja, sir. P.P. Rao, sir. Sudhindra, sir. Mohan, sir. Still it is ongoing. We will be reaching to your doorstep, sir, all seniors. And another one is Smile Rally, where entire India, you people have done the Smile Rally across all the cities, across all the streets, malls, whatnot, streets, everywhere. This is the Smile Rally, where there's a map. The map shows which are all places we have gone. Not only the map, we have covered into interior places also. Myself, I have traveled to Agartala, Tripura. Myself and Secretary Ma'am, we together. You can see, not only awareness through social service also. Our flag is being carried away all over India, from place to place. There, Tamil Nadu Central Minister, he was participating. And from UP, Deputy CM sir, inaugurated in Tripura, Sri Dr. Manik Saha sir was there with us for almost 3 hours. He himself being a dental surgeon, oral surgeon. What inspiration. As a chief minister, he came, even though chief minister, he was there with us for 3 to 3.5 hours personally. Wagah border. That's on which day exactly, Sudeep? Yes, I know it, but still I'm asking. 15th. You can see the crowd on at Wagah border. Now, before I conclude anything to say, these are the Smile Rally committee. And each and every executive committee member, I thank. And before I say anything, I request my society EC members to stand up to say every time audience give a standing ovation to us. But for a change, since you have done so much, we, POB, would like to say, we are giving you a standing ovation to all the society, life members and student members. Thank you. With this, I end.
We would now like to invite the Honorary Secretary of the Indian Orthodontic Society, Dr. Sridevi Padmanabhan, to announce the Indian Orthodontic Society awards and prize winners. And we request the chief guest, Honorable Prakash Javadekar, to present the awards.
A very good evening to the dignitaries on and off the stage. I know how busy our chief guest is, and he's kindly consented to stay back for a little more time and present some of the awards. But before we do that, sir, I request you to release our annual report, which reflects the work of the executive committee, which reflects the calendar of events of the Indian Orthodontic Society, our numerous study group activities, activities of our members, and the achievements of our members. It is now my pride and privilege to announce the iOS Awards and present them to our chief guest. Every year, the iOS is happy to confer some special awards on its very distinguished members. And this year, the highest award of them all goes to a very senior, revered, and respected teacher and clinician, Professor V. Surendra Shetty. And before we invite Sir to come and receive his award, I request Dr. N.R. Krishnaswamy to read out a small citation for Sir.
I am privileged to be asked to read or present this citation commemorating the outstanding contribution of Professor Surendra Shetty, who is today conferred the highest honor of the Indian Orthodontic Society's Lifetime Achievement Award. We, who have been in this profession for a few years, well know its challenges and attractions. It is indeed a tribute to the indomitable spirit of Professor Shetty that he never ignored any of the obstacles or drawbacks in the early stages of one's career in this discipline. He was a brilliant student and later a scholar, which is testified by the chronicle of his rise to eminence. He became a brilliant teacher with an outstanding ability to marry complex theoretical aspect and clinical skills with surpassing lucidity. Every budding academic should try to emulate this feat if one wants to be successful. It is not a surprise that you combine intellectual and pragmatic excellence should inspire many an aspiring orthodontist in this country. Many professionals would have been content with achieving academic excellence, but you also excelled as an administrator. Professor Shetty, destiny beckoned you to embrace the opportunity to guide institution with vision, fervor, and the knowledge required for the task. And you embraced it with both your hands. Administration, which is anatma to a researcher or a practitioner, drew your best out. You shaped the institution of Manipal University from its nascent stages to emerge as one of the best in the business. Thus, you showed what it is to aspire, not only for oneself as an individual, but also for the collective community of students, researchers, faculty, and administration who constitute an institution. Your leadership qualities and robust spirit in bearing administrative responsibilities with ease and enthusiasm have become benchmark to those who are earnest and want to contribute to the field of dental education and care in this country. Your care for patient, your clinical acumen, your commitment to ethical values in practicing the profession all hold up to the humanist in you. You did not guard your knowledge of the discipline like the proverbial miser, but shared it with the large heart of a Karna, for you well know knowledge is a treasure to be shared and savored. Thus, it is for your multifaceted accomplishments, which are acknowledged today in the form of the Lifetime Achievement Award of the Indian Orthodontic Society. By honoring you, Professor Shetty, the society honors itself, and by choosing me to do the honors, I feel it's my good fortune. May you live long to scale greater pinnacles. Thank you.
This year, the iOS has awarded 4 senior teachers the Dr. A.V. Arun Outstanding Professor Award. The first award goes to Dr. Ritu Dugal, and as we request Madam to come on to the stage, I request Dr. Puneet to read out a citation on her behalf.
Good evening. It's my proud privilege to read the citation for my teacher, who was my dental BDS as well as an MDS teacher. Dr. Ritu Dugal is the chief of the Center for Dental Education and Research, the professor and head Division of Orthodontics and Dentofacial Orthopedics at the prestigious All India Institute of Medical Sciences, New Delhi. She has been a guide and a mentor to numerous postgraduates, research, and PhD scholars. Under her guidance, more than 50 research projects related to basic sciences, clinical sciences have been conducted. Acumen in research and communication skill is par excellence. Being a good human being with compassion for colleagues as well as for students is beyond greatness. More than 100 publications in various national and international journals to her credit, she still remains humble and down to earth. With an academic career spanning over 30 years, she is known among her students to be always there and approachable. Having interest in the field of non-extraction treatment, treatment of children with special needs, and functional jaw orthopedics, she strives to continue to render excellent patient care and the highest quality of research at the esteemed Center for Dental Education and Research at All India Institute of Medical Sciences. Thank you, everyone.
The next award, the Dr. A.B. Arun Outstanding Professor Award, goes to Dr. Sudhir Kapoor. And as I invite Sir, I request Dr. Jitendra Bakchandani to read out a citation on Sir's behalf.
Thank you, Indian Orthodontic Society and the 56th IOC Pune for this great opportunity. Good evening to one and all. It is indeed a very special evening of my life as I read the citation for an esteemed professor who had been my teacher during my days of graduation. This gentleman is a perfect blend of an academician, clinician, administrator, and an ardent golfer. After having finished his graduation and post-graduation in the specialty of orthodontics from King George's Medical University, Lucknow, in 1984, he dedicated 38 years of his life in teaching and nurturing the orthodontic professionals. During his initial year of academic career, he had been a part of prestigious institutions like Maulana Azad Medical College and All India Institute of Medical Sciences, New Delhi. Currently, Sir heads the Department of Orthodontics and Dentofacial Orthopedics at Sardar Patel Postgraduate Institute of Dental and Medical Sciences, Lucknow, and is also an organizing chairman to the next year's 26th IOS PG Convention 2023. His accolades and achievements speaks oodle of his personality. A researcher and a guide to over 100 postgraduate students. It's indeed an honor and pride to announce the very well-deserved Dr. A.V. Arun Best Professor Awards. Ladies and gentlemen, boys and girls, please give it up for Professor Dr. Sudhir Kapoor, sir, ex-member, Dental Council of India, ex-president, UP State Dental Council, and the executive committee member of IOS for past 3 years. Thank you so much, ladies and gentlemen.
Next, it's a pleasure to say that the next award goes to our very own Dr. Gauri Vichare, Scientific Committee Chairman. I request Dr. Ruchika Agarwal to come and read out a citation on Madam's behalf.
Good evening, everyone. I would like to read the citation for Dr. Gauri S. Vichare. Thank you for giving this opportunity to me, ma'am. Dr. Gauri Shekhar Vichare has devoted over 35 years to the field of orthodontics, and for the past 22 years, she's been a dedicated teacher of orthodontics at Bharati Vidyapeeth Dental College, Pune. And many students, including us, have been lucky to have learned under her guidance. She has seen the transformation in orthodontics since the year 1987 when she graduated from the first batch of post-graduation at Government Dental College, Nagpur. And until today, in her clinical practice, she's never given up on learning newer techniques and current practices. She got the certification from Indian Board of Orthodontics in the year 2000. Her zeal for the subject drove her to seek M.Orth from Royal College of Surgeons, Edinburgh in the year 2002. She also served the Office of Indian Board of Orthodontics for 5 years, from the year 2003 to 2008. She was the first lady chairperson of the Indian Board in the year 2008. She further pursued her PhD in orthodontics and completed it in the year 2014. She staunchly believes that one lifetime isn't enough to have enough wisdom in this subject and continues to learn even today. One cannot speak enough of her contributions to the society as a profound clinician and a brilliant teacher. The Indian Orthodontic Society is delighted to have you as a part of it, ma'am, and is fortunate to have such a distinguished personality amongst us. Let's give a big round of applause for ma'am.
The recipient of the next award is another very senior and respected teacher, Dr. Tulika Tripathi. And I call upon Lieutenant Colonel Rajkumar Maurya to read a citation on her behalf.
Good evening to the August gathering. It is indeed a very emotional moment and matter of a great pride to read this citation for my own mentor, the first batch, Dr. A.V. Arun Best Outstanding Professor Awardee, Professor Dr. Tulika Tripathi, Senior Professor and Head of Department of Orthodontics, Maulana Azad Institute of Dental Sciences, New Delhi. Ma'am graduated in 1983 and went on to complete her post-graduation in orthodontics from KGMC Lucknow in 1986 and has a teaching experience of over 36 years. From her initial mentorship days till date, she has carved, nurtured, and built one of the most prestigious department of orthodontics at the highly renowned Maulana Azad Institute of Dental Sciences. Professor Tripathi ma'am is a recipient of more than 18 awards and honors, including WHO Fellowship of Training at the Tokai University of the School of Medicine, Japan in 2001, Famden Acquisition of the Year 2016, the ICMR International Fellowship for the Senior Biomedical Scientist for the Research at the University of the Glasgow 2018, Delhi State Award by Delhi Government 2019, and numerous best and paper and posters to mention. She has the rare distinction of having her oral research paper elected consecutively for the 4 times at the American Association of Orthodontists Annual Conference, held first at the Hawaii, then at the Washington, D.C., also at the Los Angeles, and lately at Florida this year. She and her department also holds a unique record of winning maximum awards in almost all the competitive categories of the scientific session of the 50th IUC 2015, including herself winning the Best Paper, Clinical Innovation category and Best Poster Research category. Ma'am remains a pioneer in India with some of her achievements, such as the first non-defense civilian orthodontist to be conferred with the citation of the GOCNC Western Command 2021. She has published more than 125 national and international publications in a prestigious high-impact factor journals, to name a few: AGODO, JO, PIO, JCO, and many more. She has the rare distinction of being the first Indian orthodontist to publish her original research work in Scientific Report, a journal by Nature, as the lead author. Biomarker in orthodontics, especially in a growth assessment, has perhaps become a synonym to ma'am as her name. Her work since more than a decade in biomarkers dominated the research field and publication all over the world. She has not only guided more than 31 PG students in the last 16 years, including myself, but also a PhD supervisor at the Rajasthan University. Her phenomenal research output has more than 6 extramural research projects funded by prestigious national bodies such as ICMR, DHR, UGC, and CSIR. We, the Indian Orthodontic Society, proud to present to her Dr. A.V. Arun Outstanding Professor Award 2022 for her immense contribution to the Orthodontic Society as an administrator, keen clinician, vivid researcher, excellent teacher and mentor, and above all, an excellent and selfless human being. Congratulations, ma'am. Thank you.
मैं आपकी इजाजत चाहूंगा, लेकिन एक वाक्य बोलना चाहता हूं। जैसे अभी मैडम आई तो मंच के भी 2 लोगों ने और सबने उनको पैर छुआ, तो ये केवल और केवल टीचर को ही मिलता है, दूसरे किसी को ये सम्मान नहीं मिलता। तो जो भी 3 ऑल 6 प्रोफेसर्स आउटस्टैंडिंग, बिकॉज ऐसे ही लोगों से व्यवसाय यानी उससे ज़्यादा एक मिशन के तहत उन्होंने काम किया, तो उनको भी बहुत बहुत बधाई। और आई वुड हैव एंजॉयड बीइंग यू विथ यू, बट नाउ सतीश रेड्डी जी will sit at my house in Delhi, will discuss many issues, so I take your leave. इतना ही कहूँगा कि मुझे भी एक दूसरा कार्यक्रम है। In our country, politician is, or politics is most misunderstood and underrated profession. Thank you.
I would request everyone to please remain seated.
This year, the Dr. K.K. Mistry Scroll of Honor goes to another very senior teacher, Dr. D.N. Kapoor. Since Sir is abroad, Dr. Priyank Rai will receive it on his behalf. And I request the President-elect, Dr. Balvinder Singh Thakkar, to read a citation on Sir's behalf.
A very good evening to one and all. It is indeed a proud privilege to read out a citation for the teacher of teachers, Dr. D.N. Kapoor. He has been an active orthodontic mentor as academician, researcher, and clinician since last 57 years. Dr. Kapoor has served as teaching faculty from 1965 to 2013 in KGMU University, Lucknow, and MJP University, Bareilly. He has been very active in mentoring budding orthodontists at various national and international conferences of AO, IOS by virtues of seminars, workshops, guest lectures, and keynote addresses. He has contributed to more than 115 research papers in national and international journals and mentored more than 135 postgraduate students in the field of orthodontics in the last 5 decades. He has been a member of IOS since 1967 and chairs as president of Indian Orthodontic Society from 1993 to 1995. During his journey of orthodontics is more than 5 decades, he distinguished himself in the field of academics, chaired decorated highest positions such as Senate member of KG Medical University, Lucknow University, member of Task Force Committee, and member of Oral Health Policy of Government of India. He has been a medical advisor technical committee as well as empowerment committee of Government of Uttar Pradesh from 1995 to 2003. Thank you so much.
Before we continue with the rest of the awards, the president of the World Federation of Orthodontics, Dr. Niklesh Vaid, would like to present a token of appreciation to the president-elect and the organizing chairman of the 56th IOC. I request Dr. Niklesh to do the honors.
Can open it.
Last year, the iOS Research Foundation proposed to the annual general body that we increase the number of grants and the quantum of awards. So this year, the iOS Research Foundation had set up a panel of peer reviewers to view numerous grants applications which had come to us. Out of these, there are 4 candidates who were selected, 2 LM members and 2 student members. Each LM member would get a grant of 1 lakh for the research that they had proposed, and each student member would get a grant of rupees 50,000. So I now call upon Dr. LB Peter, who is the first grant recipient, to come and receive his certificate. The second recipient is Dr. A. Venkateshwaran. Two student members, Dr. Ramyaja and Dr. Dilip. I request you to come to the stage one by one and receive your certificates.
Yeah, go.
No, we go on to the rest of the iOS awards. The Dr. J.G. Kannappan Award goes to Dr. Sumud Deshpande. Hmm. Medal? The medal is in that.
Yeah, this is already.
Already. Congratulations. The Dr. P.P. Jacob Award goes to Dr. Shilpa Devdutt Kulkarni. She will receive a medal and she will also receive the group certificates on behalf of the other authors. If the other authors are there, we request them to come on to the stage. Dr. Vasundhara Bhad Madam and Dr. Umal Doshi. The certificate, you can take out all the certificates. You get one certificate and there are other certificates also for madam. Yeah, each one gets a certificate. You can all hold it up and take a picture. Dr. George Jacob Award for the best clinical innovation published in JIOS goes to Dr. Anand Ambekar. Is he here? And the other members of his team, Dr. Smita Warpe, Dr. Sujit Sadake, and Dr. Suresh Kangani. Congratulations. The Indian Orthodontic Society Colgate Palmolive Award for Life Member. We have two awardees this year, Dr. Vaibhav Mishra. The second awardee is Lieutenant Colonel Dr. Shiv Shankar Agarwal. The Indian Orthodontic Society Colgate Palmolive Student Research Award goes to Dr. Siddhi S. Chandak. And Dr. Shruti Hari Krishnan gets the second award. And the last of the iOS awards.
Dr. Mrs. Savita Ramesh Vaid Memorial Award, Madras Orthodontic Study Group. I request Honorary Secretary Dr. Sridevi to deliver this award. Conveners, or whoever has, you can recognize. Jana, please. Vijay, anybody else contributed? Please come. It's a study group. Please, Kavita, please come. It's your entire study group. Rekha, please come.
We now go on to the 55th IOC Awards. Results of the competitive oral presentations. Dr. Shivratna C. Savadi Award for the Best Research Paper goes to Dr. Muhammad Irfullah Khan. Muhammad Irfullah Khan. All of you stand here. It's not nice. Just a few more. Congratulations. Dr. Sandhya Sheshadri Award for second best research paper goes to Dr. Parameshwaran TN. Right. And the third best paper goes to Dr. Vipul Sharma. We will congrats. We will take a small break in the award ceremony at this juncture, and I'll hand it over to the MC.
Yes. For patron, license, and 2 minutes.
Hello, hello. Hello. We would like to welcome our guest of honor, our patron, Dr. Asmita Jagtap Tai Sahib, Executive Director, Bharati Vidyapit Medical Foundation, Health Sciences. Ma'am, we welcome you on the dais, please. I would now request the President of the Indian Orthodontic Society, Dr. Sri Krishna Chalasani, and Dr. Satish Kumar Reddy to felicitate Dr. Asmita Jagtap. I would request Dr. Asmita Tai Jagtap to please say a few words and address the gathering.
Dr. Ashima Valyatan Award for Best Clinical Paper goes to Dr. Ashish Kamboj. Dr. Anil Kumar Mehrotra Award for second best clinical paper goes to Dr. Mona Prabhakar. You're already wearing two medals. And the third place goes to Dr. Rosaline Tina Paul. For the clinical innovation category, Dr. Neeta Bhaktani Award for Best Paper Clinical Innovation goes to Dr. Priyanka Kapoor. Congrats. Congratulations. And Sai Pranav Memorial Award for second best paper goes to Dr. Pallavi Kusum. Please take it, please. No problem. She's shaking it on behalf of. And the third best paper goes to Dr. Mangesh Kakodkar.
I'll tell them. I'll tell them. Next is poster presentation. Your kind attention, please. The next category of winners, poster presentation research category, Mr. Kanyal Chatwani Award for the best poster goes to Dr. Nega Bhutani. The second place goes to Dr. Nivedika. Nivedika, wait. The second place goes to Dr. Nivedika. I request the audience to applaud and encourage the prize winners, please. The third place goes to Dr. Aarti Sethia. And that completes the research category poster presentation. The next category is poster presentation clinical category. Poster presentation clinical category. The first place goes to Dr. Roshan Manjunath. Yeah, you can afford to clap a little more, audience. And the second place goes to Dr. Pradeep Kandi Katla. And I don't want to repeat it again. A big round of applause, please. Dr. Pradeep Kandikatla on stage. The next category is general category poster presentation. There is one and only prize, and that goes to Dr. Ramya Mary Varghese. The last and final category is table clinic. The clinical first prize goes to Dr. Samiksha Chopra. Two more prizes to go. The last but one is Dr. Samiksha Chopra. And the last but not the least, table clinic general. First prize goes to Dr. Rajkumar Maurya. Your Honor.
Token of appreciation to President of Sri Lanka Authority Society.
Sir's name.
Ratna Kumar Disanayak. Ratna Disanayak.
I must say it correctly. Ratna Kumar?
Ratna Kumara Disanayak.
Ratna Kumara Disanayake. Yeah. We have a request from the president of the Sri Lankan Association of Orthodontists, Dr. Ratna Kumar Disanayake. He would like to honor the Indian Orthodontic Society with a small token of appreciation.
We now invite Dr. We now invite Dr. Satish Kumar Reddy, Vice President, Dental Council of India, to inaugurate the scientific session of the 56th Indian Orthodontic Society.
Chief guest of the day, dignitaries on the dais, senior faculty colleagues, my dear colleagues, postgraduate students, press, electronic media. Namaskar to everyone. I really feel honored to share the dais in this IOSC conference, and I'm privileged to inaugurate the scientific session. And coming to the point, I've been sharing a couple of issues with President Chalasani. He has done a wonderful job as President IOC, and being associated with Indian Orthodontic Society, he has been continuously asking me how to resolve the issue of present commercial companies coming into the field of, eating over to the orthodontics with incompetent and incapable work and spoiling the reputation of orthodontists and, the cause of the kind of chaos they are creating. We have worked out a very clear legal mechanism how to restrict them. And I've been sharing with him couple of thoughts. And in this platform, I want to get to your notice. Now, the Indian Orthodontic Society has to give a clear document to Dental Council of India stating that any movement of the tooth or any kind of dental corrections is a specialized field, and an orthodontist is trained intensively for 3 years with all the biomechanical procedures that are involved and with all the details where all the possibility of any damage that can be done if it is improperly handled, and aligners to be brought as a separate chapter into the curriculum of post-graduation, stating, we have to do little more work on to the other aspects of biomechanics of aligners, and it should become a separate entity like our other mechanotherapies. Then only we will be having a stand tomorrow to fight all these commercial entities which are causing a chaos and eating away onto us. Otherwise, there is no option. At my capacity at the Dental Council of India, I will get it immediately amended that it will become a part and parcel of orthodontic program. Then we would be legally rightful to question and stop these guys. Right now, we cannot say anything because it's a commercial product. There is no rule, regulation. There is no regulatory over that. It's like selling a Fair and Lovely. Nobody can talk. See, because Chalasani has been trying to restrict it, because we don't have a clear-cut legal validity or point where we can address in judiciary, we are just stuck up. As a President, State Dental Council of India, and being in touch with other state dental councils of India, we are also working a roadmap how to restrict this. First point, it has to come into the curriculum, wherein iOS has to write to the council saying the implications, what is the important of biomechanics. Of course, aligners is also part and parcel of orthodontics. An incompetent person just going to a home, just taking a scan and say that this can be done on a remote control mechanism. So unless we establish this ground, we will not be in a position to really fight. This is one aspect. And this is the one bothering most of the, orthodontist, wherever any college I visit, most of the HOD is saying, what is this, sir? This is causing problem. So I thought I should make a point on this. And furthermore, senior colleagues are there legally. Pradeep Jaina is there, who is one of the top guy legally who can address the issues. If there is anything, they can come forward how together we can do something good for our society and our, members of the society. With this, I thank you. All the best to everyone.
Thank you so much, sir. We invite the President-elect of the Indian Orthodontic Society, Dr. Balwinder Singh Thakkar, to inaugurate the trade fair now.
Thank you so much. Respected dignitaries on the dais, off the dais, delegates, and my dear friends. We all know trade is the backbone to any conference. So without trade, no conference can be as rich as what this is. So I declare this trade fair open and I welcome you to the city of Pune, welcome you to the 56th IOC. Thank you.
Thank you so much, sir. We now call upon the Vice President of the Indian Orthodontic Society, Dr. Sarabjit Singh, to release a souvenir for the 56th Indian Orthodontic Conference.
We now request the President of the Indian Orthodontic Society, Dr. Sri Krishna Chalasani, to felicitate Dr. Satish Kumar Reddy, Vice President of the Dental Council of India, President Andhra Pradesh State Dental Council.
The conference organizing committee has decided this year to felicitate the senior most orthodontists in Pune for their guidance, dedication, and sincerity towards the orthodontic profession. They have been a beacon of light to all the orthodontists in Pune and across the Indian Orthodontic Society. We invite Dr. Sudhir Joshi to come up on the stage. We invite Dr. Rupa Abdullah ma'am to come up on the stage, and we request the President, Dr. Sri Krishna Chalasani sir, to felicitate her. Thank you, ma'am. We now invite Dr. Colin Luzado to come up on the stage, and we request the Honorary Secretary, Dr. Sridevi Padmanabhan ma'am, to felicitate Dr. Colin Luzado. We now invite Dr. Sudhir Joshi sir to come up on the stage, and we request the President, Dr. Sri Krishna Chalasani sir, to felicitate Dr. Sudhir Joshi. We now invite Dr. Prem Nanda sir to come up on the stage, and we request the Honorary Secretary, Dr. Sridevi Padmanabhan ma'am, to felicitate Dr. Prem Nanda.
We would now like to invite Dr. Ashok Dhoble, sir, Honorary Secretary General, Indian Dental Association. We invite Dr. Nitin Barve, past President, Indian Dental Association, Maharashtra State Branch, to please come up on stage. And we request President Dr. Shri Krishna Chalasani and President-elect, Indian Orthodontic Society, Dr. Balwinder Singh Thakkar, to felicitate Dr. Nitin Barve. We would like to acknowledge the help of the dignitaries that have gone out of their way to render all the possible help in organizing this conference. Dr. Sanjay Lalwani, Medical Director, Bharti Hospital, Pune. Dr. Arundhati Pawar, Director, Business Development and Operations, Bharti Vidyapit Medical Foundation. Dr. Veera Bhosle will collect the award on her behalf. Dr. Mandar Karmarkar, Dean and Principal, Medical College, Bharti Vidyapit, Pune, deemed to be university. Dr. Rajesh Shirsagar, Dean and Principal, Dental College, Pune. Thank you, sir. Dr. Vedula Soni, Principal, Engineering College, Pune. Oh, got it, good. We also acknowledge the presence of the following dignitaries. Dr. Vasant Rao Maitre, Joint Secretary, Bharti Vidyapit, deemed to be university. Dr. Mahadev Sagre, Joint Secretary, Bharti Vidyapit, deemed to be university. Dr. S.F. Patil, Executive Director, International Affairs, Research and Training. Dr. Shailesh Lele, Consultant, Academic Development and Quality Assurance. Dr. B.B. Kurt, Chairman, Bharti Sarkari Bank, Finance Director, Bharti Vidyapit, deemed to be University, Pune. And finally, Mrs. Aishwarya Hardikar, Finance Officer, Bharti Vidyapit.
Ma'am, we're done with the awards. We now invite the organizing secretary of the 56th Indian Orthodontic Conference, Dr. Jayesh Rahalkar, sir, to propose the vote of thanks.
Good evening, everybody. Hello. Good evening, everybody. I'm here basically to give vote of thanks to make this particular event a magnanimous one so that everyone can enjoy, have camaraderie at the same time, as mentioned, enjoy the scientific deliberations also. So I would like to thank Professor Dr. Shri Krishna Chalasani, President of Indian Orthodontic Society, our chief guest today, Honorable Shri Prakash Zavadekar, former Minister of Information and Broadcasting, Member of Parliament, Guest of Honor Dr. Shivaji Rao Kadam sir, Chancellor Bharati Vidyapit deemed to be University, Guest of Honor Dr. Vishwajit Kadam sir, Pro Vice Chancellor Bharati Vidyapit deemed to be University and Secretary Bharati Vidyapit, Guest of Honor Dr. Asmita Tei Jagtap, Executive Director Bharati Vidyapit Medical Foundation Pune, Navi Mumbai Sangli, Guest of Honor Professor Dr. Sadashiv Guest of honor, Professor Dr. Satish Kumar Reddy, sir, Vice President, Dental Council of India and President in Andhra Pradesh State Dental Council. Guest of honor, Professor Dr. Nikhilesh Ved, President, World Federation of Orthodontists and Vice Dean of Academics, European University College, UAE, and also Bharati alumni. Guest of honor, Shri, then Dr. Sarabjit Singh, Vice President, Indian Orthodontic Society, Dr. Balwinder Singh Thakkar, President-elect, Indian Orthodontic Society, Professor Dr. Devi Madam, Honorary Secretary, Indian Orthodontic Society, Srimati Vijay Kadam, Vaini Sahib, Chairman, School Education Committee, Bharati Vidyapeeth deemed to be university, Honorable Dr. Manikrao Salunke, Vice Chancellor, Bharati Vidyapeeth deemed to be university, Honorable Shri G. Jaikumar, Registrar, Bharati Vidyapeeth deemed to be university, Dr. K.D. Zadhav, sir, Joint Secretary, Bharati Vidyapeeth, Dr. Vasantrao Mehtre, Joint Secretary, Bharati Vidyapeeth, Dr. Mahadev Sagre, Joint Secretary, Bharati Vidyapeeth, Dr. S.F. Patil, Executive Director, International Affairs, Research and Training, Dr. B.B. Kurd, sir, Chairman, Bharati Sahakari Bank, Finance Director, Bharati Vidyapeeth deemed to be university, Dr. Sanjay Lalwani, Medical Director, Bharati Hospital, Dr. Arundhati Tai Pawar, Director, Business Development and Operations, Bharati Vidyapeeth Medical Foundation, Dr. Mandar Karmarkar, sir, Dean and Principal of Bharati Vidyapeeth deemed to be University Medical College, Dr. Padwal Madam, Vice Principal, Bharati Vidyapeeth deemed to be University Medical College, Dr. Shailesh Lele, sir, Consultant, Academic Development and Quality Assurance, Dr. Rajesh Shirsagar, sir, who is a very dear friend of mine and my room partner also, Dean and Principal, Bharati Vidyapeeth deemed to be University Dental College, Dr. Vidula Sohni, Principal, Bharati Vidyapeeth deemed to be University Engineering College, Mrs. Aishwarya Hardikar, Finance Officer, Bharati Vidyapeeth. Our special guest today, Deans of other dental colleges in Pune, dear Dr. Gopalakrishnan sir, Dean Dr. D.Y. Patil Dental College, Pimpri, Dr. Samir Patil sir, Dean Simhagar Dental College, Dr. Ramandeep Dugal Madam, Principal M.A. Rangunwala Dental College, and Dr. Shigli sir, Dr. D.Y. Patil Institute of Dental Science, Lohegao. Dr. Nitin Barve sir, past President, Indian Dental Association, Maharashtra State Branch. The senior most orthodontist in Pune, Dr. Sudhir Joshi sir, Dr. Rupa Abdullah Madam, Dr. Colin Luzardo sir, Dr. Prem Nanda sir. All the international faculty, delegates from Japan, Colombia, Korea, Nepal, and Sri Lanka. All the past presidents of iOS, past chairman of IBO, principal office bearers, executive committee members of iOS, members of iOS, friends, colleagues and students. And I would also like to thank the trade partners who had been supporting our trade fair, the hospitality team, and the management of Bharati Vidyapeeth. And I would fail in my duty if I did not thank the following people who have helped us: Mr. Anil Kadam, Mr. K.R. Kadam, Mr. Mandar Zadhav, Mr. Mayur Shah sir, Mandar Bhondre, Mr. Pawan Kumar Mohite sir, Mr. D.R. Patil, Mr. R.M. Suryamaushi, Mr. Salunke, Mr. Paigude, Mr. Vinayak Bhande, Mr. Vishwas, Mr. Suryamaushi, Mr. Sharad Patil, Mr. Amol Yadav, in charges of various sub-units here who has on the campus who have helped us. And I would like to thank the chairman of COC, Dr. Shailesh Deshmukh sir, for giving all the support in organizing this particular event, all the conveners of the committees of conference organizing committee, and I would really fail in my duty if I don't thank the team of conference organizing committee. They have put in a lot of efforts. So thank you very much to all of you. Jai iOS, Jai Maharashtra, Jai Hind. Thank you very much.
Thank you so much, sir. We request everyone in the audience to kindly rise for the national anthem now.
मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात मराठा द्राविड उत्कल बंग विंध्य हिमाचल यमुना गंगा उत्कल जलधि तरंगा तव शुभ नामे जागे तव शुभाशिष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय जय हे
We now request all the dignitaries on the dais to assume their places in the audience. We are glad to we are glad to we are glad to inform you We are glad to inform you that the organizing committee has arranged a small cultural extravaganza for all of us. We request you to please enjoy this performance. It is a tribute to great Chhatrapati Shivaji Maharaj. We now invite Dr. Nilima Kakre to come up on the stage and tell us more about it. We are just getting this. I request all of you to kindly wait back in the auditorium and enjoy the cultural program which is organized. It is only about 10-15 minutes, so I request you all to kindly wait.
Requesting all the guests to please be seated. Please be seated. Friends, please be seated. It's going to be a beautiful dance number. I'm sure you all will enjoy it. Super enthusiastic performance on a tribute to Chhatrapati Shivaji Maharaj, pride of India, pride of Maharashtra. तुम्हीच हेल्प करा ना चेअर मागे ठेवायला तेच पटकन म्हणून. Don't have more people to help you. Yes. Stay there only now. Keep it वहीं पे रखो.
Hello.
शिवाजी
क्या हुआ? Perfect. कॉस्ट्यूम बहुत अच्छा. You need this.
A tribute to Chhatrapati Shivaji Maharaj, the pride of India, the pride of Maharashtra. Born on Feb 19, 1630 at Shivneri, Pune, we are very proud. Died on April 3rd, 1680 at Raigad. Founder of Maratha Kingdom of India. Shivaji Raje is known as the father of Indian Navy. Shivaji was the first to realize the importance of having a naval force, and therefore he strategically established a navy and forts at the coastline to defend the Konkan side of Maharashtra. Shivaji established a royal name for himself in history with his administrative skills by upholding the Swaraj values and the Maratha heritage. He was known for his bravery and tactics, with which he won numerous wars against the Mughals. Presenting a dance number, hope you all enjoy. Jai Maharashtra, Jai Hind, Jai Bhavani, Jai Shivaji.
भवानी के वीरो उठा लो भुजा को।
शाहजी और जीजा माता के वंश के उत्तराधिकारी स्थापित करने एक मराठा होता है 100 पर भारी। रक्षा मातृभूमि की करने आया एक ऐसा सरताज, भारत के धरती पर जन्मे वीर मराठा छत्रपति श्री शिवाजी महाराज। उन्होंने अपनी उंगली काट दी खून की आहुति, ली स्वराज्य पाने की शपथ।
सरर होलिका चले शत्रु राख में मिले हमने, जब जब शमशीरें ताने है माए भवानी। आंधियां उठे शत्रु चढ़ सही मिटे हमने, जब जब शमशीरें तानी है माया भवानी। मर्द मावड़े बड़े खुद्दार है, अब हर एक दिन स्वराज का त्योहार है। अब ये ही नाच दे तेरी साथ हम रखे तेरे।
जो 65 किलो की तलवार चलाता है उसका नाम यशाजी। जो 2000 सैनिकों से अकेला लड़ता है उसका नाम बाजी। जो हाथ कटने पर भी लड़ता रहा उसका नाम तानाजी। जिसने सिर्फ 700 मराठों को लेकर 30,000 मुगलों को भगाया उसका नाम रामजी। और इन सबको एक साथ लेकर स्वराज्य निर्माण करते हैं, उनका नाम छत्रपति श्री शिवाजी। शिवाजी
गणपति गजाश्वपति भूपति प्रजापति सुवर्णरत्न श्रीपति अष्टप्रधान जागृत अष्टप्रधान वेदित न्यायालंकारमंडित शस्त्रास्त्र शास्त्र पारंगत राजनीति धुरंधर प्रौढ़ पुरंदर क्षत्रिय करुणावतौ सिंहासनाधीश्वर महाराज राजा शिव छत्रपति महाराज की नमो पार्वती पते